mode. Thank you so much. We will be starting in a few minutes. A very good morning, ladies and gentlemen, and welcome. I'm Paloma, and it's my privilege to welcome you all to the Indian Hepatitis Summit 2025. We are excited to have esteemed healthcare professionals, researchers, policymakers, and industry leaders gathered here to share knowledge, strategies, and best practices for combating hepatitis. This summit is yet another new beginning to accelerate efforts to eliminate hepatitis through innovative solutions and global partnerships. We are honored to have such distinguished dignitaries with us here today. Without further ado, let me welcome our esteemed guests onto the stage. First, we are honored to have Dr. Vivekanandan Shanmugam, Managing Trustee of the Chennai Liver Foundation. With over 18 years of experience as a liver transplant surgeon, he's been involved in over 750 transplants and is an expert in complex surgeries with a high success rate. Of course, all of you know him, but let's give him a round of applause and welcome him onto the stage. Next, I invite Dr. R.P. Shanmugam, founder of the Chennai Liver Foundation and the organizing chairman of the Indian Hepatitis Summit 2025. He has played a crucial role in advancing liver health care through innovation, raising awareness, and improving accessibility. His 2 decades of dedication have significantly impacted liver transplantation in India. Can we give him a big round of applause as he makes his way to the stage? Joining us next is Ms. Rachel Holford, President of the World Hepatitis Alliance and CEO of the Hepatitis C Trust, bringing over 25 years of experience advocating for high-risk populations, including the homeless, substance users, and migrants. Can we welcome her with a big hand, ladies and gentlemen? Welcome, Rachel. We are also pleased to have Dr. Radhakrishnan Dhiman, Director of the Sanjay Gandhi Postgraduate Institute of Medical Sciences and the Kalyan Singh Super Specialty Cancer Institute. He was instrumental in establishing India's first doctorate in medicine and hepatology and pioneering the nation's first liver ICU and liver transplantation program. Let's give him a big hand. Please welcome Dr. John W. Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. He has an extensive career in public health and is a key figure in shaping global hepatitis and HIV research. Welcome, Doctor. Lastly, we are pleased to welcome Dr. Rodrigo H. Offren, WHO representative to India and the former Regional Emergencies Director for WHO Southeast Asia. Can we give him a big round of applause, ladies and gentlemen? And ladies and gentlemen, we are privileged to have with us Dr. Soumya Swaminathan, Chairperson of the MS Swaminathan Research Foundation and a former Chief Scientist of the World Health Organization. She played a crucial role during the COVID-19 pandemic, leading scientific efforts and establishing COVAX for equitable vaccine distribution to low and middle-income countries. Welcome, Dr. Soumya. Thank you so much to all of our dignitaries. And as we begin this auspicious event, let us please rise for the Tamil Thai Valthu. Thank you so much. You may be seated. As we begin this important summit, I now invite our distinguished dignitaries to please come forward and light the ceremonial lamp, symbolizing the illumination of our path towards the goal of hepatitis elimination. I call upon Dr. R.P. Shanmugam, Ms. Rachel Holford, Professor Radhakrishna Diman, Dr. Ward, Dr. Soumya Swaminathan, and Dr. Rodrigo to join Dr. Vivekanandan Shanmugam to please do the honors. Definitely a powerful visual journey underscoring the significance of our collective mission. Now, ladies and gentlemen, I'd like to call upon Dr. R.P. Shanmugam, founder of the Chennai Liver Foundation and the organizing chairman of IHS 2025, to deliver the welcome address and share his vision for the summit ahead.
Good morning to all of you who are assembled here. It's my proud privilege to welcome you all for this useful and purposeful meeting, which is rarely conducted. Probably this is the first of its kind in our country. And I hope the importance of the meeting will be realized after very good deliberations 2 days later. And I hope the government will take it up very seriously to eliminate the viral hepatitis by 2030. Viral hepatitis, along with the tuberculosis, is the second leading cause of death in the world. And 1 million people have died in 2019, and 1.3 million people died in 2022. It is increasing. Hepatitis B and C have caused 83% of the population in certain areas. And 17% of deaths is caused by hepatitis C. By end of 2022, 13% of 250 million people diagnosed for hepatitis B. Only 13%. That is very tragic event. And less than 3% received the antiviral drugs. This is another tragedy. And hepatitis B, C, 50 million people affected, 36% only diagnosed, and 20% only received the treatment. This is the status of affairs in our globe. So we must take it very seriously that hepatitis B and C is a very major killer. We do not realize this because it is not causing death immediately. It takes 20 to 30 years for the disease to occur and the people to die. And when they are affected, it takes away the exchequer, the financial burden from the government throughout their lifetime. That is for about 20 years, 30 years, they have been suffering, and they get admitted for serious illnesses of the B, cirrhosis liver, and malignancy of the liver, and that is taking away the big burden of our economy. That is, must be realized by the government, the bureaucrats, and they should all come forward to eliminate the WHO aim of eliminating by 2030. And we should all put our heads together, and we should all join together. It's an NGO, or government, or private organizations, all put together to aim to achieve this aim. Thank you very much. Once again, I welcome you all.
Thank you so much, sir. Ladies and gentlemen, now let's take a moment to watch a short video about the Chennai Liver Foundation that has been at the forefront of the fight against liver disease for over 2 decades. With a mission to provide comprehensive care and support, CLF has made significant strides in improving liver health, both in India and globally. Let's take a look.
I started Chennai Liver Foundation way back in 1998. I decided to do something to my patients who are lying with the liver diseases. So if you know that you have got viral infection in the body in the initial stage itself, then you can prevent the liver disease. Chennai Liver Foundation is doing the same thing, going to villages, our state especially. We do test the hepatitis viral infections in the body and do whether you got a fatty liver, whether you got a diabetes, whether you got hypertension, all go together, and which will affect the liver later stage. This is my ambition, that everybody should be checked up completely, and by 2030 we can eradicate the viral infection from the society at least by 90%. That is the WHO aim, and we too take part in this as an NGO.
My name is Srinivasan Swami. I've been associated with Chennai Liver Foundation for more than a decade now. I first met Dr. Vivekananda when my Acharyan, Aragya Singer, had to undergo liver transplant. Both Dr. Shanmugam and Vivekananda have been very passionate about sorting out the problem, and it is the most prevalent disease that, detected early and then solution to be found. But I think the journey has begun in the right earnest manner, and I'm sure Dr. Shanmugam and Dr. Vivekanandan would help many of us discover for ourselves the problem that is inherent. I wish them all success. Thank you.
The Chennai Liver Foundation, we are dedicated to improving lives through liver health awareness, prevention and care. And as a proud board member of the Chennai Liver Foundation, I'm here to support initiatives that bring hope to those affected by liver diseases. Join us in this journey, whether as a volunteer, a donor, or simply by spreading the word. Your support can make a huge difference. Together, let's build a community of health, hope, and healing.
At Chennai Liver Foundation, we believe that liver health is a responsibility that we all need to share, and we believe in equity of healthcare. Our mission is to educate the people and make sure that priority liver care is affordable and accessible to everyone who deserves it. We have patient support groups where the patients are a good advocate by themselves and tell the public as to how they've been cured of liver disease. Research is part of our core, and we do a lot of research these days along with multiple organizations, including the premier organization like the ICMR or the Indian Council for Medical Research. Funding is there for the foundation, and hence we request all of you to support us and join us in this movement of providing a liver disease-free society and making sure that no one dies in India of liver disease in the near future. Thank you.
That was definitely inspiring. We now move to a special moment where we honor our distinguished leaders who are shaping the future of hepatitis care. I request Dr. R.P. Shanmugam and Dr. Vivekanandan to present our guests with a token of our appreciation. I'd like to call upon Dr. Samya Swaminathan. Doctors, if you all could please do the honors and felicitate our guests. Can we have a round of applause, ladies and gentlemen? Miss Rachel Holford, please come forward, ma'am. Dr. John Ward. Professor Radhakrishnan Diman. And Dr. Rodrigo Offrin. We extend our heartfelt gratitude to all of our esteemed guests. Ladies and gentlemen, it's now time to watch a video that encapsulates the mission and vision of the Indian Hepatitis Summit, shedding light on our collective efforts and aspirations in combating hepatitis. Can we have the video, please?
Hepatitis, a silent killer, claiming lives every 30 seconds. 325 million at risk, yet it's preventable. 1.4 million deaths yearly, a preventable tragedy. We all need to come together to fight this. Welcome to the Indian Hepatitis Summit 2025, a global movement to end viral hepatitis. By 2030, hepatitis will be speakers, 10+ sessions, 2 days of impact, 250+ visitors. Join us. Together we can end hepatitis. Securing the world for the future. Indian Hepatitis.
Together, let's accelerate India's commitment to eliminating viral hepatitis before 2030. I now invite Ms. Rachel Holford, President of the World Hepatitis Alliance, to address the gathering and share her valuable insights with us.
Thank you very much. My name is Rachel Halford and I am the President of the World Hepatitis Alliance, and I have to say it is such a privilege and a pleasure to be here with you today. On behalf of the World Hepatitis Alliance, I'm delighted to welcome you all to the very first ever Indian Hepatitis Summit, and thank you to Chennai Liver Foundation and the organising committee for their incredible efforts to make this event a reality. It really is very special. So as we've heard already, viral hepatitis is a global health crisis, contributing to more than 1 million deaths each year from cancer and other liver diseases, and the numbers of deaths are still rising. These deaths are preventable and avoidable. While we have the tools to eliminate hepatitis, we have a vaccine and which is an effective treatment for hepatitis B and a cure for hepatitis C. Very few people living with hepatitis know that they have it, and most won't find out until it's too late. India accounts for 11.6% of the total hepatitis B and hepatitis C infections, with 29,800,000 people living with hepatitis B and 5,500,000 people living with hepatitis C. Globally, we have a short window of opportunity now to turn the tide on hepatitis, but 2030 is not very far away. And within this, India needs work to increase vaccination, testing and treatment for hepatitis, and this will be key to meeting the global 2030 elimination targets. India has recognised the importance of hepatitis elimination, and there is so much passion and commitment in this room today from all of you across the country. I'm looking forward to hearing more and learning more about the excellent work that's happening to increase access to vaccination, testing and treatment for viral hepatitis, and to explore new opportunities to address the challenges. Thank you all so much for joining us today. I hope that across the next 2 days you learn something new and forge meaningful connections so that we can all work together to accelerate hepatitis elimination and reach that 2030 goal. Thank you very much.
Thank you so much, ma'am. We now invite Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health, to share his address.
Thank you very much, distinguished guest, Chennai Liver Foundation, dear colleagues, new and old. It's my privilege and pleasure to join the first Indian Hepatitis Summit here in Chennai. We're already off to a flaming start. And we have a lot to explore together and learn together about hepatitis elimination today and tomorrow. Disease elimination opportunities are rare, and we have that opportunity in front of us for hepatitis B and hepatitis C. What's also rare is for countries to come together and agree unanimously. And that's happened on 2 occasions at the World Health Assembly, where all countries unanimously endorsed goals for hepatitis B and hepatitis C elimination. And now we have an opportunity to act on that universal endorsement. As a coalition for global hepatitis elimination, I have the opportunity to work around the world to bring together the partnerships, strengthen the science base, and contribute to the advocacy that raises awareness to build the capacity needed to achieve goals for hepatitis elimination. And as you'll hear today and tomorrow, there's a number of countries that are making remarkable progress toward those elimination goals. Oftentimes, that progress is due in large part to the vaccines, diagnostics, and medicines made available by industries right here in India. So our charge today and tomorrow is to see how we can devote our full attention now to increase the protection, the detection, and the treatment of hepatitis to a sufficient scale to achieve goals for hepatitis elimination in India. There are a number of feasible ways forward that you'll be learning about today and tomorrow, and I would like to join together to hear about those, to discuss those among people coming toward the problem of hepatitis elimination from different perspectives, and then leave here as a coalition of partners committed in solidarity toward achieving goals for hepatitis elimination in India. I know we can do that, and I stand ready as a global coalition for hepatitis elimination to be part of that coalition to achieve goals for hepatitis elimination in India. Thank you.
Thank you so much, Doctor. Let's now put our hands together for Dr. Radhakrishna Dimam, Director of the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Chandigarh, to share his insights on the advancements in hepatology in India.
Thank you. Respected dignitaries on the dais, my dear colleagues, ladies and gentlemen. We are here to discuss about the issues related to the Hep B and C particularly, and why they are important, why their elimination is very important. I tell you, there are 4 infections in India which are really concerned because of their mortality. They are tuberculosis, malaria, and now we have the viral hepatitis also. The issue is that the deaths caused by the viral hepatitis is exceeding the other infections: malaria, tuberculosis, and HIV, all these 3. That's why there is a program for the elimination that we have to eliminate. And one of the programs that was started for the first time in India is from the Punjab also, because Punjab is one of the provinces that has the maximum prevalence, 3.6. If you consider 30 million population, so about 100,000 patients, 10 lakhs patients, that is 1 million patients need to be treated. If viremic is 70%, then 7 lakhs have to be treated, 700,000 patients have to be treated. So this is the burden in front of us from where we started for treating. And if you look at Hep C, it is in the low prevalence zone, less than 0.5%. But if you look at the population of the India, so the burden goes up like anything. Now we have 5.5 million. Similarly, B is an intermediate zone, and we have 30 millions to treat all those things. So we started from the Punjab model, that was the famous model. Looking at the success, the government of India took over as a national viral hepatitis control program, and it is going on now. Punjab model, we started from the 25 sites. Now the national program is having over 800 sites. We are doing the free diagnostics as well as the free treatment to these patients also. But there are issues actually. One of the major issue that the algorithm that we chosen for the first time in the Punjab, it used to have 7 to 8 visits to the hospital. I think that is not practical. Therefore, we have to go that if we can have the minimum number of the visits, and we can distribute, we can do the diagnose the patient, and distribute the medicine also. I think in this there are some technologies are coming, particularly the rapid test, that oral fluid that we can look for the antibody to the SCV also, and then the reflex SCV RNA testing, and in the same visit or subsequent visit, we can deliver the whole of the medicine for the 3 months or the 12 weeks or for the 8 weeks course. So what I'm trying to say that the program in India is still evolving. I think there are many things that we have to do now so as to cover most of the population actually. Particularly, I am for the universal surveillance also, and finding out the cases and doing the diagnostic and treating all these patients. I think that is the priority for us at the moment in India. And with these words, I'd like to stop over here. Thank you very much for coming to this meeting also. And thank you very much, Vijay and Dr. Saab, for inviting me to this August gathering also. Thank you so much.
Thank you, Professor. We now move on to an exciting milestone in today's program. We are thrilled to introduce a cutting-edge digital tool designed to revolutionize hepatitis care. It promises to enhance the way we manage hepatitis in the digital age. I now invite Dr. Soumya Swaminathan, Chairperson of the MS Swaminathan Research Foundation, to officially launch this groundbreaking digital platform. Doctor, if you would please do the honors. We can do this on my count. If you're ready, 3, 2, 1. Here's to the Hepat.app, an Android-only mobile application used to collect patient data from the field, facility and follow-up at referral centers of patients with liver and cardiometabolic diseases. The app does not require the internet to operate with a dedicated web dashboard, and it is FHR HL7 compliant and ABDM ready. CLF is proud to provide this to the health community as an open source. Now, I request Dr. Soumya Swaminathan to please address the gathering. Can we give her a big round of applause?
Good morning, everyone, and dignitaries on the dais, as well as all the experts gathered here. I'm certainly not an expert on hepatitis, so I'm probably an odd person out. And you're going to hear from many of the experts. And over the next 2 days, I think, really deliberate on what the challenges are, but also the opportunities. We've already heard from some of the speakers this morning about our goals, both the global, the WHO goals, as well as India's own national goals to eliminate hepatitis by 2030. What was striking to me is the mortality figures due to hepatitis, almost identical to tuberculosis. So it's about 1.3 to 1.4 million people globally dying, both of TB and hepatitis, and I'm sure some of them have both. And this, of course, complicates the management of tuberculosis because some of the drugs are hepatotoxic potentially. So the other disease with which, of course, it's often linked is HIV. And having worked for a long time with HIV, I was delighted to see today participating in this meeting several long-time people living with HIV and people who have fought the disease, have overcome, and who are activists and champions for action on HIV. So it's really good that we look at these diseases, the big public health problems, as Dr. Dhiman was saying in India, and really look at how we sort of approach them, perhaps not in a siloed way, but look at synergies and opportunities in our public health system of touch points where we can actually deal not just with one disease, but with the person as a whole, and look at their risk factors and see what else they might be suffering from. For example, it became clear in the 90s itself, soon after HIV was found and that it started increasing, that TB and HIV were very closely linked, that HIV infection, as immunity deteriorated, that TB became more common. And in fact, it was in India and Africa and places like that where this association was really found, because in the US, the end-stage complications of HIV/AIDS were very different. And what the doctors, they were seeing Kaposi sarcoma, they were seeing pneumocystis carinii, pneumonia, and those were some of the fulminant infections, cryptococcal meningitis. But the reports from Asia and Africa were the ones that really showed the close association. But the TB was often the first infection and often the last and final infection of people living with HIV. And the research that was done basically a lot of the groundbreaking research on TB, HIV was done in South Africa and in India, and this actually did influence global strategies for prevention, treatment, diagnosis, and so on. So I think the research done in those early years was very, very important to guide the national program. And I still remember when the topic of screening TB patients for HIV came up, and the kind of resistance there was, because it was felt that TB was a well-functioning public health program, or at least it was a well-established public health program in India that had been running for a long time, and that if we introduced HIV testing, there would be a massive, maybe a stigma and a big backlash, and the whole program might collapse. So the National TB program was very reluctant. So I remember I was at the Tuberculosis Research Center then, and we said, but this is very important, and we must do this. We'll do it in 2 districts to show that it's feasible, or just find out what the acceptability and feasibility of such an approach might be. So I remember we ran this implementation research program very quickly in 1 district in Karnataka and 1 district in Tamil Nadu to show that you could offer people HIV testing when they come for TB, after they are diagnosed with TB, and that there was no problem once they were counseled. There was no issue with people accepting the diagnosis, diagnostic testing. And then, of course, at that time, South India was where HIV was very highly prevalent. So you could actually detect a number of patients, and this was even pre-ART, but obviously once ART was there, these people were, would do much better if they were offered antiretroviral treatment. So I think that doing implementation research at very critical points to answer perhaps some of the challenges that the program might have. Another example is the filariasis program. And we were using a 2-drug regimen at that time. There was some evidence from other countries that a 3rd drug, if you add a 3rd drug to the DEC and ivermectin, I'm blanking on the 3rd drug, but Rodrigo can help. And I was head of the ICMR then. So we said we should try this because we have been doing this yearly rounds of mass chemoprophylaxis, and we are not on target to eliminate lymphatic filariasis. So maybe with the 3-drug regimen, we can reduce the time. We don't have to do that many annual mass treatments. So again, we did this implementation research, and actually we learned so much from that. It was not just about adding a 3rd drug, but what makes the program successful in the field was actually the awareness and the involvement of everyone from the collector down in the program. Because what used to happen is you give these drugs to asymptomatic people in the community. They develop, if they have filarial antigen, they will develop some fever and side effects. And that used to discourage people from taking these medicines, because you're quite all right, you're healthy, you have no symptoms. You're given this drug by somebody, and then you're down with fever, body ache, So then the word would spread in the village saying, don't take those medicines. So the point was, when we got the collector and all the local administrative staff involved, not just the health staff, and we posted a nurse in the village who stayed there, so that people who developed symptoms that evening would actually get paracetamol, because otherwise the health center is closed, so people have nowhere to go. So when people knew that there was someone there who would take care of their side effects, reassure them, give them some symptomatic treatment, then the acceptability of this chemoprophylaxis was much better. And the program, the National Vector-Borne Disease Control Program, very quickly shifted the strategy to a 3-drug regimen. This was many years ago, but the point I'm trying to make here is that we're talking about challenges with the uptake of this program. We are not screening enough people. There's limited awareness, and even amongst healthcare professionals, there may be other roadblocks to the uptake of diagnosis and treatment. And of course, we know that for hepatitis C, it's curable, and it's thanks to the drugs, generic drugs produced in India, that we have been able to bring down the cost of hepatitis C treatment dramatically. And so there is no reason why people should not be offered the treatment. So the key step is the testing, right? So the awareness, the testing, and the linkage with treatment. The government of India is providing it, I think, free. So we need to think about ways, and I think the foundation, the Chennai Liver Foundation, and I must really, we have to appreciate Dr. Shanmugam for having set it up way back, in 1998, with a view to raising awareness and to helping patients with hepatitis. I have known and admired Dr. Shanmugam for a very long time, and it's nice to see Vivek actually taking forward the work that his father started. And of course, today the things are very different in the sense that we do have rapid diagnostic tests, we have treatment. Of course, we have a vaccine for hepatitis B, but not for C. But the experience from COVID tells me that it may be possible with more investment in R&D to also develop a vaccine for hepatitis C. We know the mRNA platform that was, for the first time, proved to be successful during COVID is now being used for a number of other pathogens that are of public health importance. I'm not sure if anyone is working on this, but, and there are probably a lot of scientific challenges. But after COVID, I think we all got the confidence that we can overcome challenges if we work together. And I think during the pandemic, when I was at the WHO, one of the positive things for me during the pandemic, everything was, of course, a lot of pain and suffering around the world. But what was positive was the fact that scientists, academics, doctors, and researchers came together to work on we knew nothing at the beginning of 2020, and about the virus, about how it's going to behave in humans, about how we will develop countermeasures. But within a few months, we had not just diagnostic tests, but vaccines under development. Antiviral therapies, we were not so successful. I would say generally, globally, we are not doing well on antiviral drug development, just like we're not doing very well on new antibiotics. But certainly on the diagnostic side, the technology is advanced so much now. We have so many platforms and so many rapid diagnostic tests available for many, many infectious diseases that, and India is the hub of producing these affordable diagnostics and drugs. So I think that the time is right, and maybe this is a good moment at this convening for all the stakeholders to come together and really come up with maybe a very succinct call to action at the end of the conference, which would highlight where the opportunities lie and where we could really scale up. Because we have, 5 years now less to achieve the goals. And I think if we can do that, of course, since the meeting is happening in India, it's an Indian summit, look at where we need to really focus and how we can achieve the 2030 goals. Thank you very much for having invited me to be with you all this morning. Thank you.
Thank you, Dr. Samya Swaminathan. We now come to another exciting milestone in our journey. Education plays a pivotal role in tackling global health challenges, and with this in mind, we are proud to introduce the Hepatitis Online Course and Learning Management System. I now invite Dr. Rodrigo Offren, WHO representative to India, to officially launch this game-changing platform. If you would please do the honors, sir. Three, two, one. Learn.Hepat.app is the Chennai Liver Foundation's platform for online and hybrid courses on viral hepatitis, liver diseases, and cardiometabolic diseases. In collaboration with ICMR, National Institute of Epidemiology, CLF launches a course for health professionals on viral hepatitis, aiming to train 10,000 professionals. May I now request Dr. Rodrigo Offren to please share a few words with us.
Dr. Soumya Swaminathan, our chairperson for the MS Swaminathan Research Foundation, Dr. Radhakrishnan Diman, director of Sanjay Gandhi Postgraduate Institute of Medical Science in Lucknow, Dr. John Ward, director, Coalition of Global Hepatitis Elimination, Rachel Halford, president, World Hepatitis Alliance, representatives from the Ministry of Health and institutes such as ICMR, Dr. Shanmugam and Dr. Vivekanand. Dr. Shanmugam, our founder of the Chennai Liver Foundation, who performed the first liver transplant in India and is also now a liver transplant recipient. Esteemed representatives from partner organizations, community members, faculty, delegates, ladies and gentlemen, friends, good morning. And I'm wishing you a Pongal Vartikal. It's actually heartening that from your festivities you are taking a break just to be able to do this, and because it's a very important topic where we really have to come together. It is really my privilege to be with all of you here today. The summit brings together experts, stakeholders, diverse sectors to discuss strategies to advance India's commitment to eliminate hepatitis as a public health threat by 2030. According to WHO's 2024 Global Hepatitis Report, the number of lives lost due to viral hepatitis is increasing, as you have heard from the other dignitaries who spoke. New data from 187 countries show the estimated number of deaths from viral hepatitis increased from 1.1 million in 2019 to 1.3 million in 2022. Of these, 83% were caused by hepatitis B. Sadly, it's preventable. We have a vaccine for it. And 17% by hepatitis C. While these numbers paint a troubling picture, I think today's gathering is heartening and motivating because elimination by 2030 is still achievable if we take swift actions now. India launched the National Viral Hepatitis Control Program in 2018. The program has made significant progress in making prevention, diagnosis, and treatment services available throughout the country by adopting a very integrated approach and also leveraging on all the health system investments that the country has made. The global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections aims to achieve the goals of ending AIDS, viral hepatitis B and C, and sexually transmitted infections by 2030. That's a triple elimination goal. In line with this, WHO is working with the Ministry of Health, the National Viral Hepatitis Control Program, on a hepatitis burden estimation exercise. Our experts have already done a lot of training for modeling so that we really know our numbers. We cannot be moving also without knowing what is the real burden and where are these. WHO is also supporting the prevention of maternal-to-child transmission of hepatitis, including HIV and syphilis, as part of the triple disease elimination goal. I would like to congratulate, of course, the Ministry of Health and all their efforts, partner organizations, for their commitment towards combating hepatitis in India. Most of all, I would like to acknowledge the leadership of the Chennai Liver Foundation, and of course, Tamil Nadu for really taking this on and taking the lead in this. We have the knowledge and the tools to prevent, diagnose, and treat viral hepatitis. We've just launched a few more so that we're able to eliminate hepatitis. We have safe and effective vaccines that can prevent hepatitis B infection. Antiviral drugs have been effective in controlling and preventing disease progression and managing chronic hepatitis B and curing most hepatitis C cases. It is important with all that science and tools that we also have people. I think that's the slogan of the Chennai Liver Foundation, where science meets humanity. Keep the needs of people living with viral hepatitis at the center of all efforts and deliver services closer to the communities at primary healthcare level. I take that as an auspicious sound for that statement. Empowering communities and civil society engagement will help reach the unreached. I think many of you are represented here today, and also the tool that was launched for learning is another way of reaching out and informing the community so that we can proceed with elimination. One is an overused expression. The multisectoral approach is really needed, but I really believe in that. It is also about a systems approach. Diseases are not mutually exclusive, as you already heard from Dr. Sumya Swaminathan. You have TB and diabetes, TB and HIV, hepatitis and HIV. It's all coming together into that one primary healthcare center, that one patient, that one ASHA, who has to kind of think about this and make it report not separately, but as a more integrated person. Now with that, research and developing curative treatment strategies for hepatitis B and a preventive vaccine for hepatitis C will really reap rich dividends. And India is a place for this. It's always called the pharmacy of the world, and it is. Maybe if you ask, 70% of all the vaccines of the world are actually produced in India. So if you ask anyone around the world, 7 to 8 out of 10 will probably have received a vaccine made in India. And hopefully that will be for hepatitis and hepatitis B and C. Keeping the elimination target in sight, it is important for all of us, all stakeholders, to collaborate and intensify actions. Dr. Sumya called for a call for action at the end of this summit. And I think what we really need is also to identify what would be the game changers, low-hanging fruits, and what we can leverage where there is already investment. If there is investment in primary healthcare and health and wellness centers, let's ride on that. That's being handed to us as a silver platter for a space for diagnostics and getting the patient early. This will ensure that life-saving interventions benefit people on time, irrespective of who they are and where they live. And I will end there. My best wishes for the fruitful deliberations to keep people safe from hepatitis, and we look forward to working further with you. It does not end with the meeting. It's a lot of work. Basically, we're planning what we need to do so that we can again meet to work together to achieve our 2030 goal. Thank you for your time and attention.
Thank you so much, Doctor, for your wishes and all of your efforts. As we near the end of this opening ceremony, it's an honor to invite Dr. Vivekanandan Shanmugam, Managing Trustee of the Chennai Liver Foundation, to address the gathering, summarizing the importance of this summit.
Stay hungry, stay foolish. This is one of my favorite quotes of Steve Jobs. I think everyone knows I'm fairly hungry. I want to do different things all the time. But only when I started organizing this a few months ago, I thought I was so foolish to get this going. But today, I'm excited, I'm thrilled, I'm overwhelmed to have this meeting here, to have the people on the dais and off the dais. And there are n number of people who helped me do this, who blessed me I would like to thank all of them. Of course, I was specifically told by Paloma, no, it's not a formal vote of thanks, so I have to be very short. But two questions popped up while I was interacting with a lot of people. First is, how did you get all the illustrious list of faculty? There are about 50 different speakers from various fields come in for this summit for the next 2 days. And of course, more importantly, how did I manage all these people on stage? To begin with, Dr. Offren, thank you very much for being here. Your office was fantastic. I just sent an email that we need to. I've never met Dr. Rodrigo Offren before. Neither did we know that his office existed. We got an email from someone, and we emailed. And within 24 hours, they said, yes, he'll be here, not to worry. No other questions asked. And this happened about 6 weeks ago, I think. And thank you very much for being here, inspiring us and motivating us. Thank you. The next person is, when I told his name, and they said, wow, is she on board? Dr. Soumya Swaminathan. Right? Thank you very much again. As she said, she's got nothing to do with hepatitis, but she's so well known around the world. She's just a true inspiration for all of us, especially for people from Tamil Nadu and India. Madam, thank you very much for inspiring us, helping us, and guiding us. Professor R.K. Deeman, I don't know if you know, he's the president of INASL, and the midterm meeting is happening as we speak, yet he's sitting here on the dais. So thank you again for being here, and this shows the commitment he has towards elimination of viral hepatitis. There's one person who's traveled about for 48 hours. He's doing a travel for 48 hours to attend a meeting for 16 hours. Dr. John Ward. John, I don't know how to thank you. I hope you're enjoying your stay in Chennai, and thanks for all your commitment, your guidance, your help. I've been interacting with John for about 6 to 8 months now on some other projects, and he's been amazing. We've had talks. He sits in a car washing area, and we have a discussion about some research happening. That's his commitment towards the whole process of elimination and research and education. Thanks again for being here, John. And of course, the World Hepatitis Alliance is a family to us. We've been with them for over a decade now. Rachel, Carrie, and Jess, thanks for being here. Of course, I miss Ben. Ben is a very close friend. But what they've done is being a leader, and making others grow. I think but for the World Hepatitis Alliance, I don't think CLF would have been doing so much, and I'm sure all the other members of the Alliance would do the same. So thanks, Carrie and Jess and Rachel, for being a true leader and making all of us grow, giving us that platform to grow. Thank you very much again. Of course, as everyone said on the stage, I really don't want this to be just a 2-day summit. We should have something concrete. We should all come together, because I think there are 250 leaders in this group today, and if all of us join together, I'm sure we can and we will be able to eradicate this disease. I hope you enjoy these 2 days as much as I enjoyed putting this together, and thank you very much.
Thank you so much, Doctor. With that, we come to the close of this inaugural ceremony, requesting everyone to please rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे
Thank you. It is now my great privilege, ladies and gentlemen, to declare the Indian Hepatitis Summit 2025 officially open. So let us embark on this journey of learning, collaboration, and action. And together, we hope to make significant strides in the fight against hepatitis. Enjoy the sessions and let us make this summit a milestone in the world of public health. Thank you so much, and thank you to all of our dignitaries. So ladies and gentlemen, we will dive right into our first session. We've designed today's program to foster dialogue, exchange knowledge, and catalyze action. We have an outstanding lineup of sessions ahead featuring distinguished speakers, experts, and panelists who will share their knowledge and perspectives. From strategic pathways to hepatitis elimination to groundbreaking approaches in public health, this summit will set the stage for collaborative action and change, and we look forward to your active participation throughout the day. Now let's get started with our first session on strategic pathways to viral hepatitis elimination. This session will set the stage for our discussions today, exploring the steps necessary to combat and ultimately eliminate viral hepatitis. I would like to invite our esteemed chair dignitaries to the stage to guide us through the session, starting off with Dr. John W. Ward, Director, Coalition for Global Hepatitis Elimination, Task Force for Global Health. Can we give him a round of applause? I would also like to call upon our next chair for this session, Dr. B.S. Ramakrishna, Director and Senior Consultant, Gastroenterology, Sims Hospital. He specializes in IBD and pancreatic biliary endoscopy, and he's the past president of the Indian Society of Gastroenterology and editor-in-chief of the Gastroenterology, Hepatology, and Endoscopy practice. Welcome. Thank you so much to both our chairs.
Oh, great. Okay, great. I'm happy to begin moderating with my colleague, Dr. Ramakrishna. as we begin a mind-expanding journey through a variety of presentations looking at different options for expanding prevention, testing, and treatment for viral hepatitis. To start us off, it's my pleasure to welcome Dr. Po-Lin Chan to the stage from the World Health Organization's Regional Office for the Southeast Asia region to give her regional insights on eliminating viral hepatitis in Southeast Asia. Po-Lin?
Thank you very much. So if I can pull up the slides. It's indeed a privilege to be here today to speak and set the scene on regional insights and on elimination of viral hepatitis in the WHO Southeast Asia region. Okay, how do I move the slide? This is an IT question. Okay, so first of all, the WHO Southeast Asia region, or in short, CRO, consists of 11 countries that have nearly 2 billion people. We have large countries such as India and Indonesia, but also small countries and island states including Bhutan, Maldives, Timor-Leste, and Sri Lanka. Thank you. The WHO Global Health Sector Strategies and Initiatives are the documents, the global documents that guide the framework on our work in WHO and also in member countries on HIV, viral hepatitis, and STIs. And we also in WHO have launched the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B, which is aligned by and aligned with the global strategy for women, children, and adolescent health up to 2030. Core to these guidances is actually the framework for universal health coverage and WHO integrated person-centered care. In the Triple Elimination Initiative, this is one of the true first multi-disease elimination approach. And we have standardized criteria and processes for validating achievement of elimination or the path to elimination. And we have global guidances on validation, on governance, and on country validation. These are all open for people to look into. At the regional level, we have the Southeast Asia Regional Integrated Action Plan for hepatitis, HIV, and STIs for the next few years and up to 2030. The vision really is to end the epidemics and advance universal health coverage, primary care, and health security, with the goal of ending AIDS and the pandemics of hepatitis and STIs. At the end, it is all connected. Health is connected. Let me get on to the regional burden of viral hepatitis, HIV, and STIs. This is a primer for our knowledge. And in the Southeast Asia region, we are 24% on hepatitis of the global burden, 10% of HIV, of the global burden, and 16% of the STI global burden. If you really put all in, it's more than 130 million people affected by one or the other blood-borne infections. But what's the impact? The impact is new infections, death, disability, because infections do carry disability. But really importantly, we have a whole continuum of not only adults, we have young people, we have children, infants who are infected. In this region, there are 53,000 congenital syphilis happening today in 2024, 6 years from 2030, that still happens. Pregnant women, So we are looking at a whole host of people and subgroups that are important to work on these blood-borne infections. WHO published the updated global estimates in April 2024 for both hepatitis B and C burden. In the Southeast Asia region, this is 61 million hepatitis B and almost 10 million hepatitis C. And what does it translate to? Liver cancer. Liver cancer in the region is invisible. If you look at the overall cancer statistics, you don't see liver up there in the top 5 or top 10. But you look at the sex disaggregation for men and women, you see that liver cancer is one of the top cancers in men of all ages. And when you start looking into detail in the countries, liver cancer in Thailand is the top liver cancer. They are so worried because liver cancer is the top cancer death in Thailand, but it's also one of the top 5 cancer deaths across so many countries here. It's just that we don't have enough data on cancer. But the reality is cancer, because of aging, of changing demographics, of infection, untreated epidemics, is increasing. And I will show you in the next few slides. We need to address the preventable liver cancer, especially chronic hepatitis B and C. Let's bring about a perspective, it's not just cancer, but before cancer, we also have cirrhosis or liver cirrhosis. Hepatitis B and C accounts for 2/3 of the global burden of cirrhosis. And in Seattle, this is also similar. In fact, a global review of all the regions in cirrhosis tells us that cirrhosis in the Seattle region also is due to both B and C. More than half of cirrhosis is due to hepatitis B and C infection. Let's have a look where we are doing now in the latest reports of the Southeast Asia region. We have substantial numbers of millions that are infected with hepatitis B and C. Overall, our prevalence among children for hepatitis B infection is quite low, but this is a regional average. We haven't gone to countries yet. New infections amounts to several hundred thousands per year, so we haven't switched off the tap of new infections. The number of deaths is static and will grow. And we are doing not well on testing and treatment, just not well. We're doing like slightly better for hepatitis C, but really not well for hepatitis B. So what does it lead to? Today, we can, using the modeling, are able to predict where we are going to in the next few years to 2030. Our prevalence in hepatitis B is gradually reducing because of improving immunization programs. Therefore, new chronic infections because of immunization is reducing. But hepatocellular carcinoma or liver cancer is increasing, and it will increase beyond 2030. Liver-related deaths will increase also, because it's not just cancer that kills, it's also cirrhosis or decompensated cirrhosis that kills more people. In hepatitis C, our viremic hepatitis C infection is static because by and large, most countries are working towards better infection prevention control, sterile needles, use of low dead space and better needles and syringes, so it's overall better. But it's not coming down. New chronic infections remain static because there's still a fairly substantial amount of unsafe injections or transmission still going on in the communities as well. In liver cancer, it will increase due to hepatitis C because we're not treating, we're not curing enough people in Southeast Asia to stop the liver cancer. And liver-related deaths due to hepatitis C is also and will increase beyond 2030. So now, having set the scene here, what can we do? What can we do together? And always remember, we are talking about a menu of actions. But what is this menu of actions? WHO's most recent global health strategy calls for action. It calls for concerted action because it is a combination of existing interventions at scale. We are not asking for new stuff. We are asking for existing interventions and improving and strengthening coverage quality at scale. More people, reach more people. And what are these? Immunization programs, MCH, prevention of mother-to-child programs, safe blood, use of voluntary donors, better universal precaution, safe medical injections, safer sex for, in HIV programs, better and more accessible needle and syringe exchange programs for people who inject drugs, harm reduction for people who inject drugs, and very importantly, better availability and accessibility, affordable hepatitis B treatment and cure. Let's have a look at the regional coverage of vaccines in the last several years. This is from the country reporting to both WHO and UNICEF, which we have compiled over the decades. Following the coverage of hepatitis B vaccination decline during the COVID-19 pandemic years, we can see that recovery is there to pre-pandemic levels, but it's not universal. Hepatitis B birth dose remains low, and what is important is we have to realize it. You can catch up vaccination for pentavalent. You cannot catch up that missed birth dose in babies. So you have maybe transmission happening, but still the pentavalent vaccine will occur. Thus, it's really important to emphasize that we have to improve a lot on the timely birth dose of hepatitis B. Let me show you the traffic light scorecard as well. And this is in the 11 countries of the region. On the left side, the left table, it's for hepatitis B, 3, which is the coverage for pentavalent. And on the right side is the hepatitis B birth dose. You can see that we have a lot more red and yellow around the birth dose table. And in India, birth dose have significantly been static for many years, hovering around the 60% coverage. So we have to do more. In India, institutional delivery has improved a lot. But there's a discrepancy to what we see with the timely birth dose. So we have to understand what's happening, what are the implementation issues, and how can we improve the uptake of timely birth dose. So hepatitis B control goals requires universally high coverage of all districts, more than 80% coverage. But really importantly is to date, 6 countries in the Siaru region have been verified for the control goal. And these are Bangladesh, Bhutan, Maldives, Nepal, Sri Lanka, and Thailand. And really importantly is moving beyond hepatitis B control through immunization to the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. What does it mean? Elimination is where we stop. We don't even turn off the tap. We really stop the trickle of new infections. Imagine that the next future generation is free of these diseases. And this is what we can do. This is about the promise to the next generation. Now, 3 countries have been validated for dual EMTCT for HIV and syphilis. These are Thailand, Sri Lanka, and Maldives. But we have high burden and populous countries such as India, Indonesia, Bangladesh, Nepal, that have yet to reach targets, or it seems impossible to reach these targets because, well, India is so big. Indonesia has so many islands. But there are always also opportunities to move incrementally ahead. So we have to find ways to address the diversity of the subnational epidemics, and this can need and will need consideration of the subnational elimination approaches. I would like to point out that it's not just about hepatitis B, mother-to-child transmission. In fact, this year in 2024 and 25, the regional office is looking into hepatitis C, mother-to-child transmission, because we have seen that in some of the settings, that is hepatitis C transmission to mother to child, and when there is a high background prevalence in the community or in the population for hepatitis C, pregnant women also will require testing for Hep C. At the end, we have to track the infant that is exposed to hepatitis C, follow up, and ensure that if the infant is infected, then at 3 years old or more, the child can actually get a hepatitis C treatment. There's no need for a child that is infected with hepatitis C to live until they are adolescent or adult to get treatment. We have pediatric formulations and guidelines for children now. I'd like to also remind there are other factors of new hepatitis C infection. In fact, 21% of new hepatitis C infections are still due to unsafe medical injections in Southeast Asia region. That's 1 in 5 persons. Our cascade of care in the region is suboptimal. We're just nearly not reaching people enough for testing and treatment. And it's also similar for hepatitis C as well. Access to hepatitis medicines remains challenging. The good news is that we have generic manufacturing of hepatitis drugs in the region. Bangladesh, Thailand, India, Indonesia, Myanmar, to some extent, manufactures generics. And the median global price for hepatitis B still is low, around $30 a year. And for hepatitis C, this is about 60 to 90. But the actual prices are more. So there's still work to be done in this region on trying to get affordability of drugs. I want to point out that it's not just countries that are homogeneous. There's a lot of heterogeneity. In this region, we have several countries that have emergency settings and are in conflict as well. And in 2024, the WHO has been working on the emerging crisis of hepatitis C in the Rohingya refugee setting, where in Cox's Bazar, 1 million refugees stay. And among them, 20% are hepatitis C infected. This is one of the highest hepatitis C prevalence in the whole world, in any setting. Now, why are we advocating this? Because it's not just about the future generation, it's about today. Liver cancer, it's a scourge. It's a scourge for society. It's a hepatitis, and treating hepatitis will prevent liver cancer today, and it can impact tomorrow. And what do we need? We have proven strategies, countries that have adopted universal and big and extensive coverage of hepatitis testing and treatment, find that they basically treat themselves out of the epidemic of liver cancer to come. Japan is a very good, Taiwan, Korea. These are all countries that have done that very strong public health agenda as well. And we have to be reminded the cancer is here to grow if we don't do anything today. And the cancers will come after 2030. Even though we say 2030 is our target, most of our countries will see that cancer peak around 2035 to 2040. So there is much to be done today so that we can impact tomorrow. What are the key takeaways that I'd like you to take home? The two set of actions really is about prevention and treating those who are infected. Mostly is the realization and to really support the advocacy that liver cancer is preventable. There are many things we cannot prevent in cancer, but liver cancer is preventable. And the concrete actions to scale up requires better service delivery, coverage of existing health programs, and trying to move on, really trying to get integrated services for triple elimination of mother-to-child transmission and ensure that mother is tested and the child is followed up. And lastly, on testing and treatment. In the WHO's Southeast Asia Regional Office, our strategic priorities covers the whole gamut of the three conditions on strategic information. We will continue to advocate and work with communities and with champions. We have to work on prevention, testing, and treatment, making sure that you adapt the newest guidelines and the newest evidence. There'll be innovations and digital tech, and try to just move forward more implementation science of how do we converge, how do we get the best value of money of interventions, and trying to deliver services in primary care. At the end, what matters is communities, and to try to also reduce stigma discrimination. This is my last slide, but I call on you that we will work together to optimize, to leverage, to converge, and to try to work towards integration of services. Dr. Saab from the Chennai Liver Foundation said, it's all about connection. We are all connected. Health is connected. It's not one disease. So that one person may have multiple ones. But importantly, we are learning together. And I would like to invite you to our WHO webinar where we will work with the Brazil Ministry of Health so that Brazil can talk about their implementing experience on delivering on triple elimination of mother-to-child transmission. Brazil is one of the two countries, the other country is China. So Brazil and China have now are working on the subnational certification of elimination of mother-to-child transmission. And I promise you, it will be an interesting presentation and dialogue. So let's learn together and work together so that we can get towards 2030 targets of elimination as a public health problem. Thank you.
Any questions from the audience for Dr. Polan Chan?
So we have microphones placed in the audience. If any of you have questions, you can come forward and introduce yourselves and go ahead and ask your questions.
Thank you, madam, for a nice presentation. I am Dr. Pradeep Bhomik from Agartala, Tripura, and Director of Hepatitis Foundation of Tripura. I am Professor of Medicine over there at Agartala Government Medical College. My issue is what you said about the Cox's Bazar issue. 20% of the Rohingya refugees are having Hep C. I believe it is a global threat for all of us. And what action we are taking locally and globally. That is my issue, sir.
Thank you very much. So the issue around migrants and refugees are a global issue. People move for many, many reasons. Some because of economics, some because of conflict. The Rohingya refugees is because of conflict in Myanmar and the political situation. So we acknowledge that we have this challenge across all borders. It's not only in Cox's Bazar, Bangladesh, there's also refugees in India, in Thailand, in Laos, in borders with China. So Cross-border issues are always invariably an issue for all communicable diseases. There's also malaria, TB, HIV. So hepatitis is just one of them. Having said that, WHO has been working extensively with the government of Bangladesh and also with humanitarian partners in the Cox's Bazar. And we have been working to set up the testing and treatment strategy and program and find resources to help these vulnerable population. But it offers also a lot of lessons learned. Hepatitis C is being transmitted from pregnant women to their child in Cox's Bazar. We have now, today, more than 150 pregnant women who are hepatitis C. We cannot give them DAAs because they are pregnant, and it's not like DAAs are not to be used during pregnancy. But we are finding ways and challenges how to track them back, monitor, care for them, and follow up of their babies. So there are many learnings that we can learn together and actually find the resourcing to help the vulnerable. But I'm pretty sure, and I've also talked to many hepatologists, that you do have hepatitis C also in pregnancy in India and also across the countries as well. So it's not a unique issue, it's just that it's a very big issue among refugees and migrants. Thank you.
Thank you, madam. Madam, one more issue that you said it is coming from Myanmar. So what you are doing for the Myanmar issue then?
So I think in the interest of time, we might have to have these discussions outside of this. Just one very quick question from Dr. Rakesh Agarwal.
Dr. Polin, Rakesh here. How do we say that this transmission is mother to child and not by another route such as injections? And why should virus in Bangladesh behave very differently, that it starts getting transmitted from mother to baby when it doesn't get transmitted in other parts of the world?
Thank you, Dr. Rakesh. So it's a very good question, yeah. Why do we say mother to child? It's because when we screen all mothers in Cox's Bazar because of their challenge and because of the background prevalence, and they are women as well, they're just an adult, for hepatitis C during their antenatal checkup. So they are screened for HIV, syphilis, hepatitis B, and hepatitis C. And then they are detected, and then they are followed up for both their obstetric and also for the liver staging site. And why do we say we track the babies for their hepatitis C status, and we test them for their outcomes after 18 months. And that's where we can see basically where these babies have
But if A follows B, does not mean A leads to B. We can't say that, right? They could be getting infection from anywhere.
All right. So I think it's time to move on to the next talk. It's my pleasure to invite Professor Radhakrishnan Dhiman to the stage to talk on the National Viral Hepatitis Control Program. He is a very distinguished hepatologist, originally in PGI and now director of the Sanjay Gandhi Postgraduate Institute of Medical Education and Research. Dr. Dhiman, please.
Thank you, Dr. Rama. My acknowledgements. The first question is, what is the need for the viral hepatitis elimination? As far as India is concerned, I have already told you, there are 3 other infections also besides hepatitis: tuberculosis, HIV, malaria, and I'd like to tell you that it is the 2016, when the deaths caused by the hepatitis, they have excluded the death caused by the other 3 infections also. So I think it is an important issue as far as India is concerned. Among the hepatitis viruses also, it is the hepatitis B and C, which is mainly responsible the deaths caused by the viral hepatitis. And you all know about the targets: new infection reduction by 90% 2030, and hepatitis B and SCV related deaths reduction by 65% by 2020 and 30, and 80% of those eligible should be treated also. So the question is whether these are achievable or not. All these targets you are know, it is as a result of the modeling study for the hepatitis B, where all 5 interventions, including infant vaccination, birth dose vaccination, peripartum treatment, otherwise treatment, and the cure. And if you see by 2030, we could achieve, if we follow all these 5 interventions religiously, 90%, and death rate by the 65%. Otherwise, if you look at the prevalence of the Hep C in India is very low, less than 0.6%, but because of the population, the burden in India is enormous. At the moment, it is 5.5 millions, and here, this is the southeast region also, where the India belongs to. 2/3 of the cases, they are from the India, and it shows the burden of the 5.5 millions in India. Coming to the Punjab. Punjab is one of the area or the province in India where the prevalence is very high. Against less than 0.5%, here the prevalence is the 3.6%, and against the population of the 30 millions, you can see over here, the anti-SCV positive 1 million and viremic is 756,000 persons. And you have to tackle and you have to treat all these patients. And if you look at the demography of the Punjab, there are 22 districts, therefore 22 district hospital, subdivisional hospital 41, community health center 150, and the government medical college 3. So we have to take help from these sources. So once I tell you one thing in one day that our Chief Minister of the Punjab, Prakash Singh Badal, called us. So we belonged to at that time the PGI Chandigarh, Postgraduate Institute, and we discussed about the problem of this viral hepatitis B and C, and they say that we will give you the free diagnostic and treatment, but you have to take care of this situation in the state of the Punjab. So we went ahead and we made the standard operating procedures. Ultimately, we have the 3 additions also. So this is the algorithmic approach for the treatment. You can see once anti-SCV is positive, RNA is positive, then you have to look whether cirrhosis is present or not. If it is not present, then we have treated these patients soft DECLA for 12 weeks. If it is present, then we have to do the genotype, which is mandatory. And the genotype 1456 was treated with the soft ladipasvir-based regimen, and genotype 3 soft DECLA based at least for 24 weeks. And the ETR was optional, but SVR was mandatory. You see that it requires 7 to 8 visits for this algorithm to follow also. In addition, that I tell you one thing, I was belonging at that time to PGI, where we used to treat around 13 to 1500 SCV patients in our department. Then we moved to this program also. The first of things that we did, primary care provided at each district hospital, around 120. We had a hepatitis C workshop. Thereafter, then we have the ECHO program, extension of the community health outcome. It is basically the telemedicine-based program also. So we acted as a hub, and 25 centers acted as a spoke also. And we used to discuss the difficult cases at that time also, and followed by the didactic lecture. And we used to do on each Tuesday between 11 and 1 p.m. Suppose if between the 1 week there is an issue, then we had a WhatsApp group and we used to discuss in that group also. Here you can see one of the session that was going on. Here you can see the hub. And here you can see the spoke, and it is the echo program, through the echo program that we were doing. Besides the doctors, that the capacity building was also done for the district epidemiologists, pharmacists, data management operators. Monitoring and evaluation was the prime thing that we were doing, and we had the health of the child, that is the Clinton Health Access Initiative. And we started the program in 2016 in 22 districts and 3 government hospitals, that kept on till 2018, when we have added 9 more treatment centers in the central prison, and later on in the sub-district hospital, ART center and OST center. Ultimately in 2021, we were having the 61 centers for the treatment also. All these things, that whether it was effective or not, whatever we have done, I'll come to that one now. The first of all, that we published our results in the repute journal, Journal of Hepatology also, where we have included more than 50,000 patients. See that in our hospital we were just treating the 1,500 patients per year. Here we have treated more than 50,000, and the results indicate those who have completed the treatment, the response rate, SVR was 91.6, and those who have not completed but have taken a treatment for 4 weeks, they have the response rate of the 84.5%. So we can say decentralized care of Hep C with generic DAs is a safe and effective regardless of genotype and presence of the cirrhosis. Similarly, we have the results in patients in children also between the age 12 and 18 years. If the weight is more than 35 kg, then we have given the full dose, otherwise half the dose. Here you can see the results ranging between the 97 and 100%. So this was also effective in treating these children also. And then we have the experience in persons who inject drugs also, those who have completed again SVR 91.1% also. The most important thing that we have recently published, only the last year, the paper, the patient who were having the decompensated cirrhosis, after the decompensation, they have the recompensation. Decompensation means the presence of hepatic encephalopathy, varicose bleed, or ascites, and when these things disappear, we call it the decompensation. And I will show you that we included in 1152 patients, about quarter of the patients, they have the recompensation. So the algorithm that we were treating the Punjab has not only benefited the patients, but it was effective in the reversal of the disease also. And the government of India noticed the progress at the Punjab, and they adopted the model as such. And first of all, once the NVSCP was started, so we have prepared the guidelines, first for the diagnosis and management of the viral hepatitis, then diagnosis and management of the hepatitis B, then testing of the viral hepatitis, and the operational guidelines also. What we did in NHVSCP, that the genotype which was mandatory for the treatment in cirrhotic patient, we abolished it, and it was replaced by the pan-genotypic drug, that is the Solf and the Valthu. And by doing this, we could reduce the number of the visits from the 8 to 5, 6 also, and see it that there was no genotyping in this regimen also. And this was based upon the cost-effective analysis modeling study that we did, and we have demonstrated if the budget is an important constraint, Valthu should be given to the SCV infected cirrhotic patient. If it is not a constraint, then it could be the universal drug that could be given to all patients also. What is the current status actually? The current status to achieve these goals. We have 978 treatment sites across. In Punjab, we were having the 68. Now 978 treatment sites across 711 districts across the country. And we have trained more than 500 master trainers at the national levels also. And this is the serological test provided and the access to the treatment also. But complete data is not available. Therefore, I will take the help of the data from the South East Asia region also, to which the India represents about the 2/3 of the burden of the Hep C and the Hep B cases. Here is a modeling study of the hepatitis B, where they say if we follow the intervention, all those 5 interventions, probably we can eliminate the same goals we can achieve by 2070, very far from the 2030. And the death we can achieve also by the 2080 or so. And if we do not follow these instructions or interventions strictly, then maybe the eradication in the next century also. What are the future directions actually? How can we further simplify our regimen in our patients also? So we have to reduce these 8 visits to 2 or 3 visits also. There is one study that is a minimal min-mon approach in 38 sites in the 6 countries also. And what they have done, they have just given 12 weeks course at one go. And there were another 4 components of the minimal monitoring included. No pre-treatment genotyping, because you are using a pen genotyping, you just give it for the 12 weeks. Dispensing the entire treatment course at the entry, no scheduled on-treatment visits or laboratory monitoring, and remote contact at the week 4 to assess the DA's adherence, and 22 to schedule the SVR. Based upon this, we propose, actually, I am also the chairperson of the TRG group, so we will be having the meeting and we say that we have to follow the same thing. We should be giving the software to all our patients, and we should have a remote contract at the 4 weeks to assess the DA's adherence, and the 22 to schedule SVR. And in the meantime, as far as the diagnosis is concerned, I think we should collect the sample for the rapid test as well as the reflex SCVR testing. If it is positive, then there could be a straightforward linkage from the diagnosis to the treatment also. That's what we propose now. And for the self-fit devices also, I think we can debate, we can discuss about it also. Now we have such devices who can detect anti-HCV in the oral fluid, and the accuracy is more than 98% also. And here you can see the results also, sensitivity 99 and the specificity 96 and accuracy more than 98% and so. And simply there are so many approaches actually for the diagnosis also. Whatever we are doing the current HCV testing, you require the 3 visits. And the point of the care antibody testing you can have, and the HCV RNA testing. But what is more important, if you have the reflex RNA testing, so you have to draw only the one sample. You do the rapid test. If it is positive, then reflex testing for the HCV RNA, and it has been demonstrated with the cost effective. I think this is something we need to integrate our National Viral Hepatitis Control Program also. And we have demonstrated also in our institute also. The author is already sitting over here, Dr. Amit Goyal. They have demonstrated that these strategies, they are feasible and they are effective also. I think we have to discuss all these things, or we have to think about it very seriously. Ladies and gentlemen, I like to summarize. India has a huge burden of the Hep B and C. National Viral Hepatitis Control Program has made an impact. Training of the healthcare workers. We have 978 treatment sites across 711 districts across the country, and we have trained more than around 5,000 master trainers. Drugs are available to all the districts. That is the very, very important thing that I want to substantiate over here. And substantial number of the treatment centers have been started. Viral load testing has been established also, but I think we have still miles to go. Need to review the screening strategies as well as linkage to treatment, which I have just discussed with you. But I tell you one thing, only it is not the India that is behind in achieving the hepatitis elimination goal by 2030, but they are the most of the countries except in America and few countries in the Europe. I think the most of the countries, they are lagging behind. With these, I like to close. Thank you so much.
Thank you very much. Thank you for an excellent presentation. I think in the interest of time, and also to most immediately begin to compare the situation in India, which you described so aptly, we'll hear from Dr. Oriol Fernandez about some examples from other countries, and then we'll entertain questions and comments from the audience. So if I could ask Ms. Oriol Fernandez to come forward for her presentation to look at success factors and lessons learned for global action from other countries. Oriol is a long-time colleague as a member of the CHI, the Clinton Health Access Initiative. Oriol, thank you.
Sorry, I'm just waiting for my slides to come up, but maybe I can just address the forum first as they're pulling up my slides. Good morning, everyone. My name is Oriol Fernandez, and I lead the viral hepatitis program at the Clinton Health Access Initiative, also known as CHI. It's really a big honor for me to be here and part of the summit in my home country, and actually the state that I studied in several years ago. I really want to kick off this presentation on behalf of CHI, extending a big congratulations to all the organizers of the event. It's remarkable to see how many diverse delegates have come together from all parts of India and different parts of the world to really recognize the progress we've made since the start of this program, but really grapple with the opportunities we have at hand now to catalyze and accelerate progress towards viral hepatitis in this country. Initially, I was asked to speak about what lessons we've learned as CHI from other settings that could be applicable to the India context. But as I was thinking about it, I realized, India is a country where healthcare needs to be provided to over 1 billion people, 1.5 billion people nearly now. And the lowest level of our healthcare tier system, the primary centers and the sub-centers are providing coverage to above 5,000 people. And so we work in a really unique context here in our country. And there's already so much innovation and implementing strategies that are being carried across the country that we can learn from each other from different states. And so instead, I'm going to focus my presentation on some key aspects that I feel have been big milestones in India's journey that we can take back for global action in other countries. And I hope my colleagues that, like me, work in other regions of the world will have some lessons learned to take back after the summit. So, just to start, Professor Diman really comprehensively spoke to the components of India's viral hepatitis journey since the start. So I'm not going to duplicate any of that, but just to build upon it, I think to sort of reflect on, where we are right now and where we want to go, it's important to reflect back to where we started and even before the start of the program, and really recognize the role that specialists, local researchers played on highlighting what a big public health challenge viral hepatitis was, and a growing challenge for a country like India. And then the role that community advocates really played in demanding that we start to take action right now. And then, of course, we had states like Punjab, Dr. Diman talked about, that really pioneered and showed us that it was feasible to push forward simplified test and treat approaches for this disease. And so all of this really set up the enabling environment for India really to move forward and take action. And so when the program launched in 2018, a really unique highlight for me was the strong foundations that the national program laid right from the start that was backed by 100% financing by the government. And so, when I think about the other country settings that CHI works in, I really can't think of an example where we've had a government that has put this much investment at this level of scale thus far since the start. So that's a really unique aspect of a program that we have to, celebrate when we think about the launch of the program. And as the program has scaled, it's made it a priority to really harness the power of data. Once again, right from the beginning, launching one of the strongest management information system examples we have in the hepatitis landscape. And it's stuck very closely to the principles of decentralization and integration, really taking a health systems approach to scale up this program and not duplicating. And I want to deep dive into each of these milestones a little further, but just to say up front, CHAI has been really grateful to work through our local Indian affiliate, WJCF, who's registered here in India, to support the Ministry of Health and Welfare and Family Welfare to support some aspects of this journey, partnering both at the national level and in different states to support data-driven programming and implementation. So just to move forward to some of those milestones and talking about the foundations again, I think India is pretty much an exemplar of what we mean when we say universal health access, which its priority pillars being, firstly, ensuring financing, as I said, 100% domestic funding for sustainability, and really taking an integrated approach to avoid duplication. Secondly, really focusing on access, providing free screening, diagnostics, and treatment for both hepatitis B and C for all populations. That's been guided since the start by a national action plan. And then really thinking about addressing quality, standardizing trainings and capacity building, guided by a national clinical and operation guideline. While the program has been providing some major components like diagnosis and management and along with capacity building, I think another very unique factor of how India started and has been scaling up its program is really thinking about integration with what already exists in the health system, leveraging services that are being provided by a range of other programs, as you can see on the slide, and really again to avoid duplication. And so, overall, I think India is really an example of a country that's demonstrating that there can be a health systems approach, and there needs to be a health systems approach to eliminating viral hepatitis. We're not going to do this if we try to build vertical structures. And I hope that's like a first key lesson that we can take for global action moving forward. The second sort of big milestone that I'm always impressed by when I look at India's program is the power of data. The national program, I think Dr. Dhiman touched on this before, has developed and rolled out an incredibly impressive paperless data recording and reporting system for the country, again, right from the start. And the system, enables data collection, monitoring and effectiveness, and evaluation of program effectiveness, and has been designed for India's context. So really thinking about customization based on patient flow and information flow in the India context, thinking about the roles of use and access for the different levels of individuals that need to access and use this data in the health system, adoption enabled through a variety of capacity building rolled out across the country, and then most importantly, producing real-time reports and dashboards to enable data-driven decision-making. And this is a type of data that can be used for descriptive, geospatial, and predictive analysis as well. And I think what this highlights to me is that the national program has recognized the challenge of India being very geographically expansive and having a large population, and underscoring the role that data can play in helping us track the progress we're making across our states and inform where we need to do better and continue to accelerate progress. Maybe the third milestone here, and we can't talk about India's program without acknowledging the strategic way in which viral hepatitis services are really being decentralized and integrated with incredible implementation examples from various states. And I'm not going to be able to call out all the examples happening across all the states in our country, but just to call out a few. The hepatitis program has worked very closely with the maternal and child health programs on things like really ensuring safe delivery, testing and linkage to care for pregnant women, and then thinking about cross-program tracking of hepatitis B birth dose. And there is a state here, West Bengal, that's really been trying to operationalize this approach within a triple elimination approach and has focused on repositioning the screening protocol for triple screening, so really emphasizing that we shouldn't be missing screening pregnant women for all 3 diseases when they're coming to the same health entry point for health services. The second thing that's been really remarkable in what West Bengal has been doing is encouraging cross-disease program collaboration at all levels. Again, this needs a systems approach, and it requires different parts of the health system coming together to deliver services. And then third, again, the importance of data, integrating indicators for all 3 diseases in the MNE system to ensure that we're able to track progress. So this is a really incredible example, and I think we'll hear about it a little later in the summit. A second example on integration has been how the national program has been working with the National AIDS Control Program to really address high-risk groups, so screening and treatment for people living with HIV, and also advancing multi-disease screening and linkage to care and targeted intervention in OST centers. And Punjab's been an excellent example of driving forward high-risk group screening strategies. And back in the day, tailored a strategy that was implemented to integrate screening, counseling, and treatment for diseases, including hepatitis B and C, at targeted intervention sites. And then finally, maybe one more example of integration is integration with blood banks, really thinking about improving treatment and linkage rates for hepatitis-positive donors. And here we have another state, Madhya Pradesh, who's been really focusing on a blood donor referral project, defining the referral pathways for hepatitis C and B, defining the standard operating procedures, and implementing it across 7 blood banks. And again, ensuring robust data management systems. So data keeps coming up as a key theme here. So, once again, I think we're going to dive into some of these incredible state examples as we go through this summit, but just want to call out what a big sort of highlight this type of integrated health systems approach is and where it's needed across global action for, advancing us towards our viral hepatitis goals. Now, as Professor Deman said, we have miles to go still. We're not there yet. And as we look forward, there's a lot of opportunity we can capitalize on and challenges we need to sort of look back, analyze, and address. And, specifically for me, I can't talk through all of these. I think a really important area is going to be continuing to bridge the gaps in case finding and co-infections for key populations. And to do this, we really need to uplift the voices of community and to address stigma. So there's a really exciting session, I think, later on where we're going to be talking about this. But I think this is one of the key areas we're going to need to focus on. Of course, strengthening diagnostics and linkages to care. And, I think here we have different states who are already implementing programs. And what's going to be really important is the implementation research to understand, for patients that are not being linked through the continuum of care and we're seeing loss to follow-up, understanding the contextual factors that are driving that loss to follow-up. So I do think over here, implementation research and really analyzing what's happening with our programs and then sharing the lessons learned can really help. And then maybe the final one that I want to talk about, and I think, Pulin, you talked about this, within your talk is, we have a real opportunity to expand the triple elimination agenda. India can be doing so much better on delivery of hepatitis B birth dose right now, and we already have the pathways and examples for integration, and so it would be great over the next 5 years to see some of these state-level pioneer projects on triple elimination really expanded and taken on at a national scale. So a lot for us to do. And I hope we're going to be able to capitalize on the rest of the time together to deep dive into these opportunities. But I think before we start, I hope this session has just really been an opportunity for us to underscore the remarkable progress India has made thus far and highlights how by doing more, accelerating and addressing those challenges, we can really set a benchmark both for the region and for the country, for the rest of the world globally. Thanks so much.
Thank you very much. We have a time for a few questions. I have a question both for Oriel and for Dr. Diamond. We've heard some of the positive features that's underway here in India that make hepatitis elimination feasible: pilot programs, good data, low-cost diagnostics, and medicines. So what's needed to advance progress, to get over these miles to go before we achieve? What needs to be done now? And for, I know Oriel most in her work globally, so I'm really interested, Oriel, to hear from you in your global experience. What should we be bringing into India to accelerate progress? And then for Dr. Diamond, I'd like to hear, with your leadership in the pilot programs that you were describing, what do you think are the feasible next steps that can really accelerate progress? Oriel, do you want to comment? Did you hear that question?
As far as the NVSCP is concerned, I think it was a good beginning. There has to be, as the data has come from the different studies as far as the management is concerned, that could have been incorporated actually. 2-3 things I basically understand. To whom to screen, I think that is a big question in India also. If you say the high risk population of the Hep C population is around 12 to 13%, but the remaining, they are the low risk. So how to go about it? That is the one thing. I personally favor that we should be having the universal screening program. But I would say that kind of a thing require a lot of money also, as well as the planning also. The second thing is the diagnostics actually. The diagnostics should be, as we have demonstrated in one of the study, my colleague Dr. Amit Goyal also. So rapid test with reflex SCVR and testing and the linkage to the care, I think that is the thing that can be done. That is, and at the same time, we have a colleague over here. I am really very much impressed during the Punjab model also, monitoring and the evaluation by the CHAI also. I think that is the one thing that we should have, and based upon whatever findings we get, whatever, then we have to act accordingly also. So these are the things.
Thank you. Oriel, quickly, I know we have a question at the microphone. I don't know. Did you have any, just comparing the situation in India with your experience in other countries, do you want to highlight, any other features from Rwanda and other countries you've worked with as examples for India to capitalize on?
Yeah, I think, John, I kicked up my presentations, sharing some reflections there. Firstly, what more can we be doing? I think meetings like this are incredibly powerful. As I said, India is a very diverse country, but we have a lot going on. States are implementing different projects, different strategies, and I think we need to be sharing lessons within our country context and learning from each other. And as I said, really understanding, the epidemic looks very different in different states. And so really looking at our data and understanding, what are the challenges to loss to follow-up, and where can advances in diagnostics, decentralizing diagnostics, bringing in more point of care, help us address some of those loss to follow-up challenges. I think if I look globally, I have to be honest now, I have to be humble. CHAI doesn't work across many countries of the world. We have 7 countries that we provide support to, and I feel like a lot of the countries we work in are currently drawing lessons from India, and so we're grateful to be able to be here and support and learn from what the national program is doing here. But as I said, one area that's so close to my heart is the triple elimination agenda, and I feel that that is one area that we could really be accelerating at the moment. And I was impressed to hear from Poland, actually, that we do have countries like Brazil who are starting to look at subnational validation processes for EMTCT, and I really do think that that's maybe an area where, as we continue to expand the national program, thinking about how we can expand the triple elimination agenda nationally and building off what some of the states are doing, be important moving forward.
Thank you. Do you want to
If
comment?
I may, thank you very much. I just take a page on what Dr. Sonia and Dr. Rodrigo said earlier. There is incredible opportunity and potential in India. The government of India will screen 75 million people for hypertension. They've done more than, I think, 30 million or more to date. And it's incredible because they're doing this screening at the primary healthcare centers and the health and wellness centers. Of course, there will always be implementing challenges, and we all know that. But we have to start somewhere. And the NCD program is one of the largest in the world. Similarly, for TB, Government of India screens many, many people for TB. And in TB, as they say, as I love to say, all roads in TB lead to the liver health. And when you want to start TB drugs, it still can be hepatotoxic drugs as well. So somehow in TB patients, we need to screen them for hepatitis, screen out hepatitis B and C. So these are really, I would say, multi-disease approaches. First thing is screen or screen out. And then the rest of the protocols can get in. But first is the testing. Diabetes, people come with diabetes follow-up for a very long time. Screen them out. They're aging, they are more than 40 years old, they probably never been vaccinated, they may have received unsterile injections in the past or cumulative lifetime or risk. So these are opportunities that we can leverage from all the other different programs or do proof of concept. Lastly, there's a huge investment in primary care and medical institutions. Every district will get a medical college, right? I don't know how many will to date, more than I think hundreds of medical colleges now. So 400 plus medical colleges across the nation. Every district will have at least one medical college. This is power in the institution and the ability to have the healthcare professionals and the knowledge and the expertise that can help us move towards elimination.
Thank you. Thank you. We have time. Gitan, do you have a question, comment?
Thanks so much, Dr. Ward. My question are going to be for Professor Dhiman and then linked to Ms. Fernandez. My name is Gitan. I work with Trade Asia. I'm based out of our Bangkok, Asia office. The Indian National Viral Hepatitis Program is around 7 years old, and you talked about that decentralization onto 978 facilities, so it has progress for sure. 91.5 serological test is quite a remarkable number, I think, although the burden and the population size is pretty big. You also talked about about 300,000 treatment provided. That 91.5 million is a combination of hepatitis B and hepatitis C. And 300,000, I would assume, treatment is also a combination of hepatitis B and hepatitis C, although there was, Dr. Dhiman, you also pointed out that there's a lack in terms of availability of data. And without data, we cannot, really devise on policies. So do you have, number one, is a segregation onto hepatitis B and hepatitis C, although knowing that the hepatitis B came in a year later compared to hepatitis C. Second point, especially for Ms. Fernandez, thanks to Chai for all the support that you're giving. You talked about the power of data. Your slides are blurred. Why is that?
Yeah.
If we don't, and I think we don't expect an answer here, neither from the panelists or from everybody. How many of us know the actual data in India? Ms. Fernandez talks about knowing the cascade. How do we know the cascade? How do we know where are we losing these patients? How do we know how many are coming back for SBR? Where? In which state? Each state, health is a state subject for sure in India. But how do we know who is going to intervene where? What's the point of having a dashboard when this is not accessible? I think these are fundamental questions. In 2025, we need to relook at this. The states are supposed to have steering committees. I don't know at the national level whether those are really discussing. The steering committee are actually helping in terms of deciding the programmatic strategies as well as the investment in terms of where investment should go. We can talk a lot, but I think talking about the basic fundamental premise on data without accessible, powerful data to drive both policies and programmatic challenges, I think we are not going to be there, unfortunately, in 2030, talking about 90% and 65%. Thank you.
Just to respond to your comments also, I totally agree actually, that the data has to be there. Where is the cascade actually, where we can see over here. But I remember we started the program in Punjab, only for the hepatitis C, not the hepatitis B. It was a separate thing actually. And now in NVSCP, both are different actually. But in Punjab, I think we have a very strong data with us. And this was all because of the CHAI, Clinton Health Access Initiative. And we used to have each and every patient's data with this, and we have generated the alarming system also, alarms also. If somebody has not come for the third month's or the third month's treatment, then the alert is generated and we have to approach to the patient also that you have to come. And similarly for the SVR also. So I totally agree with you. I think without data, without the cascade information, hardly you can do in future also. I think that is the primary thing we should have. And only then we can say that what is the response rate and what are the benefits that we have achieved and how much we have to add many more things that we have to achieve also. I totally agree with you.
Thank you.
Thank you. Rakesh?
I would like to hear a bit from Ms. Fernandez on what CHAI will do in terms of making this data accessible for people. I understand that there might be certain limitations, but I think this message should go back, that people are asking to see the broader data, if not the detailed one.
Yeah, thanks so much, Giten. Maybe, just to clarify, the reason they were blurred in our slides is CHAI through WJCF provides support to the national government on the data system. So we're not showing it in our slides because this data and these dashboards don't belong to CHAI. They're data that belongs to the government. In terms of who has access to it, it's different people at the different levels of the government who are managing their programs. But I think what I'm hearing from you is we need to find ways in which different leads in different states, whether you're at a state level, at a district level, the federal level, are bringing together the right coalition, communities, partners, within coordination. We call them in other countries data review groups, to review your data on a quarterly basis and understand where you're driving the challenges. And so that type of coalition, coordination, I think needs to happen more. And hopefully we can talk more about that through some of the rest of the presentations. But I agree, data is meant to be used and needs to be used by the right people. And so that's a really important factor.
Yeah. Thank you.
Yeah, thank you, Giten. You raise a very important point. We'll be exploring access to quality data later on in several presentations in the program. So I look forward to future discussions on that. Rakesh, last question, please.
So I wish to make 2 points. Firstly, we are looking at only those who are being treated as a part of the program. In India, nearly 80%, some people would say 75% of healthcare is in the private sector. And we are all aware that possibly a larger number than what has been treated as a part of the program have been treated outside the program. Do we even have any idea of that? Can we ask the manufacturers how much drugs they have sold in the country? And that number may actually be much, much higher. And that needs to be added. We cannot say the country is done only 2.8% treatment or whatever if we don't include that. The second issue is, if we think we are going to be able to test everyone, it's going to be challenging. India is a huge country, both in terms of area and the population. And in different regions, risk factors are going to be different, as people who are in the country know. So I think we need smaller studies. They may not be absolute, we may not be able to catch everybody, but if we can focus on some subgroups, that's the way to go. To think that we'll be able to screen everybody is not going to happen by 2030.
Thank you. Thank you for those comments. We're going to have to close. I'm so sorry because we're behind schedule, but there'll be other opportunities for you to raise additional questions and comments. Let's give a round of applause to our presenters, please. And we'll move on to session 2. Thank you very much.
A big thank you to our chairs and our presenters for this session. I'd request our chairs to do the honors and felicitate our speakers. A token of appreciation for Dr. Polin Chan. If you do the honors, please, gentlemen. Professor R.K. Diman. And Ms. Oriel Fernandez. I now request Professor Diman to please do the honors and present a token of appreciation to our chairs for this session. So Professor, if you would do the honors and present to our chairs, to Dr. Ward, and to Dr. Ramakrishna. Thank you so much. Thank you. Thank you so much to our chairs and our speakers for an excellent session. I think all of their insights have set the stage for a very important discussion, so we can give them another big round of applause, ladies and gentlemen. We'll get right into it and shift our focus to our next session on shaping the future of hepatitis care. In this session, we are privileged to have Mr. Arun Jain with us to present on design thinking in public health, innovative interventions for hepatitis. His expertise will offer valuable insights into innovative approaches that are shaping the future of hepatitis care. So please join me in welcoming Mr. Jain to the stage. We're eager to hear his thoughts and vision on this critical topic.
Good morning. It was a great session. I'm a technologist, not a doctor, so a lot of vocabulary which is being used in this session was somewhat out of my capturing the attention, but the work which you are doing in hepatitis B and hepatitis C, and I'm doing the research over the last few weeks with Dr. Vivek, I understand the gravity of the situation and the goal of 2030 to eliminate hepatitis B and hepatitis C. When Vivek approached me first time that you should speak on design thinking, a different way of looking at this large problem, I said, can you please tell me what is hepatitis means? I'm a CEO of the Intellect Design Arena, runs a publicly listed company. To me, the word hepatitis, I need to ask that question, what hepatitis means. If at my level, I don't understand what hepatitis means, then how a common person in the village will understand what hepatitis means? Do we need to simplify the language which we communicate to the people? Should we say Hep B and Hep C, which has been inherited from some other part of the world, to be shared in India to communicate that, do we have a Hep B and Hep C? Or HPV or HCV? So a fundamental question came to my mind whether we need to use a local language. If in India we say jigra, jigar, liver means jigar. So if inflammation of jigar has happened, whether this is an attack, people know heart attack, but they don't know liver attack. Will the new vocabulary is required? So when I'm looking design thinking as a keyword, I would like to ask, because design thinking is generally done in a more interactive fashion. So what is the meaning of design thinking? What is the literal meaning of design thinking in your mind? Anybody would like to just share what is the literal meaning of design thinking? What do you mean by design thinking when you are attending this session?
I have no idea, but let me try.
Yeah, sure, that's what I'm saying. It's a literal meaning. I am not even asking a meaning of design thinking, I'm saying literal meaning of design thinking.
So I think you're trying to think of an image, something that when people look at, it makes them think of what you are wanting to convey.
Beautiful.
So you see a Tata logo in India, you know this is a Tata company. That's
right.
possibly what you are trying to say.
That's right. What is the literal meaning? Literal meaning of it is, there are two words in it. There is a design and there is a thinking. There are two words are there. How you design the thinking is the meaning of design thinking. So now the design thinking can be used in various contexts of designing the thinking. We designed this conference we have designed. It took some few months to design this conference. When you design the thinking of a patient or the caregiver or the doctor, how you design their thinking. There's a very good paper written by which says water of system change. For any system change, what is the water of it? We talk about rocks, we talk about fishes, but we don't talk about water. Water, we assume there is some water available in which fish can survive and rock can survive. And this is a beautiful article written by Peter Senge and 3 people. When they worked for 30 years in a social sector, they found the change happens from the 3 things which we talk about in most of the conferences are policies, practices, and resources. So we constantly keep on spending time on these 3 structural change which we want, which is explicit. There are 2 relational change which is required about relations and connections and power dynamics. And finally, which is a transformative change happens when we talk about mental models. So out of the 6 conditions of change, first 3 conditions are explicit, but the rest of the 3 conditions are missing somewhere. They are there, we know it, but sometimes we don't work explicitly onto it, and that's what the design thinking can come in. So when we look at the mental model, if out of the 5 conditions of change, 3 conditions of change you're talking about in this conference, which is policy, practices, and resources, whether Punjab has done this thing, what resources are required, what practices are there, what medical health is doing it. I'll not be getting into those areas because that's not my domain. But changing the mental model, because for sustainable change, I believe it should start from bottom up. A lot of time change starts from top down. Design should come from top down, change has to start from bottom up. We are talking about state and districts in India. To me, population lives in village and panchayat. Our policies are around districts. District is too wide a subject. One district of India is like a country. I wear the three hats. One is my technology hat, running Intellect Design as a company which delivers software to the complex financial needs like Reserve Bank of India or HSBC of the world. Second hat I wear is Mission Samriddhi, where we are working with 500 villages in India using in 10 states. This is done by my foundation called Polaris Foundation. And third hat is a school of design thinking, where I'm influencing design thinking that if this can be adopted, it can bring a sustainable change. In design thinking, what is the mental model shift happens? I would say there are three things are there. One is system thinking, second is design thinking, and third is the first principle thinking. Now these three words you must be hearing it in various conversation. What is the system thinking? System thinking is around how do you maximize whatever the resources available to you. You want to maximize those resources and optimize the resources. The management programs, what we taught in MBAs, are about maximizing and optimizing the resources, which is around system thinking. Then comes design thinking, where we bring customer in the center. So customer in the center for Hep B and Hep C is sitting in a village or panchayat, which get aggregated to block, which get aggregated to district. And then we talk about first principle thinking, which is start with why. Why do I have to change? Why a person in panchayat needs to change, what he needs to know and what he needs to change. His stigma has to change, what needs to change. It has happened at that stage. That will come from the first principle thinking. So there are three kinds of things which constitute a mental model of the community to change, because we are looking for community to change when we are making a sustainable and holistic change. Our objective of this agenda is it should be holistic, it should be sustainable. So I'll take another 15 minutes, I'll go to the more theoretical session on design thinking. This kind of workshop I do for many of the cross-functional and transdiscipline kind of a teams. Like in this forum, we are having a lot of NGOs, lot of CSOs, lot of healthcare organizations, multiple stakeholders are sitting, for which design thinking is a methodology. So normally this workshop takes a day or two to do, but I'm just going through the slide very fast, but just to ensure that I'm covering the topic, the design thinking, science of design thinking. So design thinking started from Stanford in 1992. They said design thinking is about customer desirability, technology feasibility, and business viability. You need funding. So when three things intersect, desirability, feasibility, and viability intersect, it's a true design thinking which can happen. But similar definition from East Coast, from Yale University came in, where you say design thinking is about mystery. When you look at the patterns and anti-patterns, you create heuristics, and that heuristics, when it becomes aligned and it becomes algorithm, then it becomes design thinking. So that's the second way of looking at design thinking, from mystery, heuristics, algorithm. Third is, how do you remove mystery to heuristics? You need to understand stated and unstated requirement of the customer. You need to observe pattern and anti-patterns. So most of the discovery in medical sciences are based on understanding, observing some patterns or observing some anti-patterns. So most of the research which is happening is based on observation. Observation is a key piece here. So design thinking revolves around 4 senses human mind has. We call it listening, observing, reading, and dialoguing, which can be abbreviated as a LOD. So those 4 senses are important for observing patterns and anti-patterns, that how I listen to the patient, how do I observe his behavior, his symptoms, and how do I wire it with my readings, and how do I dialogue with the medical community to get a proper analysis of that particular data. Then I connect the dot which is within the same system. That system could be hepatitis system, or it has to be connected with other systems of human body is connecting the dots. And sometimes you need to look at it. There will be some blind spot. How do I take care of the blind spots? So there are 4-step processes. There are 3 different ways of defining design thinking: desirability, feasibility, viability. Second definition is mystery, heuristics, algorithm. And third definition is understanding deeply what is unstated, what is below the surface, what is the pattern, anti-patterns, what is the connecting the dot, and the don't know what I don't know. So a lot of time we don't know what I don't know because we make certain assumptions which are not relevant for that kind of a case. So my assumption, my biases holds me back for understanding the blind spots. The 3 laws of design thinking: less is more, last 2% is 200%, and when we are prioritizing, it is a 10 gram, 100 gram, 1000 gram item, not ABC. So a lot of time we have to focus on what 1000 gram items are, which will drive it. When we look at design the thinking, there is a 2-part section I'm taking. First is how you shape the thinking, which goes inside the mind of the people, of the customer, or the community. And what is the process of design, which is thinking the design. So in first part, I'll cover you, the 5 elements are required for making any design team, right design team, or right design mind. First force is my skills. I need to have a right skills. I need to have a right expertise or mastery, which is at subconscious level. So my expertise is my depth of knowing the things. So I go to basement 1, I go to basement 2, I go to basement 3. I keep on acquiring more and more expertise, and I keep moving down from ground floor to basements. That's the expertise which is there. Now when I'm looking at third element for design thinking is I need to go and look at the larger landscape, which is a complete landscape and cartographic view. And that is nothing but perspective. So for perspective, I need to move from ground floor to first floor to second floor to third floor to fourth floor to look at the larger view of the context in which a problem are being solved. So I need a skill, I need expertise to go down to the 4th basement. I need to go fourth floor to go up for the perspective. And this one is the width space and one is the depth space, which need to come together. When you combine width with the depth, you come with a set of ideas. Now this is the idea where motor runs horizontally. If motor runs vertically, you get an elevator. The idea is asking the right question and connecting the right dot. Because motor was designed for replacing horse cart, and many years it was only replacing horse cart. But one fine day somebody said, if motor has a purpose of moving from point A to point B, can this point A and point B can be vertical? And that shift of dot created a new opportunity of high-rise buildings. And that is what we call idea. If I ask a question in a workshop, what is the definition of idea? Lot of people respond to that. I say, what is the definition of idea? Not what idea does. Pardon? A thought. But what is it basically to whom we call idea? Idea is, yeah, please.
It has to be novel.
It should change something. It should connect something new. So when we say idea comes to my mind when I'm in shower and comes an idea, then idea is just about connecting a new neuron in a new pattern. So some neurons are running in your mind. When these neurons get connected, it shapes newly. That's an idea. In this diagram I'm representing, idea is connecting the dots. Each dot is a knowledge packet. And we have a set of knowledge which is available about hepatitis or public health. We have so much knowledge available. Each dot is a knowledge packet. And if these knowledge packets get connected in a new pattern, it's the idea. It can connect within the same space of liver, hepatitis space, or it will connect with the cardiac space, or it will connect with the neurological space. It's interconnect ideas. So idea can be within a space idea or interconnect ideas. Amazon as a company, they connect the dot by saying, I can receive an order on the internet. It's an idea which is connecting one dot. So a lot of time, IKEA as a furniture company created an idea that instead of assembling a furniture in the factory, if you assemble at a home, then you save the logistics cost and give a ability to reduce the cost and price to the customer. So that is a one dot connected, that instead of assembling the furniture in a factory, you assemble the furniture at a house, you save logistics cost and storage cost substantially to drive the lower cost and create a viability. So a lot of time ideas are connecting a one dot in a system. Then finally, we need to look at like alignment. The 5 aircraft running, there has to be so precise that every initiative should be run in conjunction, and that's what I call alignment. So skill, expertise, perspective, ideas need to be aligned, and this kind of a forum is the right forum when we can align these ideas. And these 5 drivers are required for design. They're the basic ingredient for design thinking or design mind. I just abbreviated SAPIA just for acronym for better recall. But if we have put all of this thing together, do I have an assurance of sustainable change or water of system change? May not be, because there are 5 frictional forces which I call DCAF. First frictional forces is doubt. You may have idea, you may have answers, but do you have a doubt to take an action on it? A lot of time we don't take an action on the doubt. And doubt is, we don't even understand where the doubt is coming from. It's my indecision, it is my uncertainty, it is not just clear. Is that the doubt? A lot of time the great ideas are there, 95% of idea get killed because we have a doubt in ourselves. 95% of idea in the world gets killed at the stage of doubt. It doesn't take a shape. After somebody else taken that idea and implemented it, then said, oh, I thought of it. Didn't I thought of it 10 years back? That's the power of the frictional force called doubt. Second element is called conflict. And we say all the time there is a conflict between government and NGO, there is a conflict between pharmaceutical company interest and the doctors community or a patient community. We believe conflict is a very common word where we push most of the problem statement behind conflict. If you go to anatomy of the word conflict, what does the conflict come from? What is the definition of conflict? Conflict is a difference of opinion, it's a difference of perspective, or it's a difference of expectation. There are only 3 ways of conflict. Any conflict in the world is about these 3 things. I'm not talking about self-interest over here. There could be conflict because of self-interest of a person. I'm not putting that as a part of this equation. I'm saying conflict is a difference of opinion, difference of perspective, and difference of expectations. Now, if I go back to anatomy of creativity, that if we want to find a creative solution in public health, I will need all the 3. For creativity, I need a difference of opinion, I need a difference of perspective, I need difference of expectation to define a creative solutions for a public health. So, is conflict and creative are the 2 sides of the same coin. When we want to suppress one, other gets suppressed automatically. So when we are connecting design mind SAPIA, skill, expertise, perspective, idea, and alignment, these forces, doubt, conflict. The third force is anger, power. A lot of people acquire power in the system. In a water of system change, the power dynamics plays a such an important role in the whole system of water system change. And navigating power is something becomes most critical for us to make the sustainable change. We feel power is an authority. To me, power is a helplessness which drives anger. Sometimes people become angry to each other, organizations become angry to each other. So I'll just skip this slide. This is about anger meter. I just use it for. Fourth force is a fear. Fear of unknown, fear of going wrong, fear of failure, fear of commitment. A lot of time the fear is of unknown is the most important thing. It's not about going wrong. A lot of people in this hall are expert of their subject. Sometimes fear of unknown is there. What will happen to this? Then there is a fifth force is ego, roadblock of learning from outside. How do we create a humility environment? How do you create acceptance to learn? Or how do you unlearn certain things? So these are the 5 forces which are frictional forces. I call frictional forces because these are useful forces also. Friction is not bad because I'm standing on this dais because of friction. But how do you use a friction for what purpose is important to us. So if I look at 5 frictional forces which are there, doubt, conflict, anger, fear and ego, and integrate with the SAPIA 5 growth forces, these 10 forces are there to make a water. Water system change comes from these 10 forces. And on the top of it, you sit the policy, practices and resources will sit on the top of it. This will create only water. This will not be visible to you. Now I move to second part of it called process of change, which is called thinking the design. And how do you make the process work? Like if there is a community of 100 people, they have to use design thinking, how will the process work? We call it a design thinking workshops. So when we start, I took a challenge in 2016 when I got some money by selling off my first company called Polaris, and I got a foundation created out of it. And that foundation, we were saying we will contribute to the poorest district in India, and we identified Yavatmal as the poorest district where the highest number of suicide happen. And I visited that city with 20-member team. I realized that I don't know anything because I've grown up in cities. I may have expertise as a CEO of the company, but I didn't know anything about ABCD, about what works in a Yavatmal, what works in a panchayat, what works in a village. I found myself completely incompetent for doing a social change. I would have done a greatest banking product, but not a social change. I went back to the canvas and started doing design thinking workshop with the experts. Each workshop, I said my core competence is design thinking, not system change. First, me take 3 years time to learn what change, social change means. And once based on social change, so I conducted close to 40 different workshops of 2 to 3 days each, where I used to invite the experts in each area of health, education, social equality, panchayat systems. And each time I was learning, I was documenting pattern, anti-pattern, and start putting into applying the design thinking process. So first step was, I tried to learn, create a cartographic view of the problem. What the problem statement look like? How do you create a cartographic view? How do you create a map with the latitude and longitude to understand where in the map you are sitting? And for this, I need to understand landscape, I need to understand technology landscape, I need to understand what competitive landscapes are there, I need to understand what technology trends are there, and then I need to put them into frames. So now this is a very complex chart which is sitting there. This is first chart we draw after 2.5 years of design thinking workshop. I draw this chart that there are 7 rings are required for social change. Social change, I have to start from an inner ring, which is why I am doing it. What is my first principle thinking? I need to build a sense of belonging in a villager, that I belong to this place. And I need to have his emotion that I want to sense of ownership. So I need to have a journey from sense of belonging to sense of ownership. And there is 7 rings people are involved in system change, in which the first was what value system we want to improve. Because any sustainable change requires a value system change. Second is what beneficiaries are required, who are the beneficiaries, who are the life enablers, natural resource management, drivers, enabling system, governance and impact assessment. So the 7 rings are there. First ring is a values, second ring is beneficiary, third ring is a quality of life enablers. Then what is my resources available? In villages, what natural resources are available? Then what is the driver for it? Knowledge management is a driver for it. Communication is a driver for it. So the red ring which is there, it defines what are the drivers for change. Then who are the bodies involved? The next ring is what policies are there, government programs are there. And then governance platform, which is measurements. So I found that the complexity of a social change is as complex as this chart. I need to simplify it further. Though this gives me the cartographic view, I need to take next section. I put it into 38 elements of social change and divide into 5 areas of change. First area of change in rural India is their personal development, designing, transforming the personal image, which I call development block 1, which is a personal change or personal development, which can happen from growth mindset, it can happen from personal values, behavioral change, folk art, constitutional values, volunteerism, sports. They constitute first block. Then on that soil, you need a social development, which are around 9 elements, starting from education, health and nutrition, village infrastructure, social justice, children, gender equality. Once I have first block, then second block social development, then third block comes economic development, fourth block is ecological development, and fifth block is institutional development. So now these 38 elements have been further divided into level 3, we call basement 1, basement 2, basement 3. So this is my basement 2. Going to basement 3, I divide into 144 measurable elements for each village development, and each village development score is created around 1,440 points. And this we then call it cluster development program. Then we deployed a person who can facilitate and run this program. They can create a measurements. So we have a team of 4-member team per cluster. One is called cluster development facilitator, followed by 3 panchayat resource person who are the knowledgeable person about it. So 4-member team defines a change where we incorporate all the knowledge which is required to bring a change. Now this is interesting that hepatitis was not a part of our radar. In all this workshop, hepatitis never came into our radar. It means none of the people who are coming in these workshops for healthcare, for them it was not even an agenda. It should have been part of their agenda. If they don't know about, the cluster person doesn't know at the village level, it means we are talking about the topic in this conference room, but not below the district level. Maybe district committee may know it, but not below the district level, something is happening or not. Anganwadi worker, does she know it can have a liver attack based on this? So this 144 elements created my measurement system, monthly measurement system. On this 38 elements we measure monthly. When we say 3 years time, we'll give it to our deployment of this program. So this program is deployed for 36 months. Each month we have a measurable outcome. And this measurable outcome is done by multiple awareness, created by multiple tools. We do Nukkad Natak in the villages where they bring into a play. We convert the story for awareness into a street plays. And street plays are done within the community of panchayat to create awareness. It's not done by the complex presentations, which are done by most of the time I found government programs are gone by presentations format. No villager is interested in that. If I translate into street plays and then make the street plays people going around and making an entertainment kind of a job, and then you pass on the message. It was getting very well communicated. So moving from that, this is the kind of a technique we call cartographic view technique, we call L0 technique, where we capture the knowledge into a single frame so that human mind can pick up in a single frame. Once we do that, we need to find the opportunity. Second step is we need to solve the problem. We need to solve the right problem. A lot of time, we need to define the problem correctly. For defining the problem correctly, a lot of time, we don't have a no agenda meeting. Have you heard the word no agenda meeting? Have you attended any meeting without an agenda published? Pardon?
All gossip sessions that we do in our country.
That's right. But no agenda meeting, formal meeting. I do a 3-day workshop in my company with 300 people without agenda being published. Now you will say, how can you do it? People are coming from international, our sales team, we are operating in 23 different countries, people come from their people. I say, if I publish the agenda, it's my agenda. I need to see what is the agenda which company needs to address. If I define my agenda, I am defining my problem, everybody is responding to that problem. So they are not understanding what the true agenda is. So when we call the people, first thing we do is circle time. Circle time means if 100 people are there, they will stand up in a circle and they will say what one good thing happened in their community or in country and what one thing they need to improve. They share 100 stories in a circle time. It takes 2 hours for people to share 100 stories. And then they share one stories of which they feel the company should change. Now this defines the agenda. Agenda surfaces. Agenda evolves. The water itself evolves the agenda. Because all the people, 100 people in the meeting are experts anyway. They don't need to tell what is to be done and what not to be done. We are inviting experts people in a large meeting. So no agenda meeting is another great way to identify what is the true problem we are solving. Are we solving the true problem or are we solving the problem which chairman of the company knows or chairman of the conference knows? So this is where the true problem statement emerges, which is a process step 2. Once process step 2 is there, then we create a possibilities. This is the idea generation phase. We bring multiple expertise, multiple perspective to solve the problem, challenge all existing assumptions and biases, pick up positive pattern that works within the organization and outside the organization, pick up some pattern, anti-patterns, and from there we create a large set of ideas. So we have a whiteboards, we have a design center, we created 30,000 square feet of design space. If somebody is willing to want to come to our center in Chennai, it's a 30,000 square feet of only space for thinking space. And there we write down in large whiteboards all these ideas which are there to consolidate. Then the step 4 comes choices. Now you got 100 ideas, how to make a choices. And there is a methodology for it. You create affinity cluster, you distribute 10 gram, 100 gram, 1000 gram items, classify it into quick, bold and long action items, and make choices by deleting 80% of them, choose only 20% of them. And then finally, step 5 is design a story. Once you select the idea, you solve the problem, do the prototyping of it. To design a story, to design a communication is another significant time consumption. So once the idea is there, if I'm doing AI, I write a technology for AI, generative AI, we write a platform called Purple Fabric, which can help in AI to be, enterprise AI can be there. Now, it's taking me almost 6 months time to design a story. My product is ready, but designing a story is not ready. It's taking 6 months time to design a story, and each story is a complex job. How to communicate, how to communicate, how to communicate. Product is there, but how to communicate in the mind of the listener so that he can pick up my product. And that is the way any social change, we need to sell the social change. Social change is as big as sales process. A lot of times social reformers believe that I don't have to sell. Oh, I am a social worker. Why should I sell? He has to be biggest salesperson on the earth if he has a social person is there. A doctor, when he does a design and discovers something, he needs to sell as much as he does the discovery. So there is a 5-step process: cartography, spotting the right problem, universe of possibility, making choices, and design a story. So this is the 2 I summarize. I'll say design the thinking, which is skill, expertise, perspective, ideas, and alignment is to be done. You need to be aware of doubt, conflicts, anger, fear, and ego. So this 5 plus 5, that shapes the environment. Then second is design the thinking, the design, the 5-step process again, cartography, spotting the opportunities, create the idea generations, making choices, and design a story. So I just trying some story for you. When I was talking to Vivek, I was saying, if who is my customer, what is the language should be there? Should the language should be liver failure or jigar inflammation or something local language? What is the local language of Tamil? What is the local language of Telugu? What is the local language of Thai? We need to translate the language of which is attractive enough for the person to pay attention to. You need to have visualization. So if I saying, if I want to do self-inflicted diseases, so these are self-inflicted diseases. One is, which is lungs, which is, we all know. Second is our kidneys, diabetes. We are looking eating habits, which translate into heart disease. We have a liver, which could be alcohol related or virus related. So if these are the 4 items are there, can we combine into one story for rural India? Can we combine this story for corporate India? So each corporate India, when you are taking a session, can we take the combined session of all the 4 stories called self-inflicted diseases? There are 4 diseases which are self-inflicted in nature. And if you have to protect 4 critical organs of yours, heart, liver, kidney, lungs, these are the 4 recipes of it. So then each one build on each other. Hepatitis become part of my diabetes awareness. It's a part of BP awareness. It becomes part of the universal system in India. So when state government and district government wants to promote, they promote all the 4 together. Then the more resources can be pulled in by connecting 4 dots into one for this kind of a awareness program of looking at it. So when we are looking for desirability of prevention, diagnosis, and cure, we need stakeholders, global policy maker, NGOs, government policy makers, state policy, state health workers, Anganwadi workers. These are multiple stakeholders. So we need to design story for each one of them separately. So in summary, for sustainable change, 6 conditions of change: accelerate sustainable change, embed design thinking workshops to drive design thinking change, firstly leading to systemic change and on-ground impact. This is what I want to share. Thank you for listening carefully. A few questions we can take. 5 minutes are there. Or Vivek, yeah.
So when we say you haven't heard or many people haven't heard about hepatitis and people's perceptions are different, one way to look at it, as we hepatologists want to look at it, is that people don't know about it. I would think the other way around. People have more important and urgent priorities.
Sure.
And is it that we are just flogging the horse unnecessarily? No, so where does advocacy fit in? We are trying to take people away from what are their needs, what are their requirements.
That's right.
So, is advocacy really a right thing?
Yeah, so my response to that is, all of us want the attention of the human being. Whether a product company wants attention, employer wants attention, It's the attention and intention. The two words are there, attention and intention. How to get attention if we are advocacy? Advocacy also wants attention. How to get attention right? What is the story of attention getting right? In Intellect, as a company, we have 6,000 employees. If you do a survey of 6,000 employees, how many people knows hepatitis B and hepatitis C? I'm sure it will be less than 1%. Now, if I have to create that awareness in Intellect, then I need to make it a part of some agenda. Somewhere I need to simplify, which become holistic health. So if I say holistic health and embed it into part of that holistic health, maybe chances that 1% can go to 7% or 8%.
See, the dilemma I have in healthcare is trying to do things that are good to people, and on the other side, running the risk of pushing a technology which costs people money.
Beautiful point.
And the problem, what I see as a clinician, very often we are ending up trying to do the first and actually doing the second. We think we are helping the patient, we are helping the individual, but are actually ending up pushing technology. That's an ethical dilemma that, at least makes me very uncomfortable. What do you think as a person who's slightly away from medicine? And I'll stop here, I'll not speak after this.
No. I really appreciate your point. The point is this, what is the right topic to be discussed in no agenda meeting? Let's spend some time. We need to take out this time of one day time only on no agenda. What you're talking, the relevant question. I am not the expert to answer it, and I'll show my ignorance how to answer it. But questions are right. And these are the questions which design thinking should be taking up, but taking up in a sustained manner. This question should not get die down in one meeting and I say, oh, I know the answer, sir. I don't know the answer. So I should have a courage to say, I don't know the answer of your problem, but I know the process in which this answer can be solved.
My name is Dr. Ganesh Kumar. I'm a scientist in ICMR. Thanks, Arun, for this wonderful insight. I'm from a public health background. Fundamentally, the purpose where we are all sitting here and trying to put together here is trying to find some solutions for the critical problems which we face day to day in the public health. And here what we are talking is hepatitis elimination. And I wanted to simplify that. One of the elimination goals set by WHO is that 65% reduction of the deaths compared to 2015. This is one of the important goals. Assume this is what we wanted to solve this particular problem. We hear from your story and as well as elsewhere in the literature that design thinking lays a kind of like a credible pathway in order to find out solutions and accelerate this particular process to find the solution for a problem. Apparently in public health we haven't started, or we don't know that what we were doing to find the solution is part of the design thinking framework or in the pathway of the design thinking. Some pieces we have taken. Assume that like we are supposed to start somewhere else in order to make ourselves intelligently to approach these solutions for the problem what we are having. Where we should start in terms of design thinking, or from your perspective, you have your own personal experience of using design thinking to find out some of the solutions for technology in finance, fintech solutions. Now, as a public health, you also have the experience of using design thinking for societal development also, which working at the grassroots level at the villages. Now, where we should start for a public health, for a problem, say very specific, 65% reduction of deaths due to hepatitis, where we should start doing this or applying this design thinking. Thank you.
So first thing is, you given a platform for me to introduce a topic called design thinking. Itself is a trigger point in your mind. The point Vivek saying, can we do a triggering? If you, out of this hall, how many people are believing that what I'm talking makes sense to your change of system? Thank you very much for acknowledging it because I was very scared before coming to this conference when I saw the names of the people, so many researchers and so many directors on this, whether I'm the right person to even speak in this conference. So you validated that it's important for us to look at it. Then the next step will start. Out of this hall, some 20-30 people will really believe into it. 20-30 people, if we can create a community of 20-30 people to start dialoguing this question. Just I'm not talking about answering the solution. What as United Nations and WHO publishes, my difference of opinion with WHO and United Nations is they are only goals. When you say 17 SDG goal, there is no process behind it, there is no system of change behind it. Just by defining the goals is not the answer of the problem solving. You can say 65% elimination this. These are not the answers. They are the question. They are just the goal target given by somebody sitting in a White House and given the goals. The things happen at the ground, and for that, there is no shortcut for solving the problem. We need to spend lot of thinking time and dialoguing time among all the people who believe in solving it, not by just saying, I want to put a checklist item. A lot of things in the world happen on a checklist item. A lot of government work happen on checklist item. I've seen in last 8 years, I stopped going to governments anymore because they just tick mark the things. And they publish some measurement numbers and some measurement number here and there. They don't, no IS officer sits down for 2 days to look at designing the process. Sorry to say that in public forum. My personal experiences are, they look for some numbers, some metrics, some measurements, and that revolves around policy, practice, and resources. The three implicit thing which requires to change, the mental models, the power dynamics, are not being taken care of. So thank you very much. I think I'm run out of the time. So whatever outside the office, my number will be available. So I will be there till lunchtime, and we can spend some time on it. Thank you very much.
Requesting Mr. Jain to remain on stage for a moment longer, I'd like to invite Dr. Vivek to please come up on stage and do the honors and present him with a token of our appreciation. Thank you so much, sir.
Thank you. Thank you. Thank you.
Thank you. We'll now begin with our last session before lunch. And once again, a big thank you to Mr. Jain for that insightful and thought-provoking presentation. I think his perspective on design thinking and the innovative interventions for hepatitis care is invaluable. Before we move on, I would just like to remind everybody that you can put your posters up at 1 p.m. or before you head out for lunch. And we're looking forward to the poster presentation later on today. So we will now have a panel discussion on addressing the complexities of viral hepatitis elimination. This discussion will be moderated by Mr. Carey James, who will guide our panelists through a dynamic conversation about the challenges and opportunities in eliminating hepatitis. So let's welcome Mr. Carey James to the stage with a round of applause. I would also like to invite our panelists, Dr. Priya Abraham, Dr. Amit Goel, Dr. Rakesh Agarwal, Dr. Kavita Lole, and Dr. Arindam Ray. Let's give all of our panelists a big round of applause, ladies and gentlemen. And I hand the floor over to Mr. James.
Hello. Good afternoon, or almost afternoon, maybe just afternoon. My name is Kerry James. I'm Chief Executive of the World Hepatitis Alliance. And I just want to say once again what an honor it is to be part of this fantastic event, and huge congratulations to the Chennai Liver Foundation and the whole organizing committee for putting together this first ever Indian Hepatitis Summit. And the World Hepatitis Alliance is very proud to be part of it. And I'm very proud to be chairing this very prestigious panel in this very important session on the complexities of hepatitis elimination. So before we get into the discussion, we're going to have some short presentations by our panel. And then we really want this to be an interactive session, so please do come up to the microphones, and please do think about questions while we're going along, because we'd like to have everyone participating in this session. So let's start straight away. So first we're going to start with Dr. Priya Abraham, who's the former director, yes, if you want to take the podium, former director of the National Institute of Virology and professor of clinical virology at the CMC. And she's going to be talking about overcoming diagnostic barriers in viral hepatitis. Thank you.
Thank you, Mr. James, for kicking this off. And my mandate is to outline some of the diagnostic challenges in facilitating more testing in any country. How does this work? Sorry. Okay. Do I move down? Just press the center. It's not budging. So the biggest challenge with these diseases is the asymptomatic nature of hepatitis and B and C infections that precludes comprehensive screening, preventing an individual from getting timely management. We already heard that most individuals remain undiagnosed, untreated. Dr. Shanmugam had mentioned the figures there. And an additional feature is that with hepatitis C infection, there's a long serological window period requiring the use of assays such as HCV RNA testing or HCV core antigen testing, which are expensive, but they are the only tools to detect new infections in a population. It's not moving. The main barriers to diagnosis of these infections is a lack of knowledge, be it in the public or even among healthcare professionals. There's a lack of access to, easy access to testing. There's stigma and discrimination associated with these infections, particularly in some high-risk populations. And for those who do not have access to a nation's program, there is out-of-pocket expenses. So the WHO in 2024 put out an operational guide and has put forward some key enablers that could facilitate more testing in a population. The most important enabler, I think, is political commitment. High-level political leadership and commitment is required. And in India, I would say, this will home in to a particular state in the country. And we've seen the success story with the state of Punjab. High-level commitment has led to making policies that have made viral hepatitis a premium health priority, and have also looked into resource allocation and sustainable financing. The next, to enable policy and legal and regulatory environment while creating testing policies. We've heard about this time and time again. We need to integrate viral hepatitis testing with other blood-borne virus screening as well as STIs. We heard how Bengal is moving in the direction of triple elimination goal. We also need to think of equitable health access for high-risk populations, thinking of people who may be incarcerated, high-risk populations, promote and protect human rights, ensure informed consent when you're doing the testing, preventing stigma and discrimination, and also ensuring gender equality. Another key enabler is planning and data generation. Planning of any testing service requires accurate and reliable data. Programs need to actively gather, validate, and analyze this data to quickly identify gaps that may aid in planning, and this helps to make a good situational analysis. Community engagement is paramount, empowering individuals, their families, and communities as advocates of the policies we are bringing in to promote and enhance an equitable access not only to testing, but for subsequent treatment. Access to quality-assured products and establishment of quality management systems. All I'd like to say here is this is something India needs to do, is to evaluate and identify good in vitro diagnostics and put it up there as their national essential diagnostics list. We can be guided by the WHO model list. WHO has a list of pre-qualified IVDs, so does the Global Fund, and this serves as a good mechanism by which we can identify what are the good testing assays that we could employ in a given geographical region. Planning of this, planning the selection, planning the forecasting the need, planning procurement are all important aspects of getting those vital testing tools into the region. And last but not the least, we also need to think of quality management systems, and I'll come back to that later in the presentation. Decentralization, we heard about it again, time and time again. Integrating HBV and HCV testings into other existing services, very important. I'd just like to make one statement here. A systematic review showed that when you integrate HIV, HBV, and HCV testing, for every 1 case of HIV detected, 5 cases of hepatitis B and 3 cases of HCV are detected. See the efficiency with which you can enhance the testing. Human resources, transportation, lab information systems can be shared across programs. I know the National Hepatitis Program has attempted to share, to integrate with other programs, but on the ground, this is harder than we think it is. Integrated training of health workers. We need to work with those at the grassroots level, enhancing capacity building, ongoing training, retraining, mentorship, and particularly emphasizing on our primary care doctors, nurses, technologists, and pharmacists. And this may involve a very intensive phase of actually training the trainers. Now I come to more granular shortfalls in testing, the barriers, and how we can scale. We spoke about educating not only healthcare providers, key populations, and the general public. And some of the ways to make a beginning is to tell them about the asymptomatic nature of these infections, their long-term sequelae, their deadly sequelae, how these infections can be transmitted to sexual partners, to their offspring, and that today we have available treatment options. This will draw their attention. Poor accessibility to testing for these infections, particularly in low and middle income settings and in regions where it is largely an unreached population, is to bring in point-of-care diagnostics, keeping in mind affordability is premium. Think of central procurement for national programs. A one-stop shop, as it is called, should involve not only the first-line testing, even if you use a rapid diagnostic device, that should be involved, linked to reflex testing so that linkage to treatment is implemented immediately. Home visits, door-to-door, doorstep testing is important. Identify gaps in existing testing services. Is there a lack of availability of some aspect, or is there underutilization? Dried blood spots for serology and molecular testing are gathering momentum. We need to create accessible locations for the unreached. Combine it with other available programs like antenatal programs. And core antigen testing for HCV is also another option if we do not have HCV RNA testing. I outline here the strategy that a country like Pakistan took. Pakistan is this country which has the second largest burden of hepatitis C, the largest in the eastern Mediterranean region. And in the left of the screen, they approached slums in Islamabad. They did doorstep testing, and people who were positive by the screening assay were referred to the closest primary health center. And you can see the cascade from there. They also looked at the general public of Pakistan. Here, instead of the RNA test, they used HCV core antigen. This is not perfect, but you're making some inroads into a largely untested population. Another barrier is stigma and marginalization of our population. Again, we spoke about increasing their awareness. We might have to, in addition to using dried blood spots, maybe oral sampling, self-sampling is something that we need to kick in India. We need to provide testing in settings that are preferred by these individuals. We need to decentralize, we need to demedicalize our testing services. We also need to introduce point-of-care molecular assays of a certain order, of good quality, to make diagnosis possible in a single visit on site. These are examples of how you could take crevicular fluid from a salivary fluid for self-testing, dried blood spots. They are great in situations where phlebotomy is not possible. You can't access venous blood. And they are excellent for packaging and transporting to distant locations. They may be also good for handling outbreaks, but this requires training, requires supervision. It needs, there may be challenges by not creating good dried blood spots. It has an additional elution step, and not all assays are compatible with the use of dried blood spots. But we have had successes in India where we had a multicentric study where we found that actually there are assays that are very compatible with the use of dried blood spots. And here is a study from our own center where we collected venous samples and 2 sets of dried blood spots from consenting participants of the study. We stored these dried blood spots for 15 days at refrigeration temperatures and at 37 degrees. Why 37 degrees? This was to simulate the ambient temperatures in which these dried blood spots, once packaged in a distant site, it takes that long to come to a reference laboratory, and we looked at the virus loads. You can see that the correlation between the plasma virus loads and the normalized dried blood spots was very good both at 4 degrees and at 37 degrees, which tells us that if you use a good assay, dried blood spots are a good option. I want to stop at this most important slide. We have many assays in our country, but if we do not have good quality control and good quality assurance mechanisms in our country, we may be using assays that are suboptimal. In vitro devices ideally must be sourced or followed as per the National Essential Diagnostics List. End users must be reminded that there may be lot-to-lot variations and lot-to-lot verifications must be done. Country program leaders must support participation of all testing facilities in an external quality assurance program. This is really important to know how well their assays are performing, and we should make the reporting mechanism of their assurance program easy for the end user so that we know the data we are collecting is accurate and the right person is being linked to care. And with this, I would close to say that testing is the most critical step to treatment and cure. Thank you.
Thank you so much for such an up-to-date and comprehensive view of testing, and it was great to see all those examples from India. So we're going to move on and have the questions at the end. So now we'll call to the podium Dr. Amal Goel, who's professor and head of hepatology at SGPGI in Lucknow, who's going to be speaking on therapeutic strategies and management complexities in hepatitis care. Please.
Good afternoon. How it will move this way? Okay, right. So, briefly, I will talk about the hurdles in hepatitis care. The cascade of hepatitis care start with the case identification, linking them with care, evaluation for eligibility of the treatment, start of treatment, selection of drug and doses, duration, etc. Then follow-up for the treatment completion and for the complication. I will restrict myself just for the evaluation and treatment, but not the other part. And my talk is centered toward the public health perspective for the decentralization of the hepatitis care based on the evidences provided by the literature available and applicable primarily for the low-risk population, not the high-risk population. These are the hurdles we have. Sorry. Recently, upper limit of normal for ALT/AST is revised from universally accepted 40 to 30 and 19. Second, there is delay in the evaluation process and start of the treatment, which causes loss and poor linkage. Use of different drugs, tenofovir and entecavir for hepatitis B treatment for cirrhotic and non-cirrhotic. Use of 2 different doses of entecavir, 0.5 and 1 milligram for those with HBV-related cirrhosis, higher dose for decompensated cirrhosis, and probably 12 week of treatment or 24 week of treatment duration for SCV is also causing some loss to follow up. Dispensing problem, logistic issues, we need to shorten the treatment duration, which is possible, and 2 different treatment duration similarly for decompensated cirrhosis. So all these different options creating logistic issues in periphery where the resources are limited and healthcare workers are less equipped with the skill. University, we have been known and learned that 40 international unit is the standard. If we revise it, first we have to send this message across the board to all the healthcare workers that the upper limit of normal is revised, which would be a difficult task. And indication for HBV is APRI more than 0.5 and DNA more than 2,000 international unit with ALT any level upper than upper limit of normal. But we know that ALT/AST can be elevated, particularly AST, due to so many non-hepatic causes like delay in sample processing, inaccurately corrected sample, minor muscular injury because muscle is a good source of AST, muscle mass, exercise, and diet. And this study from India had shown among healthy blood donor that median ALT level was well above the 30. So all these issues, if upper limit of normal for ALT/AST is lowered, a larger proportion of HBV infected people may be inappropriately started on antiviral treatment. Then how to avoid delay? We have done a study in Manipur with help of Cone organization. Primarily, they have conducted this study. PWIDs were counseled, then they were screened for hepatitis B and C using RDTs on site, and immediately SCV reflex testing was done with mole bios diagnosis followed by drug dispensing. And all this procedure was completed with a median time of 6 hours 38 minutes in a large samples of somewhere around 450. And we can see that achieved 100% on-site SCV RNA testing in those who were antibody positive, and more than 99% viremic were started on DAA on-site within 6 hours 38 minutes. So on-site point of care test, reflex testing of SCV RNA could improve linkage and adherence. Now coming to the use of 2 different drugs, entecavir is the drug of choice for hepatitis B in presence of cirrhosis. But see, these are the benefit of using entecavir. It causes less degree of kidney injury, less degree of bone loss. The harm is possibility of drug resistance on prolonged use, high cost of therapy, 2 different doses, and high risk of hepatocellular carcinoma, which is one of the common reason for the mortality associated with hepatitis B. This is the individual patient meta-analysis of 11 study, which included more than data for more than 42,000 patients, and have shown that use of tenofovir is associated with 23% less risk of hepatocellular carcinoma as compared to entecavir. Same study has done subgroup analysis, and this stands true even between cirrhotic and non-cirrhotic both. So we may consider to change tenofovir, use a single type of drug for all hepatitis B patients. Now I will talk about the 2 different doses of entecavir for cirrhosis and non-cirrhosis. HBV guideline universally, all ASLD, EASL, WHO, INSL, all the guidelines recommend use of double dose of entecavir instead of 0.5 milligram in decompensated cirrhosis related to HBV. There is no data to support the use of this higher dose of entecavir, and this recommendation originated in lamivudine era, when lamivudine resistance was common and the drug of choice for resistant lam was 0.1 milligram of entecavir. This is the only data which we generated actually available, which has compared in a pilot study of 32 patients where the half of the patients were treated with 1 milligram and half were given, all of them were decompensated cirrhosis with viral load more than 1 lakh international unit at the time of startup treatment, and have shown that higher dose is not associated with rapid viral suppression in decompensated cirrhosis. So actually, we may consider to use the same dose of entecavir, which will remove one of the hurdle in all the patients. Coming to the shorter duration of therapy, currently HCV non-cirrhotic patients are treated with 12 weeks of SOF and VELPA. This one study which was done in PWIDs where 100 patients of PWIDs were treated with 8 weeks of SOF-VELPA. All of them had either F2 or F3 fibrosis. All of them were from genotype 3, which is considered difficult to treat. And on per protocol analysis, it was 100% SVR rate. In intention to treat analysis, it was 96% SVR rate. So we may consider a shorter course of DA for patients who are not having cirrhosis. Coming to 2 different regimes of SOF-VELPA, 12 week for compensated cirrhosis and 24 week of SOF-VELPA for decompensated cirrhosis. This recommendation is also across the board, all the guidelines. It is based on the study published in NEGM, which had 3 arms, SOF-VELPA 12 week with and without ribavirin, and SOF-RIBA for 12 week, which had shown a comparable SVR rate. If you read this paper, method itself is writing that this study was not designed or powered to detect a significant difference in rate of sustained virological response. Though we have done a post hoc analysis and what we are following. So actually, if we have to follow this data of this study, we have to give SOF-VELPA RIBA for 12 weeks because there the SVR rate was higher. But we know decompensated cirrhosis patients hardly tolerate ribavirin. Further, this study is writing that post hoc analysis also failed to identify any significant difference between the treatment response. So we may use a single type of DA regimen for SCV. A single type of DA regimen means 12 weeks for compensated cirrhosis and decompensated. That will further ease the implementation of the program. So in summary, we have certain hurdle in hepatitis care and its decentralization, which can be removed by promoting on-site point-of-care reflex testing for SCV RNA. Need to explore shorter courses for SCV treatment, at least. Use of 12 weeks of SOF-VELPA for SCV DCLD. Uniform use of tenofovir for all HBV cases regardless of the cirrhosis. And 0.5 milligram entecavir for all HBV patients, regardless of the decompensated or compensated cirrhosis. Thank you.
Thank you so much. So I think we'll move on to our next speaker, which is Dr. Rakesh, who is the former director of the JIP MER, who's going to be speaking on navigating management challenges in special populations.
Thank you, Dr. James. So I'm going to talk about the special populations, trying to address some issues. What are special populations? These are groups that need special consideration, which could be based on demographic features, health conditions, or based on socioeconomic factors. And these are various groups that if you go to different publications that are listed as special groups. I'm not going to talk about several of these, especially those against which you see a cross, because those are situations that happen in healthcare settings, and we are looking at settings which are community settings. So I'm going to talk about co-infections, persons who need drugs, MSM, incarcerated persons, and pregnant women. So if we look at persons living with HIV, HIV shares risk factors with HBV and HCV, so co-infections are common. There is an increased risk of persistent infection with HBV or HCV if these infections occur in those who have HIV infection. There is a faster progression of liver disease. There is higher probability of non-hepatic manifestations and overall mortality due to hepatitis viruses, though there is no effect on natural history or outcomes of HIV infection. Now, does it really matter? Basic thing is that you need to test HIV positive people for HBV and HCV, which is easy to do. So there are no challenges except to ensure the logistics, particularly because indications for treatment regimens and cure rates for HCV infection are very similar in those who have HIV infection compared to those who have only HCV infection. There are some challenges because there are drug-drug interactions. So if an HIV infected person gets HCV infection and that has to be treated, there may be a change in anti-HIV or antiretroviral drug regimen. And India has only some drugs available for HCV, but still, there are still so many regimens of HIV that can be used, so this is really not a constraint. If they get HBV infection, again, indications for treatment are very similar for treating HBV, but even if that is not indicated, HIV treatment needs to be modified to make sure that there are drugs that inhibit HBV also, so as to prevent resistance in HBV. Again, those regimens are easily available, so really that's not a barrier. The only barrier may be to monitor, because HBV status needs to be monitored frequently, and Dr. Priya Abraham has already talked about what we can do about investigations. The other special group is people who have both the hepatitis virus infections, HBV as well as HCV. Again, here indications and regimens for treatment are generally similar as for mono-infected patients, and those are available, so really there is no constraint. We just need to detect them and get them linked to care. Successful treatment of HCV infection can lead to reactivation of or activation of hepatitis B virus replication. So some of these people who are not eligible for hepatitis B treatment may need reassessment of their hepatitis B status after they have completed their hepatitis C treatment, and then decision about HBV treatment has to be made. People who inject drugs, all the three viruses can be transmitted through that route, so these people are at a higher risk of HIV co-infection with one of the hepatitis viruses or both the hepatitis viruses, a situation that I have talked about. And also there is an overlap with the population, men having sex with men, so that's another thing that one needs to consider. The real barriers are their poor access to and their poor utilization of hepatitis care programs. These groups tend to have lower adherence rates to investigation plan and treatment, but once they take treatment, the treatment response is very good. And one more challenge that exists is that if they continue to inject drugs, then there is a risk of reinfection. So what does one need to do? We need to screen all PWIDs for HBV and HCV infection. We have heard about investigations from Dr. Priya. It's a question of making sure that these are logistically available and these are done. If hepatitis B surface antigen is negative, we need to vaccinate them. Again, we need to have programs for this and ensure that these programs are adhered to both by the program and also by the users. We need needle syringe programs and oral substitution therapy. These people need periodic testing for acute HCV infection because they're at continuing risk unless they adhere to use of safe injection techniques. There is need to improve adherence. We need to have reflex testing. We need to have patient navigators or care coordinators. And we need to work on long-acting drug preparations so that we can have a depot preparation that can take care of this issue of non-adherence. If injection use continues, then these people need periodic retesting for HCV RNA and treatment of acute HCV infection. And even after treatment of HCV or HBV, they need measures to reduce transmission. And one needs to think, and that's something I think we are failing at making sure that if there is a network of people who are sharing equipment, they are all treated at the same time because that can help reduce transmission. MSM, the issues are pretty similar to what I talked about in the previous slide, except that we need to think of protected sex using condoms, and so I'm not going to repeat that. In homeless persons and people in correctional settings, again there is a higher risk of HBV and HCV infection as well as HIV infection, and a part of it is related to other factors, but some of these are also related to injection use, drug use, and to MSM, and the fact that they come from sections of society where they may have been more prone to getting exposed. Again, some of the challenges are similar to that we discussed in the other two groups. Pregnancy is a special group because these are otherwise healthy people. There is no specific risk of liver disease worsening during pregnancy, so that's very good. Pregnancy can lead to temporary reduction in ALT levels, so that might end up in some of these people not getting treated, but I think cannot do much about it. There is a risk of transmission to the newborn. For HBV, there is a high risk of perinatal transmission, but that depends on DNA level or HBeAg status. Many of these infections are chronic, so that's a major concern. For HCV, the risk is much lower unless there is a HIV co-infection. Drug treatment has challenges, but those are real challenges because these can cause harm either to the fetus if given during pregnancy or to the newborn if given during lactation, so we need to be careful about that. And in the postpartum period, there can be a spontaneous clearance of HCV and flares for HBV. So what we need to do is to avoid treatment during pregnancy. We need to wait till the delivery is over, and ideally after breastfeeding is over, unless the treatment in the mother is very urgent, which most often it is not. Sometimes what is happening is that if these infections are detected, people are being advised to undergo specific care during obstetric follow-up or have cesarean delivery, and these are not needed, and we need to spread the word that this is not needed, and that might allow more pregnant women to get tested and get linked to care. Breastfeeding is not contraindicated, and this is again something that we need to tell these mothers, and we need to make sure that children are tested at 18 months. Similarly, for HBV, birth dose, India is making progress. Yes, we can do better, but we are making progress. HBIG in a public health system is going to be challenging, and I personally believe the same is true for antiviral treatment. Our hepatitis B rates are not that high, in my understanding, that we should go on to this form of a public health program. That's going to take away money from many other interventions, even in hepatitis, that we need much more importantly. Finally, a word about where do special groups stand in relation to the overall burden and how much effort we need to do in these groups as compared to for the whole community. This is a meta-analysis for Southeast Asia region done by Dr. Goyal, and I was also a part of that. The total burden of HCV in the special populations is listed on this slide, and it's about 0.6 million. In the rest of the low-risk population, it's about 5 million. So in special populations, there is only about 10 to 11% of the hepatitis C burden is in that group. The same is true for hepatitis B. In fact, there it will be expected to be much lower because injection drug use predisposes people much more to hepatitis C than to B. So overall, friends, there are several special populations. The principles of prevention and treatment are generally similar in these special populations. The more important issues are not medical issues, but related to access, utilization, and adherence. And these need to be addressed in a comprehensive manner. I believe that this can be done much better, not at the national level, because issues are very different at different local places. These need to be hyper-local solutions, ingenious solutions, which can come from local healthcare workers because they know the situation much better. For some subgroups, there is a special problem of HCV reinfection, so treatment will have to be followed with continuous preventive measures. And as I said in my previous slide, contribution of special populations to the overall burden of hepatitis in India is a small proportion, and our primary focus will still need to be on the general population rather than on these special populations. Thank you.
Thank you so much for such a comprehensive and clear view of special populations. So our next speaker is Dr. Kavita, who's a scientist G at the ICMR, the National Institute of Virology, and she's going to be speaking on the role of genomic epidemiology in viral hepatitis control. Please.
Yeah, so I'll be speaking mostly on the basic virology. And a lot has been said about hepatitis B and C since morning, but I don't see any information regarding hepatitis A and hepatitis E, which are enterically transmitted viruses. Though both are causing self-limiting infections, but it is a big problem in India, and I think we are overlooking. I agree that most of the deaths are caused by HBV and HCV. Almost 95% deaths are caused by HBV and HCV, but A and E cannot be overlooked. So I'll start with A and E a little bit. Hepatitis A, actually it is mild self-limiting disease. India was earlier highly endemic for this virus, and we used to have a lot of infections in early childhood, and most of these infections were subclinical, and they used to develop lifelong immunity. So this was the picture in the past, but now the scenario is changing. We are not having this universal exposure by 5 or 10 years of age. Initially or previously, these HIV infections used to be sporadic infections, but now slowly HIV infections are emerging in the outbreak format because we are transitioning from highly endemic to the intermediate or lower endemicity levels. So we are seeing outbreaks in children and in adolescents, and we all are aware that as the age increases, the severity of hepatitis A also increases. So there are many complications which are being reported, and which will eventually lead to the more severity and deaths. So coming to the genotype, since I was told to focus on the molecular epidemiology of these viruses, so genotype 3A is the predominant genotype currently circulating in India, though previously we have reported certain genotype 1A and 1B infections. So there are certain viral factors which have been attributed to the severity of hepatitis A, because since we are seeing outbreaks and severity in young adults in last maybe 5 to 10 years, we are actually trying to find out, being National Institute of Virology, we are trying to analyze the virus from the mutation point of view. And there are certain reports like 5' non-translated region of the viral genome. There are 2 reports. And they have said that there are certain changes in these regions of viral genome which could be responsible for the severity. So this is one analysis done at NIV, since NIV happens to be a nodal lab for all viral diagnostic network laboratories in India. So we have opportunity to get samples from all over the country. So what we see is now genotype 3A is the predominant genotype. And in 2024, there was one outbreak in Kerala, which was actually very huge outbreak of hepatitis A. And we did a little bit of genome level analysis, and what we see at 5' NCR level, definitely there are comparatively less changes in 5' NCR as compared to self-limiting disease. So there is something at the viral sequence level. If you compare these with the acute liver failure cases which have actually recovered, you don't see that change in these cases. So, but if you see overall genome analysis, there are no changes, the comparable changes between death cases and recovered cases. So, attributing only 5' NCR region changes to severity, it becomes difficult. So control, as far as HIV control is concerned, we know that we are transitioning, so we have to improve our sewage sanitation, sewage disposal, sanitation, good drinking quality. We have to educate our food handlers. And treatment, there is no antiviral treatment for hepatitis A currently. And there is a vaccine for hepatitis A, but we have not introduced in our extended vaccination program. And a recent sero survey conducted by NIV shows that definitely there is a transition from high endemicity to low or intermediate level endemicity. So there is a high time that we now need to introduce hepatitis A vaccination in India to prevent outbreaks in young adults and in children. So this hepatitis E virus is another fecal-orally transmitted virus. We have genotype 1 virus circulating in humans, genotype 4 in pigs. In certain neighboring countries, they have genotype 4 infections in humans also, but fortunately, we have good food habits, so we are not seeing any genotype 4 infections so far in humans. And the problem of HIV is like in pregnancy in 3rd trimester, the infection can lead to acute liver failure and severe manifestations. Death rate is also very high, up to 25 to 30%. So again, there are few viral factors which are attributed to the severity of hepatitis E, but it's very difficult to say for sure that these are the viral mutations which are responsible for severity, because it is a very complicated kind of scenario. There are certain host factors also which are very important. And as I told you, during pregnancy, severity is very high, and it's a multifactorial basically picture. It's not only cytokines or not only viral factors, but there are other nutritional status, hormonal factors, certain viral proteins are also important. So it's a complicated picture. Now, definitely we are seeing some changes, improvements in sanitation, in drinking water qualities. And now, previously we used to have huge hepatitis E virus outbreaks, which we are now definitely seeing that they are not occurring. But there is a transition from HIV to HIV. Now we are seeing HIV outbreaks. So why this? Why this is happening? This is a little bit of a surprising thing, like why HIV outbreaks are occurring, because since now naive population is increasing, children are more getting exposed to the virus, but at the same time virus is still circulating in the population. So whenever young adults and children, they get accidentally exposed to virus, they are bound to have infection and more severe infection. So in 1991 to 2010, majority outbreaks were attributed to hepatitis E, and we saw transition during 2011 to 23 from HIV to HAV. And there is a very peculiar picture, like developed states are experiencing higher proportion of HIV outbreaks because of the improvement in the sanitation and drinking water qualities. And states belonging to lower socio-economic status are still showing HIV predominance. So this is because their children are getting exposed in the early childhood, so they are immune to hepatitis A infection. But they are suffering with HIV infection. So hepatitis E control, again, we need to have proper sanitation, good drinking water quality. Vaccine, there is only one vaccine available in China. It is not introduced anywhere else so far. And there are few off-label antiviral therapies available for hepatitis C. Now coming to hepatitis B, I needn't say much. I'll just go to the molecular epidemiology. Carrier rate, we have, since morning we are hearing that it is at intermediate level in India. And the genotype, as far as the viral genotypes are concerned, genotype D is the predominant genotype which circulates in India, followed by A and then C. We are also seeing lot of mixed infection with different genotypes. There are core promoter and pre-core mutants also seen in many chronic hepatitis B infections. Occult hepatitis B infections are also very common. Almost 10% HBsAg negative chronic liver disease patients are seen. These are actually having anti-HBC antibody positivity, but they do not show HBsAg positivity. So this was a novel genotype which was detected by NIV by retrospective screening of primitive tribe samples. So it appears that primitive tribes have a different scenario than the mainland. So this is the recent picture that we since NIV received samples from all over the country. This was a screening for 12 states of India. We still see genotype D as the predominant genotype circulating in India, followed by A and then genotype C. But since we are now doing a full genome analysis, we see lot of recombinants because of the mixed HBV infections. So you would ask me why do you want to do all this analysis? To some extent, genotypes are associated with disease states. It's a sort of, again, complicated pictures. There are controversial reports. Like genotype D is associated with more severe liver disease, more prevalence in HCC patients, significantly high acute hepatitis in contrast to higher chronic hepatitis with genotype C, more frequency of basal core promoter mutations and pre-core promoter mutations. Genotype C is associated with higher viral load and the increased risk of chronic liver disease. To some extent, genotypes are also associated with the response to the therapy, like higher sustained virological response with lamivudine is obtained for genotype D than genotype A. Genotype A or mixed genotypes, they have more tendency to undergo intergenotype switch on the long-term TDF therapy compared to genotype D. Genotype genotype A is known to have negative association for long-term response to TDF therapy, lamivudine response, and YMDD mutations which occur over the period due to lamivudine treatment. Now genotype C, it has negative association with the entecavir response. So there is some association, but you cannot say for sure that you need to consider genotypes or you have to do genotyping before starting the therapy.
So sorry to interrupt, we are just running a little short on time, so if you could just...
Yeah, this is last slide. I'm not going to talk much on hepatitis C.
Thank you.
Because hepatitis C, again, we have genotype 3, which is predominant in India, and it is a comparatively difficult genotype to treat. But since we have now better pan-genotypic therapies, we needn't worry about genotyping the patients. A little bit on these response to about 5% of individuals who do not respond to the HCV therapy. Now people have done analysis of this response or resistance associated replacements or mutations in the genomes, and it is seen that there is only one study from India who have done analysis in the genotype 6, and they have shown that even if you do this mutant analysis prior to beginning of the treatment, it doesn't matter if you do or if you don't screen these patients, there is no change in the final response. So again, it is final conclusion is that there is no need of, at the current situation, there is no need of genotyping of the patients before starting the therapy.
Thank you so much. Thank you so much. That was excellent, and thank you so much for bringing hepatitis A and E into the conversation today. And our final speaker is Dr. Ray, and he's the country lead for new vaccines and immunization systems for the Bill and Melinda Gates Foundation, and he'll be speaking on overcoming barriers to vaccination for viral hepatitis. Dr. Ray.
Thank you. I am in the unenviable position of standing between you and lunch, so I would be quick changing gears from diagnostic and management to the prevention. As you are seeing on the right side of the slide, that many, even large states in India, say Maharashtra or even Kerala, they have registered decline in coverage. And much of it is contributed by not getting the birth dose to the newborns. Now, what is the reason? One reason is supply shortage. These are all newspaper snippets, but this captures the shortage mostly in the private sector. But I mean, 5-6 years back, we have also noticed, quite a bit of shortage in the public sector also, but which has been addressed by the government of India by introducing one of the supply chain solution, which is called Electronic Vaccine Intelligence Network, by which you can monitor from the manufacturer to the last mile the stock and flow of the vaccines. But the more and more participation from the private sector into the program, and if they can ensure getting the vaccines from the government if required and submitting the reports, may actually fill up the last gap in the mile. The second is, even when the vaccine is available, hepatitis B, as you are showing again on the right side of the slide, that is mostly freeze-sensitive vaccine. Now, there has been documented instances where exposure to freezing temperatures has destroyed the potency of the vaccine. Now, with the introduction of the conditioned ice packs, that means these ice packs are not hard frozen to transport the vaccines from the store to the where the vaccine would be administered, you can reduce. There are also technologies that have come where the sensors are put into the storage as well as in the transport, whereby you can actually monitor constantly the temperature and other parameters which can affect the vaccine potency. The third issue and the most important issue is the delivery of the birth dose. Now, there are many studies which have actually documented even as latest as in 23, there are still gaps where we are not being able to administer the hepatitis B birth doses. This is a quick dipstick assessment from the largest state in the India, Uttar Pradesh, where you can see that one of the main challenges that if you have to administer the birth doses to the newborn, even at the institutions, the labor room nurses need to administer it instead of the traditional ANMs or immunization nurses at the immunization clinics, because you have to administer the birth dose within 24 hours. So that's, so that's a challenge. Now there has been protocols and policies and programmatic intervention which have been put by different state governments as well as in the guidelines of the national government to address that, so that the labor room nurses get trained and the parents also get aware, and labor rooms should have also ideally a storage where they can have enough stock of the hepatitis B vaccine, so that the vaccines actually can administer the newborn not by any kind of pro rata predetermined roster, but by as the birth occurs. But of course, that's not happening in all places, and that has also been contributed by lack of parental awareness. One study, there are multiple studies, so I've just summarized a couple of them. You can see that 40 to 70% of parents are not actually aware about what causes hepatitis B, not aware about the disease, so they don't feel the urgency or the need of getting their babies vaccinated. And only even 8% of those parents are only aware about that, okay, at least 3 doses are required, discounting the hepatitis birth dose. And the hepatitis B birth dose is they're even unaware of, because they're not getting delivered, and the awareness is not being created by the frontline workers. This is changing along with the training and repeated messaging, but it's difficult. One of the significant challenge in hepatitis B birth dose delivery is also that it is paired with other birth doses, which are BCG and OPV. Now, BCG birth dose, as per GOI guidelines, you can get it even up to 1 year of age. And the OPV, you can get up to 2 weeks of age. Now, pairing them with the hepatitis B birth dose may lead potentially to missing that golden 24 hours. There are other challenges related to health infrastructure and workforce, both in terms of availability and their training and their updation of guidelines, policy implementation gaps, even when there are policies and programs, how much those have been implemented, that varies from districts to district. There is, the surveillance is also not that, I would say, agile to actually have enough data at your fingertips to do proper risk and benefit communication. Indigenous and rural communities who are marginalized and who are deprived or who are part of multiple deprivation problem, hepatitis vaccination is not an exception. There are also myths and misconceptions which are associated with generically with other vaccines, may also impact the uptake of hepatitis B. Because hepatitis B 1 to 3 are also tagged with other 4 vaccines. So it's a pentavalent vaccine. If you are missing 1 dose, you are missing 5 vaccines. So, and as we know that Penta 1 vaccine is also known to cause the most injection pain, which is one of the major deterrent for the parents to get the vaccines. There is also less uptake in the private sector. I've already said there are not much data, but there is one study which have shown only around 5% of hepatitis B and 4% of hepatitis A vaccination in the private sector. Kerala has tried something of hepatitis A. It's available in the private sector. There has been discussion in NITAC couple of times about having good surveillance data to establish overall public health value proposition and cost effectiveness so as to consider its inclusion. But of course, there are higher priorities and more prevalent and important critical diseases against which more effective vaccines are available. So hepatitis A still not is part of the program. Hepatitis C, just for the sake of completeness, the only licensed vaccine, as you know, is from China, but ICMR has invested in development of hepatitis C vaccine and completed animal studies and going into clinical trials. So there are multiple strategies, some of which I have already said. I'm not trying to take your more time by reading out. I will just mention a couple of things that India is going to or is already actually implementing the largest name-based immunization registry, which is called UWIN, which will track every birth and the birth doses of this vaccine with their timings. If that data becomes available to all the frontline workers and program managers and policy people, it will be much easier to track the performance of the vaccination program in terms of coverage. And it's also linked interoperably with the EVIN, which is the vaccine supply side. So the vaccine consumption data can be actually calibrated against the vaccine coverage data, and that may give you a much more granular visibility and improve the performance. There are innovative technologies people talked about earlier. There has been theoretical constructs about oral and aerosol vaccines of hepatitis B, but as we know of the size of the surface antigen and other difficulties have not been able to. There is one, I'm skipping this slide, one interesting case study from Indonesia where they tried pre-filled hepatitis B syringes to administer the vaccine door to door within 24 hours. Now with examples of vaccine on wheels in India and mobile medical units and the concerted efforts to reach the zero-dose population, particularly in marginalized geographies, there might be some scope and opportunity to explore those kinds of things, provided these don't override, and as Dr. Rakesh also mentioned, there is also an opportunity cost. The moment we spend something on an intervention, that means it's taking away from something from other. This is a study which shows actually the decline of the seroprotection, where under 3 years, 100% of the children have the protective level of more than 10 international unit per liter antibody. It declines very steeply, and at 10 years, only 40% of them have the protective level. Now, whether that means do we require a booster dose? China has it at 10 years. GUI has a program of vaccinating the health workers free of cost, but we don't have a booster dose. I'll leave you with that question. Thank you.
Thank you so much. And thank you for highlighting the possibilities of delivery of the birth dose outside of healthcare settings, because I think that's so important in so many countries. So we are over time, but we can allow just a couple of very short questions or comments from the audience. But please be succinct, because we want to have lunch. Thank you.
Thank you to all the speakers. I'm Dr. Amudan. I'm coming from Microbiology Department, Government Theory Medical College, Tamil Nadu. This question is to the special population, Rakesh sir. Sir, what's your take on these dialysis patients? I think, did I miss or something? The screening of the dialysis patients for HCV and HCV.
So, dialysis patients are at a higher risk of infection, particularly with hepatitis C virus infection. I didn't address that because most of that happens in the hospital setting, and those are looked after by the specialists, and here we are trying to focus on a more community-oriented thing. There are basically the best method to prevent is adherence to safe practices, infection control practices, that is the best, and then they need to be periodically tested. Each unit has its own protocol. Those protocols vary between countries, between institutions, and it also depends on what is the source of infection in each unit, and that needs to be taken into account. And then you have to treat them as acute HCV. The other thing is whether you treat HCV before transplant or after transplant. Today the belief is that it is best to treat this after the renal transplant has been done.
So is it integrated with the NVHCP program, the dialysis in the HRG group?
I don't have much idea of the dialysis program, so I really don't know. People are supposed to do it. The question really comes to implementation rather than whether policies exist. That is the most important issue.
Great,
Thank you. One last question. So, I said Dr. Kavita said HAV hepatitis A is an outbreak. Ma'am, I beg to differ. This is not an outbreak, ma'am, because this is being endemic. So I come from a district where we are constantly reporting hepatitis A for the past 6-7 years, and we have a manuscript in work. Thank you.
So is that a question? Oh, sorry. Okay. Okay. Pauline.
So this is, thank you very much for the panel and addressing the complexities. I would like to address the question to ICMR and whether ICMR is actually looking into the pipeline of hepatitis B cure. Because recently there has been a very interesting publication from Chinese researchers that actually looked at drug cure for hepatitis B, functional cure at least. So they found an RNA molecule in that space. And while it may be very early, but it still means that there is a whole research area that really looks into hepatitis B cure. Thank you.
Many things are going on for hepatitis B cure, like microRNA therapy, other things, many things are going on. But as of now, none of them are approved, have reached to the clinical trial phase 3, even clinical trial level, probably phase 1, phase 2 something. So it's not the right forum to talk about that kind of therapy. That's why I have not talked about.
Then thank you. John?
Thank you. Excellent panel. I learned a lot in the last hour. I just wanted to extend the discussion that was opened by Dr. Ray regarding the seroprotection following Hep B vaccination. You do indeed lose antibody levels progressively year to year after a 3-dose completion of hepatitis B vaccination. Below what's considered to be a seroprotective level. However, when you challenge those individuals again, they'll develop an amnestic response to Hep B vaccination, indicating that the cellular side of the immune system has immune memory, and so that protection continues even though that antibody level suggests otherwise. And in long-term studies in Thailand and in Alaska in the United States, the data indicates that protection lasts for at least 35 to upwards of 40 years. So I just wanted to add that body of evidence to the discussion. Thank you.
Thank you so much.
Thanks, John, for, I think, adding that. Otherwise, I was planning to comment on that. We don't need boosters for general population.
Great. RPS, did you want to?
A couple of questions quickly. To Dr. Rakesh, you have not mentioned about malignancy and viral treatments.
Sir, I did include that in the first slide where I said what are special groups. Immunosuppressed people was included there, but I said I'm not going to address that. 7 minutes, you need to choose.
Okay.
Otherwise, you would have told me that.
I know. This is Dr. Goyal. Combined infections, hepatitis B and C, which one you prefer to treat based on viral load or any other reason?
No, there is a clear-cut guideline. If we have B and C co-infection, first we have to treat hepatitis C, wait for SVR, and then treat for HBV because of 2 reasons. One, in presence of HCV infection, HBV replication is suppressed. So you will not get the real picture of DNA load. Most of the time, DNA will remain undetectable. So first, we have to finish and clear the HCV treatment and let the virus surface up and show whether it is replicating or not. And the second reason is HBV treatment even today is largely dependent on serum ALT level. Rise in ALT will be contributed by 2 viruses, B and C. We may get a false picture. So first let the one agent get out and get the real cause for ALT elevation, how much it is contributed by hepatitis B. And anyway, third, what I believe that one treatment is over, at least patient get a mental satisfaction that he is get rid of one virus.
To add to that, sir, if you are clear that hepatitis B also needs treatment, for instance, if a person has cirrhosis and has both hepatitis B and C, you would possibly, and because they are irrespective of viral load you'll be treating, then you should start treatment for both simultaneously. Thank you.
Great, thank you all so much. So we'll just finish with one quick fire round for all the panelists. So very quickly, in like 30 seconds, in the area of your talk, what's one thing that you think would make the biggest difference in India for hepatitis elimination? Like what one thing in testing, what one thing in vaccination? Okay, very quickly, thank you.
For testing, decentralizing testing with reflex molecular testing for HCV, but under, very importantly, quality testing.
Yeah, I think as I mentioned, the EWIN under implementation should be a game changer to track the performance, along with the EWIN, which can actually boost the entire supply chain. I will say also complemented by the liver room nurses training, and their performance probably would be able to deliver the blood doses.
Excellent, thank you.
In the special populations, the maximum burden is people who inject drugs. So really we need to educate those people that they need to get tested and linked to care. Unless we engage with them, will not make an impact. So we need to engage with them. Thank you.
I'll speak more on hepatitis A and E. For hepatitis A, definitely we need a vaccine. For E, we need to think of developing some indigenous antiviral therapy, especially for a high-risk group. I won't comment on B and C because a lot has been said.
So in my opinion, for success of program, we need two things. One is the involvement of academicians, means the medical colleges, because we are generating more than 1 lakh MBBS student every year, so that we are training those who are in job, but not training them who are in training of medical science. That is one thing. And second, we should promote research in hepatitis so that innovation can come up. Otherwise, there will not be innovation in treatment modalities. We will just be a good follower of the available literature.
Thank you. And thank you to all our panelists. I've learned so much. So let's give a round of applause for our fantastic panel. And I think there we go. Just really quickly, we'd just like to make an important announcement. So the World Hepatitis Summit is coming to Asia, is coming to Southeast Asia in 2026. And we're very happy to announce the dates of the 28th to the 30th of April 2026 in Bangkok, Thailand. So I think you'll find some cards on the tables. You can enter a free competition to win a free registration. And we hope to see you all there. But now please enjoy your lunch and we'll see you this afternoon. Thank you.
Thank you so much. If we can have Mr. Carey James do the honors and present our panel with a token of our appreciation. Can we give our moderator and our panelists a big round of applause, ladies and gentlemen? Those of you heading out for lunch, please don't forget to put up your posters and also collect your certificates from the registration desk. And requesting Dr. Agarwal to do the honors and present a token of appreciation to Mr. James. Thank you so much, ladies and gentlemen. Requesting everyone to please join us for lunch in the designated area. And we'll see all of you back here in the hall at 2:30 p.m. Thank you so much. Have a wonderful lunch. explore the key themes of viral hepatitis care, from tackling stigma, discrimination, to uncovering opportunities for integrated care models and the latest innovations in the field. So let's keep the momentum going as we move forward. We're now ready to begin session 4, a panel discussion on combating stigma and discrimination in viral hepatitis. Please put your hands together and welcome our moderator on stage. We have with us Ms. Jessica Hicks, Director of the World Hepatitis Alliance. Can we give her a big hand? She leads WHA's global initiatives for viral hepatitis elimination by the year 2030. I'd also like to welcome our panelists, Mr. Anil Parmar, Dr. R. Tara, Ms. Kausalya Periyasamy, and Sharon D'Souza. Welcome.
Hello, good afternoon, everyone. Thank you for coming back so promptly after the lunch break. I hope you all have had something to eat. I'm really delighted to be here on behalf of the World Hepatitis Alliance and would like to thank the Chennai Liver Foundation and the organizing committee for inviting me to chair this really important panel discussion today. You know, stigma and discrimination has come up across the presentations this morning, both as a barrier to elimination and also as a priority area for action. And I think importantly, one of the things that hasn't been discussed yet around stigma and discrimination, but I'm sure we will discuss it in length across the panel, is really the devastating impact that stigma and discrimination has on people living with viral hepatitis. This is an area that the World Hepatitis Alliance are incredibly passionate about, and it's a priority area for us. It's not a problem just in India, it truly is a global problem. And picking up on some of the conversations this morning around data, it's an issue where we have very much little to no data. And so to help address this, the Alliance piloted last year a hepatitis stigma watch in 9 European countries, which looked at stigma and discrimination experienced by people living with hepatitis B and C. And the results from that were quite startling. It really did highlight that people living with viral hepatitis are impacted by stigma and discrimination in every aspect of their life, from how they feel about themselves, how they interact with family and friends, and their healthcare seeking behaviors, you know, often delaying accessing treatment or doctor's visits because of how they fear that they will be treated. And so, as I said, we piloted that in Europe. Our plans for this year are to roll this out globally, and I really hope that we'll be able to partner with everyone in this room to gather the data in India, because while it's a global problem, we need local data and local solutions, and that's what we're going to hear about on the panel today. So I'm delighted to be joined by my 4 esteemed panelists who are going to talk about the work they're doing around combating stigma and discrimination in India. And so, with no further ado, I'll hand over to Mr. Anil Parmar, who's our first speaker for today.
Good afternoon, everyone. I represent a non-profit called United Way Mumbai. We work on hepatitis B and C across length and breadth of city of Mumbai. Most of our work is concentrated in slum communities where knowledge, awareness on hepatitis B and C, or screening methods or vaccination platforms are rarity in those kind of communities. And we work there to make people understand, acknowledge that hepatitis B and C are chronic issues that need to be addressed and need to be aware about. I must be candid and tell you that I am not a medical practitioner. I'm a community health practitioner in that sense. I have tremendous passion on community health, and that's why we are working on hepatitis B and C. My presentation as well, you will see, has no graphs, no data. There are no technical terms as such, because where we work, the kind of people that we work with, possibly may not relate to that kind of data or graphs or tables. And that's why our language is quite simple. Language is based on the community or the culture that we operate in. And that's what I'll like to present to you. Stigma, we all are aware why. We all know why we need to work on this. The presentation will focus on how of it, what we are doing on this, and share a bit of our learnings and experiences, and dare I say, our failures as well, because that is important for all of us to talk and learn from each other. So the theme of the session is investing in communities to address stigma and discrimination. How that looks like is what I'll try and cover. I'll try and cover this through visuals, and as I said, there are no graphs. These are some visuals only. If you see this visual, it has few women in a community, few of our team members working, and then right across that is a landfill site in Mumbai. What I mean by landfill site is where the waste is collected in the city's waste is collected, and this particular venue, or the dumping ground as we call it in a layman's term, has a lot of needles and syringes. There are people who go and segregate this waste, come in contact with those needles and syringes or any kind of waste really in the city, and that can be an infection, a practice that can really get them contaminated as well. And this is where we talk about hepatitis B and C. Here, the language really talks about is from the perspective of the community. So we don't really say hepatitis B and C. We don't say HBV, HCV. We talk about pilia. Pilia in Hindi means kind of is related to hepatitis B and C. And then we go and explain people about what pilia is really, what kind of causes, what kind of factors are there to cause this, and how do we prevent ourselves from getting infected. Here we use local language, as I said, and the context also, the wording that is used is also community specific. So nothing alien that really alienates the community from listening to what we are saying. And that really helps us to get attention and get some kind of relevance among the community members that we talk to. So that's one of the visuals, and I think that's one major input or learning that we can share with you, is that we need to make our awareness generation, we need to educate our communities and meet them where they are, help them understand in the language and the wording in which they will understand or they want to understand on this kind of chronic issues. The other piece is, and we've been talking about this since last evening really, is that the government has come up with the national viral hepatitis control program, and it has centralized a lot of testing, screening, treatment and things like that. But what has really happened is that the community has not warmed up to this concept, because it requires the communities go to a hospital which is far off. It means loss of wages if they are going on that for that day, and there are many other socio-economic factors. Again, the question that we asked was, why not meet community where they are? And we took the screening process or the camps in the communities where the members are, and we saw a turnaround. We saw that the government's resources were now being fully utilized. The camps are being done in partnership with the government, and it is being done where the communities are, and that has really changed the game for us as well. And in this, when we do this in the communities, it is being done for everybody. So if there are 100 members in the communities, everybody is invited, everybody is welcome and convinced to come and do the screening. This also reduces stigma. It also helps people realize that there are 99 people like me who are going for testing, so it's nothing that I need to be worried about or need to be discriminated upon. And that really helps us to reduce and break the barriers related to stigma here. The other piece is, again, as I said, we talk to everybody about hepatitis B and C, and we try and improve the health-seeking behavior. How do we do this? Is we try and make sure that whenever they have any kind of symptoms related to the disease, they are accessing quality healthcare, which is provided by the government or by private players as well. And this is done through door-to-door visits, through one-to-one interactions with the community members as well. It is personalized for each community member. It's not a mass awareness message that is being given, but it is curated to an individual who is in that community, specific for that individual, so that they can relate to it and have more acceptability behind this as well. This is a critical piece which is on treatment support and patient support groups. We've heard a lot about patient support groups, and there are global case studies on this. But the more we localize this, especially in a country like India, which is super diverse, every 100 kilometers, culture may change, language may change, the kind of food we eat may change. We need to localize how these support groups will look like. In our case, our patient support groups are done in the community, in a community hall, in a temple or a mosque or a church, whatever is available and whatever is acceptable for the communities to come and have a chat about. Here we have an interaction. We try and make sure that each person has a chance to speak and share whatever challenges that they may be facing. And the patient support groups also are extended to the families of people who are positive as well, to make sure that the family members know how to create an enabling environment for the family members that they have. And through this, we are able to reduce the stigma and make sure that the discrimination part is taken care of within the communities. These may look like softer interventions. Of course, these are softer interventions, but there are concrete data and verifiable indicator for each of this when we have seen incidences of discrimination or stigmatization have completely come down, visibly have come down, and the patients and the community members have come back reporting positive behavior towards them in that particular community. In this, I think the parting shot would be from our end would be that we need to normalize, regularize, and possibly, dare I say, humanize the disease as well. We need to meet where the communities are and talk to them in the language that they prefer and that they would want to understand. And I think that way, there is a clear pathway to reduce stigma and make sure that there is investment coming into that particular challenge. Thank you so much.
Thank you so much, Anil. A really important message there around educating communities to reduce stigma, and I think that's a really critical message. So I'd now like to invite Dr. Tara, who's the Vice Chairman of the Schizophrenia Research Foundation, to present.
Good afternoon. I'll talk very briefly about how the mind plays a very important role in hepatitis, as it does in many other physical illnesses. So I'm sure many of you are aware of this because you are the people who are actually seeing persons with hepatitis. Depression is extremely common, up to 30%, and it is more in people who use intravenous drugs, and definitely more in those on methadone maintenance. There's a whole lot of literature on depression and methadone maintenance. And what was depression associated with? Poorer work and social adjustment, lower acceptance of the illness, higher stigma, poorer reported thinking and concentration, that is what we call cognitive functioning, and higher levels of subjective physical symptoms. When I say subjective, it is what psychiatrists call somatization. There may not be an actual disorder underlying the physical symptom, but they will be complaining of headaches and abdominal pains and so on. And it has been also reported largely from the West that interferon that is used in treatment can also cause depression. Anxiety disorders have not been studied much, but there is a 25% prevalence. And what is really unfortunate is a large part of this depression and anxiety has been undiagnosed because people don't really report them. And very often it coexists with depression. When it comes to severe mental illnesses like schizophrenia or bipolar, they are less likely to be aware of HCV, screening, diagnostic confirmation, referral to treatment, and they face many, many barriers in successful treatment. The prevalence of HCV in people with severe mental illness in the West is as high as 30%. But like he was saying, we do not have data from India largely because we don't really see people with intravenous drug abuse. They don't come for treatment. Many of them do not seek help at all, until they develop a severe crisis. Therefore, the prevalence of blood-borne viruses, including HCV, is consistently higher in patients with severe mental illness. And again, it often remains undetected. that is a role that community psychiatrists have to reevaluate how they can really manage patients in schizophrenia who have HCV. I must tell you that we have been running the Schizophrenia Research Foundation for the last 40 years. It's a WHO collaborating center for mental health research and training. But we have done HCV testing only on 5 patients. So, I mean, that is the amount of awareness that many psychiatrists, why psychiatrists, even medical professionals have about HCV and its relationship with mental disorders. And what is a stigma? Like, in the olden days, we spoke about leprosy. Leprosy was a condition that was grossly stigmatized, but we all know that the stigma has come down. Wherever the disorder is thought to be contagious, severe, and there are always magico-religious models like karma, curse, family, enmity, and so on. All this has always been associated with stigma. But what is really important is, I was reading a whole lot of papers for the first time in my life about hepatitis, and what I read was that the healthcare setting, the people in the healthcare setting obviously do things that increase the stigma. For example, it's extreme caution, the patients are not seen on time, there are procedural delays, and there is also social stigma like exclusion. A paper from India has reported that there have been marriage rejections when people have found out that person has hepatitis. I mean, when you say mental illness, I'm not surprised, but this is possibly true of marriage as well. And the global study has shown that discrimination was work-related. If you write in your visa form that you have hepatitis, then many times you have been denied the visa. So that is something that all of you need to keep in mind. But it is always to report or not to report, you know, what's the right thing to do. And also in educational institutions, there's been a lot of stigma. And the emotional impact itself of the hepatitis has been huge. There's no time to go into why it is so, but that is what it is. And it will be good if all of you keep this in mind when you actually talk to your patients and talk to the families. So what is the role of mental health professionals? HCV, as I said, is very common in IVD users, but at least in India, we do not see in our clinics many IVD users. They do not come to us. They don't want to get rid of the habit. So we don't really see them unless things really get very bad. So there is hardly any data from India, which is very sad, because I think when things are so prevalent, we should be able to get some data, and I hope as an offshoot of this conference, we will be able to generate something here. And we definitely need increased awareness among mental health professionals. I can tell you 80% of psychiatrists know nothing about hepatitis. I mean, broadly, yes, but really nothing about HCV and its relationship to mental illness. Therefore, we have to look at regular screening for HIVs in OPDs and de-addiction centers, and also be aware of the fact that interferon therapy can cause depression and even suicidal ideation. And about 10 years ago, a lot of antidepressants like SSRIs have been tried. But again, I have no experience with the new antiviral agents, but I believe they have reduced the side effects of depression. You will know better about this. So we really need integrated community mental health settings are ideal. And the challenge in treatment is how do we get these people to take treatment? Because it's a daily regimen, as you know. So psychiatrists can play an active role in screening at-risk patients and collaborate with medical and other treatment teams. This is just for you. For those of you who have not seen this paper in the Lancet of 2015, look at the green line, which is the HCV care continuum among persons who have used intravenous drugs. I mean, it's practically nil. You know, that's what I'm trying to say, that there is no identification, there is no detection, and there is no treatment. So it would be really good if some of you got together. We are prepared to help, but we should, I think, generate some data. We should look at the mental health spectrum and what can be done towards improving the mental health of people with hepatitis. Thank you again for this opportunity, and thanks a lot.
Thank you so much. And I think really important points raised there around the intersectionality between hepatitis, stigma, and mental health, which really isn't discussed enough. So now I'd like to invite Ms. Kushulia Periasamy, who's the founder of the Positive Woman Network, to share her presentation.
Good afternoon. Thank you for giving me this opportunity. I can share about the stigma for the HIV and then hepatitis, how it is actually affecting for both of them, and mainly for women. The women often in the program itself actually discriminating us, because it is only targeted populations. When we don't have a IDUs habit, or we don't have any risk populations of whatever says in the cascade of testing. So then we are actually not targeted for testing itself and giving awareness itself. That itself for HIV or Hep C, both is actually for knowledge sharing to the community. For women, it is lacking. So we needed in the knowledge for how it's affecting. Then only we can able to take care of our family, ourselves. Like only the women are seeing it in the pregnancy and delivery part. Beyond that, the women, also the health of women are not seeing it as such. So that is actually for, I say it is a discriminating in the program for us. Another thing is for healthcare sector, already ma'am says HIV or Hep C. When there is going to the hospitals, the discriminations happen. Both the disease when the person has, so there is a dual discriminations of any healthcare setups, it is happening. So that's a women says. And yesterday we had a discussion with Manipur, Mizoram, and then for UP, and then we had it in Tamil Nadu. So almost 7-8 states, the women are participated for to preparing coming for me to this meeting. So I prepared myself for all the women. We had a discussion. So I can share some of the things what they said. The treatment access, already they said it is actually for either medical college, that's far away. When there is a state 1 or 2, it is actually very far away to reach them to get the treatment for Hep C. Until that time, to testing, investigation, so the women are going to die. So that's a situation. Even HIV previously happened. So same thing it is actually happening. So how it can be local level, like how the Punjab, they are doing it for pilot project. So how it will reach to other part of country. And Mizoram, they said there is a testing availability is there, but when it comes to the HIV and the drug user community, for the treatment, because you say it is actually for adhere to treatment, but they need a treatment, otherwise they cannot live with it. How they can be motivated to adhere, or they, how they can be a part of this program to get the treatment at least. Otherwise, it lead to death. So when you are actually saying resistant or something else, but the thing is, we are not getting treatment also, it is discriminating us. So that's another point. And then the rehabilitation center for women, it is only 2 centers are available in nationally. for drug rehabilitation center. And alcohol rehabilitation center, there is only hardly says it is paid one available, no free. So it is actually for, that's also needed when there is actually for, when you are now more alcohol habit is there for everyone. So there is no availability, then you cannot able to see even targeted community, whatever accessibility, treatment of Hep C. So this is actually for one of the lack of this things, and also discriminating for when you don't have a facility, then there is actually for you are neglecting us. So that's another one more things. It's very old. When we had a program with UNODC in 2009, 2003, that time we advocated for a women drug user rehabilitation center. So that stands as it is. So please, actually, for the government should also think about it, to how you can extend this facility to other places. And the treatment part of, we heard about in the morning for pregnancy women. There is one woman shared about in Mizoram. She is actually for 2009 she tested. Her son is actually in the tummy in that time. So they given medicines and they are able to now free from Hep C. So this is actually for maybe some study or something is happening, but we needed in the some fast results. So that how can be connected with whatever you are saying, like HIV, PMTC, EMTCT program, and this how can we connect, and whatever merging the program, and how without discriminating us also very important, because everything when we are talking in HIV for transmission, we are not talking about it. We are only talking about for high risk sex. So that's a thing made us discriminating in the community. Because everybody was actually think about only for targeted community. That's why the beyond that it is not actually going ahead of the program. Still some infection increasing, some reducing. So this how you like. I'm happy when I saw the morning says that everybody should reach Hep C. Testing and also treatment. So this is actually for me, it's happy of sign. This way, it might be help us also for HIV program, not to be discriminated and women to know about HIV, know about Hep C. So that's actually a happy of sign. So if you have any questions, answers, so I can able to answer it more. There is 13 things we are actually, the women says, almost I said everything, but the prevention part of Hep C vaccine is how can be given to positive people. So we saw here some dialogue, some dilemma, but even though there is actually 2-3 hepatitis virus can be preventable. So how vaccine can be helped to not getting HIV positive people on Hep C. So in the not risk population, or at-risk population, whatever. So both the people to get the vaccine is important for us. So that's one point. I don't want to miss it. So one of our guy in young person here, and he said, and you had to say. So I said that also. So thank you. If you have any questions, so then I can participate there. Thank you.
Thank you so much, and really important to share the unique challenges that women can face and the impact of that. We will have time, hopefully quite a bit of time for a good Q&A. We do have one final speaker though, which I'm very much looking forward to hearing from. So I'll invite Sharon D'Souza, who's the Assistant Research Coordinator at I Hear Sangath.
All right. I don't think I know how to use this clicker. Okay, got it. And this is back. Okay, thank you. Sorry. All right, so my name is Sharon, and I'm going to take you through some of the findings of a study called Vaccine Equity that is looking at the challenges that the transgender and the disability community faced in accessing the COVID-19 vaccine, and hopefully some of the information will be transferable in the hepatitis context. So while this study was done in the COVID-19 context, the two communities are also relevant to the hepatitis context. Among the transgender community, there is a high prevalence of HIV, sex work, drug use, precarious housing, homelessness that make them vulnerable. Within the disability community, some disabilities like intellectual disability, comorbidities like blood disorders, hemophilia, thalassemia, people on immunosuppressive therapies, cancer, kidney failure are also risk groups. But also disability is also an intersection with other high-risk groups. Disabled people, people with HIV are also, can also be disabled, and so on. In addition, both these communities also have a pronounced challenge in accessing healthcare due to inaccessibility, neglect, stigma, and discrimination. All right, so therefore a targeted approach is necessary for a multi-pronged approach, equitable approach. So the vaccine equity study is hosted at I Hear Sangath, and it looks to understand the structural barriers to vaccine access, COVID-19 vaccine access among the disability and trans community. And we are also currently working on a project where we draw on those findings, and we are adapting the behavioral and social drivers of vaccination framework by the WHO to include unique challenges that the disability, trans, and intersex community face. But my presentation today will focus on Vaccine Equity 1, which is the qualitative findings. And also the important role of lived experience, the three approaches, three mechanisms through which we used a community-based participatory approach in this study was that we were not only focusing on understanding the challenges of the trans and disability community, the community members were leading the research as consultants, as advisors, as researchers throughout the lifespan of the study. All right, so what did we learn? So the first thing is that from the perspective of the communities, they were not adequately prioritized, and they were seen as an afterthought in the programming. Another challenge that came up was when there are marginalizations, especially socioeconomic challenges to sustenance, then I think somebody mentioned it in the morning as well, then thinking about the vaccine is very different. So one thing that we heard was that from somebody from the Hijra community shared that I didn't have money to get a gas cylinder, so I'm not going to be thinking about a vaccination, which makes complete sense. Then another key important thing for these two communities was they had questions about how the vaccine might interact with their specific health needs. So their specific disabilities, and also for trans people, people on hormone therapy, how that might interact, people on ART, how that might interact with the vaccine. And there was a vacuum of information, and people were not really sure about what the impact might be. So there were questions about safety, which were not about the fact that they don't believe in the vaccine, but the fact that there isn't enough information about my specific health needs. Moving on, there was challenges in trust because we noted that a lot of the trust in vaccines was related to trust in government, trust in healthcare systems, trust in pharmaceutical industries. And for these communities who have had a historical experience of being marginalized within the healthcare system, there was a sort of deterioration in trust and therefore trust in the vaccine itself. Now I'm going to come to some programmatic design. So we just discussed on what all goes in people's minds when we're thinking about deciding whether or not to take the vaccine. But when a person is decided to take the vaccine, we noted that a lot of barriers come forth there as well. So the first thing was that the platform through which, the digital platform through which the COVID vaccine was administered, platform was not accessible for persons with visual impairment, persons with cerebral palsy, persons with intellectual disability, and they had to depend on their caregivers for that. Then there was also a need for mandatory ID cards, and it was only later that there were protocols for non-mandatory ID card vaccination. A key problem for the trans community was that a lot of people got their first dose in their dead name, and then they got their TGID card, and then they had their name, and they were not allowed to get the second dose. So there is willingness, but the system is not incorporating the lived realities of trans people. Then, of course, there's transport in terms of course, accessibility, like accessible transport for persons with disability, but also the cost that is involved. Vaccination centers themselves were not, the infrastructure was not disability accessible, and a lot of the organizing was binary. Of course, washrooms are one example, but the queues as well. There were somehow gendered queues for registration for vaccination. Then, even though at some point in 2021 we had a home vaccination program, lots of people with disabilities said that it was almost impossible to avail that service. And finally, on mistreatment, a lot of people were denied services and even denied entry into the vaccination space because they were presumed to be trans or they were presumed to be disabled and at an intersection of a caste minority. So those were certainly experiences, but there was also a lot of anticipated stigma where people were, because of their negative past experiences, were averse to going to these centers. But there are sort of positive stories that came across as well, and I'd just like to highlight a few. That the key thing here was partnerships, collaboration with doctors, community members to, I think, like you said, counsel and do community work to talk about the vaccine. Set up, and a lot of these programs were responsive to the needs of the community. So for example, a community of trans people and sex workers could not leave their work duties, so the vaccination was set up in the evening or some other time. One example, of course, I think somebody shared earlier was Vaccine on Wheels, which is a mobile vaccination unit. On top is Kanchan Sendre. She's a trans woman from Chhattisgarh who worked with hundreds of people, hundreds of trans people to counsel them and support them in taking vaccines, sometimes even accompanying them to the vaccination center. And in the, now coming to the hepatitis context, on the top, the picture is Turi, an NGO in Chennai itself who did a vaccination drive for the trans community in collaboration with a local hospital. So I think I've covered mostly everything, but to conclude, some recommendations is one on sort of vaccine communication, to have it be in accessible formats and in sensitive language. And a key part of this, and I think one key way in which this vaccine, the Hep B vaccine, is different from the COVID vaccine is that there is a lot of stigma, especially in trans communities. So definitely counseling and peer support that is individualized is one way, and destigmatizing campaigns. But also that question of like, how do these things interact with our specific health needs also needs to be addressed. Any digital portals that we might use, we might want to think about making them universally accessible for people with disabilities, people with visual impairment. And also, of course, non-ID card protocols for vaccination among tribal communities is also a community where like a lot of people brought up in the morning, and there are challenges to accessing ID cards. Yeah, so I think this thing calls for a larger reform of the health system. So a lot of the health system is ableist, is transphobic, and that's why vaccination systems are also transphobic and ableist. So reforming structures and infrastructure within the trans community, within the healthcare infrastructure, and ensuring vaccinations go close to people and not the other way around, especially when the cost of coming to the vaccine is so high in these communities. So transport is something that, and of course, sensitization of not just people who are vaccinating, but also administrative staff, because in one example, the guard didn't allow the person to come inside. And also to continue to use participatory research to see what the Hep B vaccine means to these communities, and use that to design communication campaigns. So finally, I think these communities are deeply underserved, and access to vaccinations is one of their issues, and we need like consistent investment into these communities' well-being and access outside of vaccination to be able to facilitate vaccination. And people have mentioned it before, but multi-sectoral partnerships between the state and the community, with the community in the forefront, and also to recognize the vulnerability of these groups, which are sort of not often talked about. I would also like to just thank everyone that was involved. I'm representing a big team and a lot of participants who spoke to us about their experience. So thank you so much. And the full paper is here. You can scan it if you want.
Thank you so much. It's always really great to hear and learn from other areas, and I think there's a lot of really applicable lessons learned there. So we do have time for questions now. So please come forward to the microphones if you've got any questions. Great, I can see people moving. Dr. Rakesh?
I think all the speakers raised very pertinent issues which need action. I have a question to Shireen, and which is slightly off track. So one is increasingly finding that these groups, the special groups, are wanting sometimes special schedules for them. For instance, for hepatitis B, that we are not okay with 016, we want a very fast schedule, which may be fine, but the other way to look at it is, the moment you move from a regular schedule, it's also challenging for the health system. And if they have been injecting for a long time, and you are starting today, how important it is to really get a very quick response. Did you in some way look at whether the schedules being different was something important for them, and how do they view this? I know I'm asking a very specific question.
Hello. With respect to the Hep B schedule, our study focused on the COVID-19 vaccine, so no, I would not be the right person to ask. But with respect to the schedule of the COVID-19 vaccine, definitely more than one dose means like the motivation to get another dose will go down. And especially in people who have multiple marginalizations, they find it extremely hard to take out time from work, etc. And I think it is difficult for the government machinery, which is why I think partnerships are really necessary. So I think that kind of infrastructure sometimes, that kind of initiative sometimes is not possible. So I saw a lot of examples where district immunization officers partnered with community-based organizations and sort of gave them more power. So there was power sharing and complete support in terms of providing the vaccine whenever it is needed. So I think those models similar to something that...
Thank you.
I'll just add into this, just a quick point on this. We've done 25,000 odd adult vaccinations on this, and looking at special groups as well in this part. We've come across very few incidences where they've asked for a customized immunization schedule as well. So we've not experienced that, but wherever we have, the DIOs have been participatory and have come forward and made the changes required in the infrastructure and the resources. So that has really helped. But it has not been, it's been an exception and not the rule in most cases. Thank you.
Rachel?
Yeah, I've also spoken to a lot of transphobic DIOs, so yeah.
Sorry, first of all, I want to say thank you to everybody. Fantastic presentations, really important, and it kind of makes me really sad that, that the impact that all the different groups, when we hear it, it makes me feel really sad that there are groups of people across society, across the world, who don't have equal access to medicines, and that there are stigma. So I just had one comment, which was, whilst there's a broad breadth here, one of the things that wasn't mentioned was the interdisease stigma. So for people with HIV, the stigma between HIV and Hep C for people affected, I think it doesn't get discussed, and actually it's really quite real, and we should acknowledge it. We need to say it, because that's particularly, I think, with the MSM, men who have sex with men population, because that's what we're finding is, particularly with PrEP, is that more men are becoming infected with hepatitis C, because PrEP means that, this safer sex is not so common. But the question I wanted to ask really was that so when we're talking about stigma's ignorance. So how do you combat ignorance? Well, you educate. So you talked about educating staff. But in terms of educating people, there's several things. There is the wider, is there kind of like a national campaign that the Indian government could do, like they did for HIV, because everybody will see it and they'll hear it because it's come from the government. But then within the communities, I wondered peer support. Now, I've only heard peer support mentioned once, I think just on the last presentation. I know in Manipur it's been really successful, and it's the only place I've really heard about it being successful. So whether that's in a paid role or as volunteers, so rather than the doctors going and spreading the messages, or the healthcare providers, engage people with lived experience, train them how to deliver the message, get the community speaking to each other, because it's an incredible way of, and there's evidence now across the world of, how to educate and how to reduce stigma, because that is the one true way to do it, is to use people with lived experience. So I just wondered now whether you had volunteers in Mumbai, in the slums, that would go out and educate other people.
I did mention about the peer support groups. We have something called as peer educators. These are people who are volunteers from the community who have the lived experience and can talk from experience about the kind of challenges that they are facing. And that really resonates with the people as well, because then they are telling a story that is lived. It's not something which is alien, and that people can resonate with. So that definitely really helps, and that's what we try and, these are also project team members. These are people who are part of the project, who go out and do the outreach, and essentially are from the community and can speak on behalf of the community as well. So that really does a lot of wonders for us.
Thank you.
Anil, sorry.
When there is actually we have also people living with HIV support group. So area-wise, we are doing it in Chennai. When they are bringing them to that support group itself, or we have to create some faith on it, and the space, whatever we are getting, it is a confidentiality maintained. So those things are actually still, it is there, because sometime the program, I said in the program is discriminating. That's the reason, the fear of coming to the one place. So how we can actually break that things. It is not only spreading in the sexual route, other 4 routes are there. So those things should be also highlighted, because there is one girl recently positive, HIV positive. She is actually for no matter the family, nobody is positive. She is only a positive. Young girl, 19-year-old. He is studying. So through that microbiology, she is studying. So lab or whatever reason she got it, and she doesn't know. So there is another girl, they went in virginity test. So they are asking about how I got it, HIV. So this, we don't have an answer to it. So self-stigma is also very high among young people. That makes the treatment adhere when there is coming to adolescence period. So they are not actually taking medications, they are skipping their medicines. So we are motivating them continuously. We are actually saying the truth, means how it is actually functioning medicines in our body. So the doctor is actually not educating, the counselor is not educating. So those truth has to be educated to the to us. So then only our adherence, our actually the things will improve, our health will improve.
Thank you. And that is just for women with HIV, or do you have similar support groups for people who are co-infected or people who just have hepatitis C?
This is actually we do support group for everybody, for HIV positive, including we also working with a SCARF for identifying mental health issues through that also. So like we are referring to a SCARF, and there is a people like free of getting treatment over there. So that's also we do that. And there is another thing is for dialysis is a big challenges when there is actually for HIV. In our states, in Tamil Nadu, there is actually for extended in the 2 places for dialysis centers. For nationally for HIV and Hep C, dialysis is very less places. Accessing for dialysis also challenges for people. So they have to come to the where the machines are for HIV and Hep C.
Great, thank you. Go back to this microphone.
Thank you. I'm Saravana Murthy from PATH. So my question is to Dr. Tara. Ma'am, I was living in front of your institution. So 20 years back, I've been to your institution to give my resume for a job. But now, coming away after 20 years, I'm seeing the stigma over mental health. It's a lot. It's still there, and it is not reduced. Still, we stigmatize mental health. I cannot reveal to my family or society. And now, HIV, it's another thing. It's a lot of stigmatized. Now, we are recommending, so let's get or leverage these facilities for hepatitis testing and vaccination or treatment also. So are we thinking it is not going to too much stigmatize, and uptake of hepatitis service also will be victimized because of further putting on to mental health and HIV? That's my question to you to respond. So because generally as a person who's working in hepatitis, if someone is saying, okay, you can leverage my HIV facilities or a mental health facilities for testing for hepatitis also, then people who are already stigmatized of coming to these 2 facilities, are they going to come to this hepatitis testing also? So that's my question. Thank you, ma'am.
No, but if you are looking at comprehensive health care, it may be a primary care setting or it may be a medical college setup. We are bound to have all these departments, and there will be a bit of crosswalk between say hepatitis and mental health, and like she was saying, dialysis unit. I mean, that is bound to be there. And in which case, it's very hard to dissect and say this much of stigma is because of this and this much of stigma is because of that. Stigma is an attitude, doctor, whereas discrimination is a behavior. See, when you deny a person visa, it's a discrimination. But what you think about the mentally ill or about a person with hepatitis, that is stigma. So unless we bring about an attitudinal change in these people, only then a behavior change will occur.
When you say attitudinal change to the providers?
Yeah, I'm talking of the providers also, because like I said, I have read so many papers where the providers themselves are adding to the stigma. So I think that is why I kept on, I'm saying the key here is educating doctors, primary care people, and of course, psychiatrists.
Thank you, thank you.
Great, thank you. And I just do really want to echo that. You know, if we're going to combat stigma, we have to change attitudes. And that has to be across, you know, healthcare, general public, policymakers. So I think that's really a key takeaway for today. But Gitten?
Yeah, thanks, Jess. I was prompted to come up here after hearing the transgender people's situation in COVID-19. And I think that was a real sad scenario when people really needed access to those vaccines, and you know how people were actually struggling across all class and creed and you know the locations everywhere. But coming back to hepatitis B, and we generally tend to ignore hepatitis B because the prevalence is low. In hepatitis C, for example, if we're testing 100 people and getting 94 people antibody positive, then we see, okay, we need to proceed. But if we're getting out of 100 hepatitis B only 3, then we'll say that, okay, the prevalence is pretty small, so we don't have to. We missed completely that 97% of people who could be protected from getting hepatitis B. I think that's a mindset we have to change to say hepatitis C could be of treatment, hepatitis B still is of prevention. We can still debate on the utility or the usefulness of vaccinating adults as a public health approach. We can debate on that. There are multiple sides to that. But for hepatitis B, I request you, you know, we heard about the 978 facilities. I'm sure in Chandigarh or elsewhere there are, you know, multiple facilities which are model treatment centers or treatment centers. The high-risk groups in the HIV program and the viral hepatitis control program are the same. The only difference is family members of hepatitis, people living with chronic hepatitis B or HBs, surface antigen positive. That's the only add-on in the hepatitis program. So you should be getting access to hepatitis. Now that the National Viral Hepatitis Control Program has included vaccination of hepatitis, of high-risk groups, you should be approaching, you talked about that coordination of multi-stakeholders, you should be proactively approaching those centers to ask for vaccination of those in partnership with the organizations that you work with. That opportunity is there. Rakesh sir mentioned slightly about you know, the choice of regimen that we would want to adopt for highly mobile population or high-risk groups. Are the high-risk groups sometimes 0, 1, 6 in terms of months is difficult to follow. So we have just did, again, in Manipur, we have just did a study comparing rapid regimen, which has been recommended by WHO from 2012, 2015, 2017 position paper. You name all the papers that has come out. So we're comparing that. So we can give people that option. It's 99% serological response with standard regimen to a 92%. So as a public health response, whether 92% with rapid regimen seroprotection is acceptable or not. I mean, those are things which we can debate. We'll share, I think, through Vivek to all the participants once that is published in the next 1 week or 2. But please reach out. There is an opportunity. Transgender people or any other MSM groups should not be, you know, kept aside from receiving this vaccine. The vaccines are already there with the national program. It's for the community to step forward and ask for this and do collaboration and partnerships. Thank you very much.
Okay, sure. Yeah, I think absolutely, and I think it's a fairly low-hanging fruit because there are already harm reduction approaches that are done by NACO at TI centers, and I feel like it's very doable because of the reach of NACO and how well the programs are doing with respect to HIV, that you can reach out to transgender people and men who have sex with men and other high-risk groups that are under the NACO.
I just also want to circle back to what Rachel was saying earlier, is the convergence. For example, in Mumbai, we have Shakti clinics, we have DOT centers. How are we utilizing that infrastructure for Hep B or Hep C? That's an advocacy that we are doing currently and using this as for adult vaccinations wherever required in the community, in the heart of the community. And that has really given us wonder. So point very well taken. That's what we are doing currently. And we are hoping to see more success there.
Yeah, thanks. That brings Priya's presentation. One HIV positive yields, if you're integrating, one HIV, that's the data from University of Liverpool. You can look up. One HIV positive yields 5 hepatitis B. That means, you know how many? And then 3 hepatitis C cases. So thanks for pointing that out again.
Great, thank you. So I think we are fast running out of time, but before I close, I want to ask each of our panelists, just in 30 seconds, one sentence, what is the key takeaway that you would like the audience to take away with them in terms of combating stigma and discrimination for viral hepatitis? I'll start down the end.
The thing is like how the HIV positive people in ART center, they can actually give a vaccination for hepatitis vaccination. That is easy way of getting us to every month we are visiting clinic. So how that vaccine will reach for us in all the ART center of our centers. So all 7 lakhs people living with HIV are taking medications. 17 lakhs people are taking in ART. So how these 17 lakhs people will get vaccinated for Hep C vaccination. Another thing is for our liver, how to be, because we are taking long-term medications, and our medication also causing for liver damages, other organ damages, how to be protected for our organs for things, how the research to be done with our organs. So this is another one more things.
All right, great. Thank you.
And without discriminating for in the healthcare setup, accessing and not far away accessing to whatever government says the ratio to reach for our treatment. So that is another one more.
Thank you. All right, no more one more. I think we keep it to one, but thank you. I think it's a very important point around Hep B vaccination, so thank you.
To make it very quick,
yes.
Just at the cost of repetition, meet the community where they are, try and localize our interventions where we are, and I think we'll see success there.
Yeah, I won't say hyper-local solutions because you just said that, but I think one low-hanging fruit is we saw a lot of digital interventions today, and I think we could definitely make them universally accessible for persons with disability and visual impairment specifically. That is one thing, and I think we have a legal mandate with the Trans Act and the RPDA Act, and I think if we so under that, if we could sensitize district immunization officers and vaccination teams to have them to build that sort of, I guess, impetus to collaborate with CBOs to reach out to these two communities.
Yeah, I think education and improving awareness is very key. And you people have to make more noise about hepatitis, have more CME programs, especially for healthcare professionals. I think it is very important. I know many healthcare professionals don't know very little about hepatitis. And for the stigma bit, some of you from India might know that we had a celebrity actress called Deepika Padukone who came forward and said, I suffered from depression. And it really changed the color to a large extent. So if you can get a celebrity to come and say that I have hepatitis, I think it will mean a lot to public acceptance of the disorder.
Great, thank you. So please join me in thanking our panelists today.
Thank you so much to our moderator and our panelists. Requesting Ms. Jessica Hicks to please present a token of our appreciation to our panelists on stage. And requesting Dr. Vivek to please present Ms. Jessica with the token of our appreciation. Thank you so much. Next, ladies and gentlemen, we'll have a technical session on opportunities for integrated care models in hepatitis management. This session will be chaired by Dr. Amit Goel and Dr. Jyotsna Sistla. Can we please give them a big round of applause as they make their way to the stage? And let's keep the applause going for the rest of our speakers for this session. Dr. B.B. Ravari, Dr. Viswajit Kumar, Dr. Kimberly Green, and Dr. Reshu Agarwal. I now hand our next session over to our able chairs.
So we have first session by Dr. Ravari, Dr. B.B. Ravari, and he has long experience of working with HIV and also hepatitis, particularly in Southeast Asia region, including India. So Dr. Ravari, please.
Is it doing this? Okay. So at the outset, I would like to thank the organizer for giving me this opportunity to talk on hepatitis and HIV co-infection. I'll be focusing my talk on the global and Indian scenario of hepatitis and HIV. What are the key points in the management of a managed co-infected person? What is the current response? What are the gaps, challenges? And of course, what is the way forward? So when we talk of HIV and hepatitis, these are intersecting epidemiologies that affect the most vulnerable. 39 million people estimated to be living with HIV, almost 8 times more with hepatitis, 1.3 million new infections with HIV and 2.2 with hepatitis. These are alarming things which have been pointed out since morning. But what is heartening is that the HIV-related, AIDS-related deaths have significantly come down to 600,000 deaths, 29 million people on ART, while the coverage with hepatitis and deaths are still increasing. Of course, hepatitis is a late entrant, and the programs have been started quite late compared to HIV. And there are many other reasons regarding international commitment, community engagement, donor funding, which will be discussed and have been discussed this morning. So if you look at the Indian scenario, the seroprevalence of hepatitis B, this is the latest data from viral hepatitis control program, 0.85% seroprevalence for B and 0.29 for C. But if you see the figure, there are almost 10 states who are above the national average for B and 7 states above the national average. And if you see some of the states like Mizoram, Punjab, which have got very high prevalence of C, and we know it is people who inject drugs, but if you look at the third state, which is Haryana, no injecting drug use, not much of injecting drug use, but unsafe injections. So while we say that unsafe injections we have taken care of, I don't think that these have been adequately taken care of. This I think I already said. In India, we have 24 lakh people or 2.4 million people estimated to be living with HIV with adult prevalence of 0.24%. When we talk of HIV, HCV burden globally, if we see 5 to 20% of the HIV people are infected with hepatitis B, of course it varies between the countries and within the countries, and 0.5 to 1% of HCV positive are also infected with HIV. This is because they all share similar modes of transmission, unsafe injection, sharing of needles, mother-to-child transmission, unsafe sexual practices. That is the reason that co-infection is significantly common. Coming to management of the two infection when person is co-infected, any concurrent or sequential infection with this virus results in more severe and progressive liver disease. There is higher serum DNA polymerase activity, lower rates of loss of hepatitis B antigen, which leads to consequently to rapid progression of HCC and also a decreased response. Ultimately, there is a higher liver-related mortality among people who are co-infected. Similarly, there is a faster CD4 decline among co-infected persons, slower recovery even when antiretroviral therapy is started, and there is increased incidence of AIDS and non-AIDS related events. Of course, there is an increased risk of ARV toxicity when you are using the drugs concurrently, and this was just pointed out by Kaushalya also in her talk recently. But when coming to treatment, all co-infected persons should start antiretroviral therapy and HBV therapy, irrespective of CD4 count, irrespective of HbA DNA level and status of liver disease. Of course, treat all for HIV has been there now since 2015 and 16, but treating everyone co-infected irrespective of HbA DNA levels need to be immediately brought in if we really want to reduce the mortality and improve the outcomes. Preferred regimen we know is that tenofovir, lamivudine, dolutegravir for HIV, but when a person fails on antiretroviral therapy, they are often switched to a AZT-based regimen, and we have to remember that we need to continue tenofovir with 3TC, and we can't leave them on only lamivudine, which is a weak agent and resistance develop quickly. This is one part I want to raise, that all those who are living with HIV and they are surface antigen negative, they need to be immunized, and this challenge was raised by Kaushalya just now. In terms of what is the vaccination schedule, I know there will be discussion on this and people may not agree, but it is said that response to hepatitis B vaccine is lower in persons with low CD4 count specifically, and there is a meta-analysis which says that 4 double doses of vaccine provide a higher protective titers than regular 3-dose schedule. And this is mentioned in the viral hepatitis control program guidelines also, and recently the technical resource group at NACO adopted this recommendation, but it is yet to come out in the field. Coming to HIV, HCV co-infected, we know that following acute HCV infection, almost 20-25% of people will resolve the infection on their own. 55 to 85 will present to chronic, and then there will be progression to cirrhosis, and they progress slowly, but ultimately there could be a hepatocellular carcinoma. But again, co-infected, in co-infected there is rapid progression of HIV, there is impaired CD4 recovery, and accelerated progression to cirrhosis and decompensation. So both HIV, HBV, and HCV co-infected person have got rapid progression of both the diseases. Coming to management, both the HIV drugs, antiretroviral drugs, and HCV DAs, they target the enzymes which are involved in the replication, and for both are targeting suppressing the replication of virus. And if you see the HCV DAs, basically drugs which block the enzyme NS3 protease, they include glecaprevir, they all end with previr. NS5B polymerase inhibitors, they end with buvir, sofosbuvir, and NS5A inhibitors. And these are the drugs which basically again block the antiretroviral enzyme, the replication enzymes, the blockade of the nucleoside, reverse transcriptase inhibitors, integrase enzyme inhibitors, and protease inhibitors. And these are the drugs which have been available and recommended that we use a combination of 2 NRTIs with 1 integrase inhibitor, and the combination used globally, including in India, is tenofovir, lamivudine, dolutegravir 50 milligram, single pill, what is commonly known as TLD, When a person is co-infected, the recommendation is that co-infected person should be treated and retreated the same way as persons without HIV infection, of course after recognizing and managing the drug interactions, if any. And this was already emphasized by Dr. Rakesh Agrawal, that DAs have similar efficacy in persons with or without HIV co-infection. And there are a number of studies which are available. And you see the similar SVRs in HCV mono-infection and HCV HIV co-infected persons, 95 to 98%, 99%. The regimen have already been emphasized in the morning: without cirrhosis, you give soft DACLA for 12 weeks, compensated cirrhosis of VELPA for 12 weeks, and decompensated ribavirin. And Dr. Amit Goyal also pointed out that what we really need to move forward in terms of moving ahead on the treatment, simplifying the treatment further. Drug-drug interaction: earlier when we were using efavirenz, there was a need to increase the dose of daclitazavir to 90 milligram, or using ritonavir, reduce the dose to 30 milligram, but there is no such drug-drug interaction with dolutegravir, so the same dosage can be used for DAs as well as for antiretroviral therapy. So if a person is not taking ART, is just detected, it is important that we provide the DAs first, complete the treatment, then start antiretroviral therapy. But people who are on ART who plan to initiate, we can start the DAs right away because there is no drug-drug interaction now. But very important was persons infected with HCV, HBV and HIV. This has again been raised that we need to consider potential for HBV reactivation before starting DAs, and also ensure that the antiretroviral regimen have got drugs which are basically two drugs which have got anti-HBV activity, that is either tenofovir or TAF and 3TC or FTC. Current response, we know that the response for antiretroviral treatment for HIV infected person has been very acknowledged globally, with almost 29 out of 39 million people on antiretroviral therapy. 86% know their status, 76% are on treatment, and 71% are suppressed. And India's figures are significantly impressive: 79%, 86 and 93 on 95 cascade. But again, has been pointed out repeatedly, there are significant gaps in the coverage for diagnosis and treatment for hepatitis B and hepatitis C. This is just to show what is the structure of HIV service provision in India, with almost 725 centers, 1,200 link centers for decentralizing, which has happened to a significant amount in India's. Even before WHO guideline came in 2008, link ART centers were established. We have more than 300 care and support centers and more than 17 lakhs people on antiretroviral therapy. This you saw in the morning also from Dr. Dhiman, more than 1,000 treatment centers. And the figure was slightly updated to 9 crore people who have been who have undergone serological test, and almost 3 lakh people who have treatment. But 3 lakh is a number which is, I don't think, is acceptable, and we need to find ways how can this be scaled up significantly. Of course, testing remains, and testing of right people is very important if you really want to scale up this quickly. The global response is, of course, off the track, but it has been modeled that if you are able to provide 40 million people with hepatitis B treatment, 30 million with hepatitis C by 2026, which is just 2 years ahead, there would be a major public health impact, and we'll may be able to achieve 90% decline in incidence, 65% decline. And there are several investment case studies which have shown that the return of $2 to $3 on every dollar which is invested now. But we know the key challenges. Key challenges are that there is limited availability of reliable epidemiological data, and we talk of globally, there is limited funding. Of course, India has committed domestic funding, fully domestically funded program, but in many countries there is limited funding as there are no international donors, they are struggling. And I know in CRO also, except 1 or 2 countries, there is no country which has got dedicated funding for hepatitis. But dose coverage remains suboptimal. Even in India at 79%, 74%, we need to do more. High cost of drugs. India has got the cheapest drugs globally, 1 or 2 more countries, but more than 50% of 10 focus countries, they pay higher price than $30, and what was highlighted in the morning. Multi-disease point-of-care platforms are not fully utilized. Political comment in many countries is not at that level which used to be in HIV with the establishment of national AIDS councils headed by the prime ministers and presidents. That kind of political commitment has not been seen so far. Community engagement, which has been a focus of pillar for HIV program and which has led to this significant engagement, working together and not working for the community, working with the community, that is inadequate as far as hepatitis is concerned. Though there have been changes over the last few years, 4 to 5 years, but still more needs to be done. We have lessons from HIV program on the strong political will, a targeted approach, reach out to vulnerable first, reach out where are unreached people, have a good surveillance. The good news is that Indian Hepatitis Surveillance Program is piggybacked on the HIV program itself. There was a need for a specific surveillance mechanism, but the good point is that we need to move from here to an integrated approach, which now the Viral Hepatitis Control Program is following. Even WHO recommendations on service delivery like adherence, multi-month prescription, 3 to 6 months prescription, ARD dispensing refills every 3 months. These are some things which have worked from which hepatitis program need to take over. And we saw the presentation from Amit and others that if you dispense, and even Pakistan, dispense 12 weeks drug together, the outcomes are significantly the same. So there are lessons we need to learn from HIV program in that. Some of the possible game changers for both could be HIV and HCV self-testing, which could help us reach the unreached, long-acting PrEP formulations, treatment optimization, focus on triple elimination, and of course, a digital support for data, and of course, addressing the stigma and discrimination, which is very important. Also, I think there is a urgent need to implement 2024 WHO guidelines, which will take up the coverage significantly to more and more people. So, and just towards the end, when we talk of way forward, integration is the keyword. WHO has come out with the integrated global health sector strategies on HIV, viral hepatitis, STIs, but I will not go into the details because I think some of the speakers after me will be covering that. Thank you very much.
Sir, our next speaker is Dr. Viswajit Kumar. He's founder and chief scientist at the Community Empowerment Lab, has over 20 years of experience in research and clinical trials. He's previously served as a faculty at Johns Hopkins University and is a member of the ICMR Research Advisory Board. Thank you, sir.
Well, thank you very much. Thank you. I wanted to particularly point out two gentlemen here who have taken the risk of inviting me to this meeting because I'm going to be the only one who will not talk of hepatitis. And one is Dr. Ganesh, who is sitting on the second, and then we have Dr. Vivek. I don't see him here. But this is I am an experiment, so this is going to be an exception because I'm not going to talk of hepatitis. I don't have any expertise, but I'll share some of my work, and I'm hoping that those who have expertise in this, there might be some light that you could actually use. So I'm going to talk of implementation research and hoping that this is possibly a solution for us to bridge the divide. And so, thank you for, is this the one? Thank you for flying me in from Shivgarh. This is a rural village in the state of Uttar Pradesh where I at least try to spend as much time as possible. Rural community with hardworking people, and one of the things that they don't want to, they dread is to get sick. And as most parts of the country, many of them are probably unaware that hepatitis is such a huge public health challenge. It's something that they are at morbid risk all the time. If they do not know where they actually have to get themselves tested. They probably are not even aware of its prognosis or where to seek treatment for. You just flew me from that village in UP to this august audience where I'm in the midst of some of the smartest minds with the most beautiful heart and skilled hands who are committed to doing everything that they can for elimination of hepatitis from the face of this earth and this country. And so this is a room of remarkable people who I believe some of the finest clinicians, some of the finest thinkers, policymakers, and surgeons. But it's fascinating the divide that I come from, that I just said, from that village in UP to this august audience. And if I look into just the proliferation of ideas, of innovations that I can see just within the room or the posters that I saw. But unfortunately, if you look at the translation into real impact, it's very limited. And therefore, that's where our major challenge is. And therefore, the big question that emerges, those innovations that we aim for, that is so promising, if it does not actually translate to real impact for real people on the ground, then what's these innovations and interventions for? And so it's the same story that I have. I started my journey 20 years back with one purpose, is to bring science to save lives of mothers and newborns. And my idea was very simple. All that I need to do is conduct high-quality clinical trials, design intervention that can save lives for South Asia and Sub-Saharan Africa. And that's all that I needed to ensure that it gets published in some high-impact journal and the babies will be saved. Well, we do know from very high-quality evidence that 2/3 of newborns can actually be saved by simple practices. Something like just breastfeeding, something like kangaroo mother care, hand washing. All of these are life-saving practices, and yet just last year we had 2.3 million newborns died from preventable causes. By the end of this summit tomorrow, we'll have 12,000 babies would have died just in the last 2 days. And of course, as you can see, the big divide here, 80% of them are actually babies from Sub-Saharan Africa and South Asia. So the divide is extremely stark. And so I started, while I was thinking of this meeting today and had some conversations with some of you yesterday night, I was like, well, this problem is probably not just, it's not special just to newborn health, but I believe it could even be true for hepatitis as well. And so I looked at, but what explains this big divide? And so I just said, let's look at the anatomy of the divide. And the first divide that I see is the scientific divide itself. It's people like us who actually conduct trials in hyper-controlled conditions. We assume that this is all that is needed for it to be translated and adopted by people across the world. And we don't necessarily, we stay within this cocoon. These are hyper-controlled, hyper-sanitized environments within which we conduct this efficacy trial and pay little attention in order to see whether they're actually effective within the environments that they have to impact. The second, of course, is the political divide. The political divide is, we don't know, we have competing. For example, to be honest, if I hadn't come to this hepatitis summit, I wouldn't have really realized how important and how big this problem is. At least in the national health priority projects that in ICMR, we have a whole series of implementation research to make that leap. We don't have hepatitis, definitely, as one of those. So I think there is a whole, besides, even if we have been able to, its translation into program at many a times, it's just completely at odds with the reality that we have. The third, of course, is the structural divide. We almost assume that the systems exist. No, we have a broken system. We have a weak system. We have a fragmented system. We have an underfunded system. We have an undermanned system. And we have an underperforming system. These are realities of the system that actually ultimately deliver the interventions that you all develop. And I think appreciation of that is extremely important. Then comes the socio-cultural and behavioral divide. At the end of the day, at the end of that mile, there is a human that you would like that human to use. That human stays in a certain reality, and that human, his perception, his socio-cultural cognitive operating system, they all are absolutely critical, whether he adopts or he rejects your intervention. And finally, of course, is the equity divide. Who gets it ultimately? Are we truly strategic in terms of identifying the most vulnerable? And so I'll just take you very quickly through this case study of kangaroo mother care. This is an intervention that is the most powerful neonatal intervention that we have known of, more powerful than any drugs, more powerful than any antibiotics, has the potential to reduce neonatal mortality by 40%. It's a unanimous recommendation that we have to reach by 2030. However, the coverage in the state of UP or over in India would be a meager few percentage points. And so if you look at the context, for example, this is where you have the delivery taking place. There is a lack of enabling environment and lack of resources at home. Now you have everything that you needed. We have the policy, we probably have the money, we have the program documents, we have the guidelines. All that we don't have is babies receiving this life-saving kangaroo mother care. And so we said, how about, and here I would like to bring, and I'd like to call out the contribution of Dr. Rajiv Behel, who was then my colleague at World Health Organization, currently the Director General of Indian Council of Medical Research. And we worked together with many other scientists there, and we said, let's try to solve it by bringing implementation research. And I would call it as the science of building bridges from barriers. And so here, essentially for those uninitiated in this, this is a largely new field, but the whole idea is then it gives you a systematic process of addressing the divide so that you can actually take the intervention that are evidence-based and translate them into impact. And so we set out, but we set out with a very ambitious goal. We said, how about achieving it at the level of a district, which is our unit of replication in our country, and achieve not 1%, not 2%, but achieve 80% coverage with quality using implementation research framework. And we said some of our guiding principles should be that we should design that is aspirational, something that is experiential, something that is empowering and achievable. We're not just going to have transactional interventions against it. And so we brought together a collaboration, and we said instead of putting the intervention at the core, we put the user at the core. In this case, it was the mother, the nurses, the doctors, the administrators, and politicians. So we designed an intervention that addressed the need of each one of them. And so this is what we came up with. We realized that we needed to build something very unique in order to attain those objectives. So we created a lounge. This is in UP, and it's an aspirational space for mothers from the low socioeconomic background. It also became a national best practice, gave it momentum, but more importantly, it was supported. We were designing a system for that intervention to operate within the mother system. It consisted of a nurse coaching. It had communication tools that was designed for the very users. And of course, we had a data-driven governance and process strengthening system. What did it lead to? It led to dramatic improvements in kangaroo mother care uptake. From less than 1% or 10%, it moved up to 93% initiation, over 50% coverage for greater than 8 hours. More importantly, the care for the mother and the baby, for the male and the female baby, was exactly the same, unlike you find in special newborn care units, where the number of male children, male infants who receive care are more than the female. What does it show? Well, this was not just the one. We did this study, but ultimately, our goal is to scale it. Every one of you whose paper was presented today, as well as on the poster, you do it because you really aspire that that should reach. As I speak, we at least have over 400 centers that are up and running with variable level of quality. Now, it doesn't stop there, because I think what implementation research does, it actually makes it living, unlike a clinical trial. Here, the outcome is fixed in terms of what we aspire to reach. The means we can keep adapting, very radically different from the model that we use for clinical research. And so this is the latest example where now that mother has gone into the intensive care unit. Now this is a national program, so this is the first in the country for a special newborn care unit, and I think it should expand to the rest of the country as well. So this is my last slide, and I want to do key takeaways. First, evidence is absolutely important. Eminence cannot be a substitute for evidence, and evidence cannot be a substitute for implementation. I think that's a very key recognition. Context is everything. Context is not just a barrier, but context can also provide us unique opportunities for implementation to work. This is, unlike just clinical trials, implementation research is a team sport. We need everyone has to win, and we are only as effective as the weakest link. So the relationship between all these factors is multiplicative. So if there is one which is a zero, ultimately there is zero implementation. The barriers are interconnected, and therefore should the solution be. If I can be tested for hepatitis, let there be connectedness for me to get a treatment as well. And more importantly, this framework makes program living. And therefore, scaling requires iteration and adaptation. The last point that I would make, more as a call for action, is Indian Council of Medical Research has made implementation research as one of its, particularly under the current leadership of the current Director General. And implementation research, we believe this is an important bridge for us to meet the aspirations of our country. And therefore, there are multiple national health priority projects that are currently underway. Hepatitis definitely is not one of them. And I think nothing would give us more pleasure than for this community to actually advocate actively and take up, just as we are doing for a whole host of other conditions, do it for hepatitis as well. I think it's very important that for the country to actually see a model and see if it can be scaled, it's important that it is big enough that it can be replicated, credible enough, and I think it has to be, as collaborative as possible. With this, thank you very much for inviting me, and thanks Dr. Ganesh and Vivek for that experiment. Thank you.
So now we have last session by Dr. Reshu Agrawal from WHO India office. She specializes in transplant and molecular virology, and she leads viral hepatitis diagnostic support program for laboratory professionals.
So good afternoon, everyone. And at the outset, I would want to thank the organizers for inviting WHO to discuss the WHO guidelines as a framework for hepatitis elimination. I think since morning, we have been discussing about viral hepatitis and why it is important. And again, I want to reiterate that it's the only communicable disease where the mortality is increasing, and it's almost equal to tuberculosis. As we speak, and even today, almost 6,000 people are getting newly infected, and 3,500 people are dying, though hepatitis is something which is preventable, which is treatable. So obviously, we really need to have a greater focus in terms of elimination. The Global Hepatitis Report, which was published last year, 2024, it also describes that there are 10 countries which have nearly 2/3 of the global burden for hepatitis, and India is among these countries. So the world has actually committed for hepatitis elimination by 2030, though this is an ambitious goal. But then there are like absolute targets which have been defined. There is a clear strategy in terms of viral hepatitis elimination, which is 5-pronged. It needs infant vaccination, prevention of mother-to-child transmission, blood and injection safety, harm reduction, and diagnosis and treatment. Though we have really made some progress on the prevention aspects, but diagnosis and treatment is something which is really lagging behind, and we really need key shifts if we really want to meet the 2030 targets. As has been reiterated since morning, that majority of the people with Hep B and Hep C, they remain undiagnosed and untreated. For treatment, only 3% of the people are actually receiving treatment globally, and that's for hepatitis B. And for Hep C, only 20% people receive treatment in 2022. Now for WHO has been coming out with the updated guidelines for Hep B and Hep C to deliver high-quality, evidence-based, and people-centered services. These guidelines have been evolving year by year to make the care more simplified to reach as many people as possible, and to also describe the how part. And these are being now being positioned as a way towards elimination of hepatitis from the world. So testing is the most important point when we talk about any elimination, and it's the most critical point of entry if you want to really monitor and retain your patients in your retention cascades for treatment. Not only for treatment, but also for prevention, because then you know that who is at risk once you have done the testing, and you can put the people in the prevention cascade also. And in fact, we have a really good model like in HIV, which is called the status neutral approach. So that's something we really need to adopt for hepatitis as well. This is something which we were discussing in morning again, that we need to prioritize the people whom do we need to test, and Dr. Dhiman really talked about it. So as per the WHO guidelines, the people who need to be prioritized for Hep B and Hep C infections is really laid out very clearly. So a universal testing approach is recommended if the seroprevalence is more than 2% for HPV or HCV in general population. Also, the birth cohort testing is recommended for people for HCV, especially for the people who were born before the injection safety or the infection prevention practices were in place. In addition, the routine testing is recommended for HPV amongst the pregnant women and the healthcare worker, and both for HPV and HCV for the blood donors, adults, adolescents, and children with a clinical suspicion for chronic viral hepatitis. Additionally, focused testing is recommended, and especially periodic testing is recommended for the key populations, sexual partners, children, and family members and close contacts of those with HPV infection, mobile and migrant population, people who are living with HIV, STI, or TB, persons who may have been exposed in healthcare setting and could have acquired hepatitis infection, especially people with thalassemia or hemophilia, people who might have acquired infection outside the healthcare setting through the invasive procedures which might have been done in unsafe manner, such as unsafe injections, unsafe tattooing, body piercing, etc. Now coming to the management part. So for the HBV management, these guidelines were revised in 2024. The earlier guidelines were issued in 2015. And why do we needed to really update these guidelines? So what we saw was that there were still major gaps in testing and treatment uptake, as you saw that only 3% of the people are on treatment. So what was realized that the criteria was quite complicated in terms of identifying the people, and a real simplification of the guidelines was needed. Then there are regional differences in the demographics and epidemiology of the infection in multiple parts of the country. And we had data coming from sub-Saharan African countries where the birth rate of people with HBV infection was quite high, the incidence of liver cancers was quite high, and people were really not receiving care. There was more emerging evidence which was coming in terms of the updation of the guidelines, and there were access challenges which were realized, and perhaps we were talking about the health equity right now. So perhaps as a part of the health equity to really reach out as much people as we can, and everywhere, wherever these people are, there was a dire need to simplify the HBV guidelines. So these guidelines were updated using a very evidence-based approach. There were 15 systematic analysis or reviews which were commissioned by WHO. There were modeling exercises which were done to understand the impact of the expanded eligibility and also to understand the numbers needed to treat to avert each case of cirrhosis and hepatocellular carcinoma. There were exercises on the landscaping, access to the drugs and cost, and also acceptability and preferences were also assessed in terms of the providers as well as the healthcare work, as well as the community. So talking about the recommendations, these guidelines actually recommend for the use of non-invasive tests for liver fibrosis, and EPRI score and transient elastography have been recommended as the tools for in identifying fibrosis. As per the new recommendation, the cutoff criteria for significant fibrosis has been redefined, and an EPRI score of more than 0.5 or the transient elastography value of more than 7 kPa is considered as significant fibrosis. Talking about who to treat, so these guidelines really lay out a very simplified criteria, and there are 4 types of people who are eligible for treatment. So first is if there is an evidence of significant fibrosis, which means the EPRI score is more than 0.5 or the transient elastography value is more than 7 kPa. Second group who needs treatment is if the HBV DNA is more than 2,000 international units per ml and the ALT level is above the normal limits. The third group for which the treatment is indicated is the presence of co-infections such as HIV, hepatitis D, hepatitis C, any family history of liver cancers, cirrhosis, immune suppression, comorbidities, or extrahepatic manifestations. And the fourth recommendation really simplifies so that the treatment can be reached to as many people as possible, and it indicates that in the absence of the access to HBV DNA, if there is a persistently high abnormal ALT level, then treatment should be considered. So these revised updated guidelines really give us a lot of key messages in terms of the expanded eligibility, and with this revised guidelines, almost 50% of the people who are living with chronic hepatitis infection would be eligible for treatment as compared to 8 to 15% as per the previous guidelines. So the inclusion criteria has been simplified. Who to treat is really very clear in these guidelines. There are 4 options to understand the eligibility criteria. The use of non-invasive tests is encouraged, and it is applicable to all the settings even if the HBV DNA assays are not available. And in terms of the cascade monitoring, it really focuses on simplified testing and diagnostics, simplified treatment cascade, and simplified service delivery models. Also, there is a recommendation of using HBV DNA testing and reflex testing. So a point of care HBV DNA testing is recommended. Also, there is a recommendation to use reflex HBV DNA as soon as the person is identified positive for HBsAg in a lab-based approach or a clinical-based approach. Coming to the antiviral treatment which needs to be used, so TDF is the choice of regimen. And in case TDF is not available as a single molecule, in those cases, tenofovir lamivudine can be used because this is widely available as part of the HIV treatment programs. Also, there is a new recommendation which talks about use of entecavir or TAF for the people who have osteoporosis or impaired kidney function. So for children more than 3 years, entecavir can be used, and for people with more than 12 years of age and for whom tenofovir cannot be used, TAF can be used. So lastly, for the HBV guidelines, these guidelines also give very clear recommendations about preventing mother-to-child transmission for HPV using antiviral prophylaxis. And again, I think the idea here is that every child should be born free of HPV, and we should have hepatitis B-free generations. So as per this recommendation, if the HBV DNA is available, then TDF prophylaxis should be considered if the level is more than 200,000 international units per ml. But in case if HBV DNA is not available, then all pregnant women who are positive for HBsAg, they should be considered for TDF prophylaxis. So coming to the HCV guidelines now. So HCV guidelines were revised in 2022. And as per this comprehensive algorithm which is given here, so we need to conduct the anti-HCV antibody testing. And if somebody is positive as per this test, then we need to proceed for the viral load testing or HCV RNA. And those who are found to be viremic, they need treatment. They need to be started on pan-genotypic drugs. So genotypic testing is not required. And in terms of monitoring, SVR needs to be done 12 weeks after completion of the treatment, and people need to be evaluated for hepatocellular carcinoma using ultrasound or AFP. So I think till now what I was discussing was more on the technical aspects, but obviously any technical guideline would work if we really have good mechanisms to deliver the services. So WHO recently came out with this very comprehensive guideline providing a framework to plan the service delivery, and it gives a 5-step approach which talks about the situational analysis. Then step 2, to define whom do you want to test for Hep B and Hep C in your local context. Then step 3 is you plan for the differentiated care so that you are able to mobilize people for testing and link them for treatment. And then you prioritize your testing approaches, like what would work in the local context, and monitor and evaluate. The key principles for reaching to everyone for the hepatitis service delivery remains that there should be linkages to testing, care, and treatment. There should be, the services should be designed in such a manner that the long-term adherence can be maintained, people are retained. Integration for hepatitis services with other healthcare services is the key, and this has been alluded to in morning as well by Dr. Soumya and Dr. Rodrigo. Decentralization to primary health care, again to improve the access is the key. Task sharing, differentiated care model as per the need of the people, and last but not the least is the community engagement, which are very critical. So just to sum up now, in terms of implementation priorities, to implement the WHO guidelines, we need to really scale up the testing and case finding and linkage to treatment. We need to update the guidelines, and this updation needs to be informed in terms of the local context as well as the implementation considerations. There is a dire need to integrate the hepatitis services with hepatitis care and treatment with other services such as HIV, TB, NCTs, wherever feasible. We need to have simplified service delivery mechanisms and using primary healthcare model. Training and capacity building, and this was alluded to in morning by Dr. Amit also, it's very critical that we need to train our healthcare workers so that they are also prepared for providing right treatment and also following up their patients who are being started on treatment. And most important is the community engagement, to create more of awareness, to use community as advocates and to use community as a peer for the people who are already on treatment. So thanks so much for your patience listening. Thank you.
Thank you so much, ma'am. Our next speaker could unfortunately not be here in person. However, we are lucky to have a video presentation. We have Dr. Kimberly Green, who will be speaking about collaboration and coalition building for hepatitis elimination. She's the Global Director, Primary Healthcare at PATH. And has more than 30 years of experience in public health management, policy development, and research. So anytime. Yeah.
Greetings, my name is Dr. Kimberly Green, and it's my honor to be presenting on the essential role of integration in increasing access to and uptake of viral hepatitis services from a global perspective. So we know through WHO data that there are still major challenges in terms of the cascade for viral hepatitis, both hepatitis B and hepatitis C, all over the world, including in Asia. Very low levels of individuals diagnosed and treated. At the same time, we know there's very important interventions for prevention of viral hepatitis, including through harm reduction and also through triple elimination, and that significant work is needed in order to expand access to preventative services to overall decrease new infections in Hep B and in Hep C. And so as part of this, it's vitally important to consider, with all of the reforms that are happening across Asia and the world, with universal health coverage and primary health care, that viral hepatitis be integrated and part of these financing and service delivery reform conversations. So why is this so important? Well, we know that with integrated people-centered care, that integration, particularly at the service point, where a multitude of services are available, increases overall access and uptake of care. So many studies have been conducted across many different health areas exploring integration, including at viral hepatitis. And I'll provide some examples from our own experience. So in work that's happening across Asia and Eastern Europe and Ukraine, Vietnam and India, we see excellent opportunities and evidence around acceptability and feasibility of integrating viral hepatitis services through antenatal care, as well as through primary health care, the public sector and private sector. Secondly, through prisons and other non-traditional or closed settings. And third, through population-specific public and private sector delivery points. And so, firstly, an excellent example and experience from Ukraine, where hepatitis C services were integrated as part of a package of overall services within penal settings in Ukraine. And this involved screening around 33,000 individuals with HIV and hepatitis C, and resulted in a sustained approach through penal settings where ongoing screening for hepatitis C and access to treatment is now embedded as part of healthcare services delivered in penal settings across Ukraine. In Vietnam, a very important example of adding viral hepatitis services within key population led services through social enterprise clinics, as well as through methadone service delivery and through ART, so a diversity of service points. This initiative was really important in really looking again at the feasibility of integration of screening, diagnosis, and treatment of Hep B and Hep C. And this led to more than 20,000 individuals opting for hepatitis B and or hepatitis C testing, with the greatest uptake through community-based modalities, and with a significant number of individuals diagnosed and treated with strong cascades. So this approach is being scaled up in Vietnam. And similarly, we see that through interesting model in Vietnam as well, leveraging self-care methods to increase hepatitis C testing through both HIV and harm reduction services in Vietnam, specifically looking at hepatitis C self-testing. And through this initiative, really found that there was strong acceptability of hepatitis C self-testing in Vietnam, and that this contributed to increasing overall access to then diagnoses and treatment, which complemented facility-based and peer-led lay testing for hepatitis C. So really important findings of the rationale for integrating and adding hepatitis C self-testing as part of the standard of care. In addition to that, a really also exciting experience from Vietnam on decentralizing Hep B services along with HIV and syphilis services as part of primary healthcare delivered antenatal care platforms in Vietnam. And so here, systematizing screening and acceptability of screening for the 3 different diseases among pregnant women, and doing so really through community awareness and strong partnership with primary health care. And as a result, overall, very high acceptance and uptake of screening for hepatitis B, 99.3%, as well as high acceptability for HIV and syphilis screening. In addition to that, strong linkage to confirmatory diagnosis and management of hepatitis B in pregnancy. And so overall, we also found earlier screening in ANC, which is so critical. And so last, really wanted to feature an exciting global project which is financed through Unitaid, which is looking at ways in which to integrate low dead space syringe access and also access to long-acting depot buprenorphine as part of harm reduction and prison settings to really increase access, of course, to prevention of hepatitis C, but then also includes integration of screening, diagnosis, and treatment for Hep C among people who inject drugs and among prisoners. And this effort is happening across several countries, including Vietnam, Ukraine, India, South Africa, and Nigeria. So key takeaways from this work, number 1, we know that globally, including in Asia, we are far behind in viral hepatitis screening, diagnosis, and treatment, as well as in prevention. And we found that better integration can accelerate access and uptake of these services. We've also learned that integration of viral hepatitis services is feasible across different settings and for different populations, including through primary health care, ANC, PrEP, harm reduction, prisons, and ART. It's also critical to finance viral hepatitis services as part of universal health coverage and primary health care reforms, including as part of social health insurance. And last, that the private sector also plays a critical role in increasing access to viral hepatitis services. With that, thank you so much. Appreciate the opportunity to be able to present. And so sorry, my apologies that I was not able to be with you in person. Thank you so much.
It's been a wonderful panel, and we've had some excellent presentations by all the panelists. Given that we have 5 minutes left in this session, I think we can open up questions from the audience, perhaps a question for each speaker, followed by our concluding remarks. So, yeah.
Hi, my question is to Dr. Reshu. And this is regarding WHO guidelines, the updated 2024 HPV guidelines. The concern I have is that those guidelines at the bottom carry footnotes. The cutoffs that are mentioned for a large proportion of people for whom treatment is advised, and mind you, this treatment is going to last for a lifetime, is based on low certainty evidence, in some cases very low certainty evidence. Sometimes on a low certainty evidence it says strong recommendation, and at places it says conditional recommendation. A therapeutic intervention that is going to last for a lifetime based on low or very low certainty evidence is something that a clinician, simple clinician such as me, does not fully understand How do we do that? And remember, if you see the whole universe, the good certainty is only for the top. Most of it is a low certainty evidence. Any comments?
Thank you for your question, sir. See, the way WHO guidelines were devised was doing a greater good. And as the global access report came in, and also the data from some of the countries where the access was really an issue, I think a lot of things were taken into consideration in terms of designing these guidelines. These are more of a public health approach and a public health recommendations, which can be discussed in in country context. So these are broader recommendations which may be applicable to a certain country, which may not be applicable to certain country. But then the idea was to reach as many people as we can, and the guidelines should not act as barrier to access.
This is exactly where the conflict comes. What we heard from Dr. Vishwajit, ultimately everything has to be evidence-based. This is the jumping from low evidence to a public health recommendation for large numbers. We run the risk. There are umpteen number of examples available around the globe where we have treated large number of people not realizing what could be the consequences, and it's later, using a spectroscope, we have realized what the issues were. Anyway, I think we can agree to disagree.
Thank you very much, and I will first congratulate on the kangaroo mother care, because that's particularly exciting and inspiring. And taking a plate from that, now I noticed that the title is about integrated care models. And given we have a lot of kinds of people that come from different walks of and programming background, my question to the group is, what can we leverage with the current government investments in primary care, in Ayushman Bharat, in TB, in the health and wellness centers, and in NCD, because in NCD, because there is a new program on NAFLD where they plan to provide FibroScan at the district hospital, for example. So is there anything that we can leverage there in terms of trying to utilize all these platforms? Government is investing in the integrated public health lab for surveillance at every district or even sub-district level. So what can we do more, and how can we have this conversation at the state, which matters a lot, and state to take it upwards to the national programs or national governments? We have significant evidence and opportunity, remarkable opportunity here, because resources seems to be here, is there, but it's just about tapping that resource. Thank you.
So who would like, yes.
Yeah, I know nothing about hepatitis, all that I've been learning here. But, so I think one key, so let me give you a very brief, I'll be brief, but the Secretary, Department of Health, and the Secretary, Department of Health Research, Health and Family Welfare, and Department of Health Research had a conversation almost 2 years back. And the whole idea was, we have programs that gets flagged off, but those never end up, they all end up along the cascade with very low coverage and quality. And therefore, what should we do? And so that's where a set of 12 key national programs or conditions were identified. Those are known as the National Health Research Priority Projects. It begins from almost, from cervical cancer to suicide prevention to emergency care systems to neonatal health. And I tend to play some role in supporting it and those rollout. And I realized that fundamentally they all face the same set of problems. And so when I look at this with very limited understanding of hepatitis in general, I think what is needed is to demonstrate that this is how, at a replicable level or replicable unit, this is how it can be done. So for example, whether it is to drive a synergy between rest of the programs, how do you integrate that within a health and wellness center? How do you integrate hepatitis into as part of the community outreach? Or in terms of, I think what is needed is to have a model that the world can see, the country can see, that then they can, that's the missing gap that I see across all the programs. And I think that's an opportunity for this community to actually address. That's one scientific way that I see where you can actually identify these and come up with a model that actually addresses and synergizes. That becomes a very compelling business case for the government.
Just to add, I fully agree with you, Pauline, but we need to really look into the words: integration, collaboration, synergy. They are different words, but ultimate aim to the same point. So it may not be integration, it may be a collaboration, it may be a synergy that actually amounts to a person-centered care. If you really look at the program, viral hepatitis control program, people have their own turfs. I am from HIV program, I am from TB program. Those things, it is very difficult to leave. Even at the bureaucratic level, if you see NHM and versus the National AIDS program, they have their own turfs. So bringing them together is difficult, but it's happening. Viral hepatitis control program is fully integrated into NHM. TB program is already utilizing the health system. HIV program has also started collaborating with the NCDs. Already there is collaboration on NCDs, cervical cancer. And when you talk of NFLD, yes, this is a fully part of the National Communicable Disease Program. Now it is not bringing out as a separate program. It is just that you have interventions, and interventions for diabetes, hypertension, NFLD are not very different. Weight loss, good diet, healthy lifestyle measures. So that level of integration is happening, but we really need to say whether it will be full integration or collaboration. Thank you.
Hi, I'm Dr. Hemant Sharma. So my question was based on like what Dr. Rewari just said, collaboration. So when we talk about integration, of course, it is important to improve the access for the general population and the community. But on the other aspect, are we thinking about the collaborations as well? Dr. Agarwal in the morning reflected a lot of treatments being happening in the private sector. So do any of the, like the question to the whole panel, do you see any role of the private sector anywhere in the cascade of care in improving access? We have some examples, Clinton Foundation, from the TV program, like PPIA and other models. But then do you see any potential of collaboration over there?
Yes, you raised the private sector involvement. It has been quite significantly low in HIV because it's a long-term therapy available free. But in viral hepatitis, you look at the private sector, more than 50 to 60% of people are still going to private sector. And as of now, on ground, yes, there is a part of the viral hepatitis control program that we collaborate, but I really think we need to collaborate more with the private sector if we really everyone to get the benefits. Like TB program is a very good PPP model program, whereby any private practitioner can provide the treatment, get it free, and get incentive also. So yes, I agree, private sector involvement is very critical.
Sir, just one small issue, sir. So Dr. Rewari, sir, can you go for not only coordination or intervention or interrogation, but can you go for convergence? Because, as you have been working with the HIV/AIDS, NACO for a long time, NACO has got good funding or scope, but at the same time, National Viral Hepatitis Control Program is not having that much scope. Can there be a convergence with that funding and concerned about the BC and HIV-3 all together? Can we do it better in a better way in the country?
thing which I raised when I was in NACO. And in fact, I also suggested that it should be a national National AIDS and Viral Hepatitis Control Program, NACVHE. But that has not happened, but I fully agree, convergence has to be there, it may not be integration. And there is convergence to some extent also, particularly for the key population and high-risk groups. But yes, more convergence need to happen.
Actually, Dr. Rewari, taking your point about private sector, the HCV treatment in India is today actually so cheap that a lot of people can afford it and they wouldn't really mind paying for it. So I think, it can continue to be in the private sector because that releases government money for more needy people. But what can be done is, I know you don't have any control on that, but that the data for those treated people are entered into the system. That is what we need, rather than government funding all the people who are getting treatment in the private sector. Thank you.
I fully agree. When I say collaboration, it is not only provision of the drugs. It is, of course, getting the information that it is 20% coverage or it is 40% coverage. Like in HIV program, we are now getting all the data from the private sector voluntarily. Initially, we went through the court orders, and now it is voluntary that NACO is getting information from the private sector, even if they are not getting the drugs from the program.
But actually the flexibility in the program is not there. So we can keep on talking about the integration with the private sector, involvement of this and that, but nothing is feasible till there is some flexibility. So I think political will is there, that's why the program is started. But now program has to have some flexibility so that the things can be done. If even if some private sector is willing to cooperate, is willing to come and join us, we don't have that power to join hands. That's the problem.
Right. Thank you, Dr. Amit. So, Dr. Jyotsna.
Hello.
Sorry.
Yeah, I think thanks for all the panelists. I think lots of questions are coming regarding integrated care models in this therapeutic management of hepatitis. I think Ministry of Health has taken a good call on integrated model. I think every year on the eve of World Hepatitis Day, there is a integrated screening for TB, HIV and hepatitis. Under Ministry of Health, there is a provision of doing this integrated care screening for all three vulnerabilities, for all the high-risk populations. As well as cervical cancer screening is another challenges to screen the public health populations. Because private partners are there for collaborations, Tata Trust or TRFs, they are the partners in the public health domain. Those help to government for integrated model screening. And I think upcoming World Cancer Day, I think on the 4th February. So that integrated care model can be very useful in the public health domain, because Dr. Rakesh Agarwal also highlighted the evidence-based, Dr. Bisri also told us that evidence-based recommendations needed some good data. So management information system under NVCP has been designed right beginning from the registration to the outcome of the patient. Need is to address the data punching in that MIS portal. And as per NFHS 4 data, if you see the prevalence of seroprevalence of hepatitis C or B, is mostly high in the Haryana, Uttarakhand, Maharashtra and Punjab. If we say the northeastern state like Jharkhand, Bihar, West Bengal, their prevalence rate is 0.5% for B and less than 0.05% for C. So there is a provision of diagnosis and provision of drugs up to dispensing up to health wellness center. Because for management of uncomplicated cirrhosis of liver or alternative cirrhosis of liver, that can be, the moment it has been screened or diagnosed, that treatment can be done up to health wellness center at the interval of three months for SVR. So instead of having the good provision of the things, only thing is that some operational challenges are there. Programmatic challenges are there. Political will is there. That's why, and in government sector, there is never lack of resources, lack of fund. Only thing is that how it will be prioritized. Under nationalism, is that there are lots of provision of fund for all vertical programs of the National Government of India.
I think now we are running short of time.
Thank you.
And discussing all these things will be more valuable when the policy makers who are having power to take decision are present here. Otherwise, suggestion is good, but we cannot implement. I would like to thank all the speakers and my co-chairperson for this session. Thank you.
Requesting our dignitaries to remain on stage for a moment longer. If we could have our chairs do the honor and present all of our speakers with a token of our appreciation. Also a reminder to all of our participants that we have the poster competition going on right now. So requesting our judges and the participants to head over to where the poster board is. A big round of applause to all of our speakers, ladies and gentlemen. And calling upon Dr. Ganesh to please do the honors and present a token of our appreciation to our able chair. Thank you so much. So ladies and gentlemen, we do have the poster competition going on right now, but I do want to remind all of you that we have a fabulous evening ahead. At the end of the formal sessions, we have a gala dinner with a fab lineup of entertainment for you. We've got some amazing performances. We have a band, we have dancing, we have an illusionist, we also have a mimicry artist. So you can be rest assured that it's going to be a very, very entertaining evening. So we look forward to that at 7 p.m. right here. And now we will move on to our final session. This is an industrial technical session which focuses on industry perspectives on innovations in hepatitis care. This session will be chaired just give us a few moments, ladies and gentlemen. We're setting up the stage. Apologies, ladies and gentlemen. Our next session is Lessons from the Field, focusing on real-world experiences in hepatitis care. This session will be chaired by Ms. Rachel Halford. Please give her a round of applause as she makes her way to the stage. I'd like to call upon our speakers, Mr. Rajkumar Nalinikanta, Dr. Somashekar Rao, and Dr. Saravanamurthy. Can we give them a round of applause? And I'd like to call upon the co-chair, Dr. Malarviri.
Good evening, all. Since morning, we've been talking at brainstorming sessions on guidelines, collaboration, integration, even design in public health. But what really matters is the community at the ground level. What are the challenges we are facing at the community level? I think this is very important session because only at this level, if we achieve, we are moving towards the elimination of hepatitis B and C. For this session, community-centric approaches to hepatitis elimination, I call upon Mr. Rajkumar Nalinikanta, President, Community Network for Empowerment. And he's a member in the steering committee of the Manipur State Management Unit of NBHCP. We would like to get your experiences from the ground level, sir.
Excuse me. How do I use this? Okay. Good afternoon. Thank you so much for the opportunity to be here and to share our hands-on experience as a part of the Indian Hepatitis Summit 2025. I'm grateful for the chance to present on the topic, community-centric approaches to hepatitis eliminations. So I will begin my presentation by giving you a background about our organization. CON stands for Community Network for Empowerment, which is a drug user-led network of 10 community-based organizations of people who use drugs from 8 districts of the state, and it was established in the year 2011. So since 2014, we have been engaged in a variety of activity ranging from awareness building to providing free diagnosis and treatment, all made possible through philanthropic and local support. We have also been collaborated with the government to develop different models of hepatitis C treatment, including same-day test and treat of hepatitis C among people who inject drug, as well as for prison inmates. Additionally, we have also provided uninterrupted hepatitis C services during COVID-19 restrictions. We are now running a hepatitis B vaccination campaign among people who inject drug with the support from the national program. Furthermore, we have also been engaged at the state and national level advocacy activity to improve and avail high-quality services. So this slide provides a snapshot of global and national burden of viral hepatitis B and C, as well as a specific issue in Manipur. See, there are over 350 million people worldwide living with viral hepatitis B and C, highlighting the significant global health challenges posed by these infections. In India, approximately we have around 40 million people living with hepatitis B and around 8 to 10 million people living with hepatitis C, emphasizing a large number of hepatitis problems at the national level. And in Manipur, the situation is particularly concerning, as there is a high prevalence of hepatitis C among people who inject drugs, with a positivity rate of 43% as per the studies conducted by CON in collaboration with Regional Institute of Medical Science. Additionally, there are significant proportion of people who inject drugs vulnerable to hepatitis B. As per our record, 94% of the people who inject drugs are found to be susceptible to hepatitis B, making the burden of viral hepatitis even more pronounced in this group. However, the key challenges that we are facing now is the rate of diagnosis and treatment for both hepatitis B and C is extremely low. This indicates a gap in healthcare access and awareness. Therefore, it is crucial to focus on enhancing diagnosis, treatment, and prevention effort to address viral hepatitis. A community-centric approach is essential in bridging this gap and should be emphasized as a key strategy to move forward. So these are some of the benefits significant with community-centric approach to hepatitis eliminations for the marginalized group, such as people who inject drug, transgender, and PLH-heavy. Community-centric approach are often far more effective than institutional-based service delivery for the several important reasons given below. I will briefly explain each point. See, the first point is early detection and prevention. Community play a crucial role in offering preventive care and early intervention by addressing the issue before they become more serious. We are in a strong position to tackle this issue before they escalate. As for example, like identifying hotspot and organizing mobile screening camp allow us to diagnose the issue on time, which in turn reduce the pressure on costly institutional service. Almost 90% of the people diagnosed from the mobile screening camp are found to be non-cirrhotic with a APRI score level of less than 2. So this clearly demonstrates the benefit of community-centric approach in terms of preventive care and early detection. And secondly, community-centric approach is a trust-based care model that lead to better engagement. The people who inject drug community often has a deep mistrust of institutional setting due to their past negative experience with the healthcare system, such as lengthy pre-treatment process or stigma and discrimination. On the other side, community-centric approach focus on building trust and providing care in non-judgmental environment. This approach is essential because people who inject drug are more likely to access services and adhere to treatment regimen. Community-centric approach can also enhance accessibility by overcoming barriers to healthcare access, barriers such as transportation issues, fear of stigma and discriminations, poor health-seeking behavior, and of course, the cost and distance travel. By bringing hepatitis B and C screening directly to the population through community-led screening camp, we increase accessibility and reach to individual which may otherwise be excluded from the healthcare services. A community-centric approach can has also support economically disadvantaged groups such as people who inject drug and people living with HIV by offering them free screening, vaccination, diagnosis and treatment under the national program, helping them to eliminate their financial barrier. Community-centric approach can also help stop the spread of hepatitis. Elimination of hepatitis is not only about treating the patient who already got infected, but it is also about preventing further transmission. So community-centric approaches are effective in engaging people who inject drug, in prevention efforts such as hepatitis B vaccination, harm reductions, and educate them on safer injection practice. This approach of addressing the root cause of hepatitis transmission within the community also help reduce new infection and promote overall public health. It can also reduce stigma and discriminations. Institutional setting can be stigmatizing for people who inject drug as they are often treated as marginalized or the criminalized individual, whereas community-centric model are going to create an environment where people who inject drugs are supposed to be treated with dignity and respect, thus minimizing the risks of discrimination and promoting a sense of safety. Empowering people who inject drug community to take a leading role in managing their own health, improve adherence to treatment, and also contribute to hepatitis elimination. So in community-centric model, people who inject drug community serve as a peer educator, helping their peer by providing education, then offering screening and guiding individual through the diagnosis, treatment, and follow-up process. The overall success of the community-centric approach lies in providing comprehensive approach to a holistic service delivery model combining testing with counseling, education, hepatitis B vaccination, linkage to diagnosis and treatment until SBR. So this model not only address the medical need, but also the mental, social, and emotional well-being of the individual as well as their family. So I will share with you, highlight some case study highlighting the community-centric approach implemented by CON, specifically the same-day test and treat of hepatitis C. This was a community-driven initiative supported by both the government and the private lab with shared responsibility in the process. National Viral Hepatitis Control Program provides us testing kit and medicine, whereas the private lab helped us to conduct hepatitis C RNA tests using their TrueNet MolBio machine, and we take the responsibility of mobilizing the camp. In terms of the method that we were involved, we work with the drug treatment center targeting people who are undergoing drug treatment at the rehab center. We provide on-site rapid diagnostic tests for hepatitis C. The blood sample for those tested hepatitis C positive are collected and transported to Babina Diagnostic, which is one of our private laboratory in Manipur, where hepatitis C RNA tests are done using MolBio machine. So those participants who were confirmed RNA positive were initiated treatment on the same day with the advice from the doctors at the Model Treatment Center, Jawaharlal Nehru Institute of Medical Science, as per the guideline of the national program. So between December 2021 to November 2021 to January 2022, we conduct a camp at 23 different sites where we screened 523 people, out of which 49.5% of them were found to be hepatitis C antibody positive. 100% of them were linked for RNA tests on the same day, of which 64.5% of them were confirmed to be RNA positive. Out of this 167, 99.4% of them were initiated treatment on the same day. 159 of them have undergone the SBR test, out of which 88.6% of them were found to be cured from hepatitis C. The median time that was taken from screening till the initiation of treatment were 6 hours and 49 minutes. And this is another community-centric approach implemented by CON with the support from the National Viral Hepatitis Control Program. Testing kit and vaccine were provided to us by the national program, and we take the responsibility of identifying hotspot and mobilizing the screening camp for hepatitis, screening and vaccination camp for hepatitis B. So, over a period of 31 months, we screened 2,961 people, of which 94.7% was found to be susceptible to hepatitis B. 100% of them received the first dose vaccination, 89% of them received second dose, and 45% of them received third dose. The percentage of people receiving third dose remain low because many individuals have not yet reached their scheduled due date for the third dose. And among those people tested positive, we have linked them for RNA tests. 100% of them were linked for DNA tests, among which number of people found to be target not detected were 61. Number of people viral load above 20,000 IU per ml was 54. Number of people below 20,000 was 13. And number of people eligible for treatment was 8. And all the 8 people have now put on treatment. And this is the third case study where hepatitis C, uninterrupted hepatitis C service was delivered during COVID-19. See, let me just give you a background of the hepatitis C service delivery implemented by CON during COVID-19. Due to COVID-19 lockdown came into force Then all the government and private hospital institutions, including the hospital, were closed down, except for some emergency case. Even the public transportation stopped operating. As a result, new enrollment for screening, diagnosis, and treatment at the model treatment. There was no new enrollment for screening, diagnosis, and treatment at model treatment care center, as the viral load for both the model treatment center were exclusively used for COVID-19 tests. So this situation prompted CONE to take action and reactivate the HIV service Delhi under the national program. So this decentralized effort allow us to screen 908 people, out of which 41% of them were found to be hepatitis C antibody positive. Then 86% of them were linked for RNA tests, among which 56% of them confirmed to be RNA positive, and 86% treatment linkages was made possible. And for this special case study number 3, I would like to thank our National Viral Hepatitis Control Program for all the support that they have provided to us. Even the cost of the viral load test at the private lab was paid by the government under the National Viral Hepatitis Control Program. So this achievement highlights the effectiveness of community-driven initiative in ensuring treatment linkages even during COVID-19 time also. So this slide illustrates the overall hepatitis C care cascade over a 10 years period through mobile screening camp initiative. It is important to note that the mobile screening camp was not organized continuously throughout this period. If it had been conducted, then the total number of people we screened would have been exceeded 30,000 by now. However, due to fund availability, the screening camp were organized intermittently with significant gap between the event during the course of over the course of the decade. I will not elaborate more on the overall hepatitis C care cascade that we have, but taking the privilege of this hepatitis C care cascade as a key message, I would just like to point out some gap from this hepatitis care cascade that we are having. See, you can see a huge gap of patient follow-up in 3 different stages. The first stage is in between the number of people tested positive and number of people undergone test, which is only 61.5%. Again, the second stage is the huge gap of patient. The second stage is in between the number of people confirmed RNA test and number of people initiated treatment, which is only 56%. And the last stage is in between the number of people on treatment and number of people undergone SBR, SBR test. So, my key take-away message from this slide is there is a need for effective community engagement in rolling out the National Viral Hepatitis Control Program, like how we did in HIV programming. If we really want to address this gap in 3 different stages, there is a need of community engagement with allocation of fund, like how we have done in HIV program. I have heard some of the speaker mention about integration of National AIDS Control Program and National Viral Hepatitis Control Program, but it will take a lot of time for us to make it to make it into a realistic, because as many of the speakers have also mentioned earlier about the gap between the different government departments. National Viral Hepatitis Control Program have already initiated developing a policy document for integration of NHCP and NBHCP somewhere around in the year 2022. But now the feedback from the NACO is still pending. Unless we finalize this document and get implemented, integration of HIV and viral hepatitis program would not be possible. Thank you so much.
Thank you for a fantastic presentation. An exemplary example of best practice, globally recognised. And I'd urge anybody who, when you think about India and the amount of rural communities, it's an incredible example of what can be done with decentralisation. So it now gives me a great pleasure to hand over to our next session, our journey, experiences in hepatitis elimination, to Dr. Just got to get the page right. Dr. Somaskar, from gastroenterologist and hepatologist from Rashoda Hospital, founder of the Save the Liver Foundation, advancing hepatological care. Over to you.
Thank you very much. I would like to thank Dr. R.P. Shanmugam and Dr. Vivek for giving me this opportunity to talk here. I'm just talking about our journey as a foundation. And obviously, it's going to be a story. Before a story, there will be a prologue. So what I want to say here is, before, I've been practicing as a gastroenterologist and hepatologist for more than 18 years. And during the course, we have been seeing a lot of cirrhosis, decompensation, requiring transplantation. And people are not aware of hepatitis viruses. People think it's only alcohol which causes liver disease, and many of them, only after they present to us and we explain them as this is one more reason they come to know. And we found that this lack of awareness and is the most important cause for seeing all these patients at a later stage. So in 2014, I was practicing in a corporate hospital where we made a habit of screening all patients coming to gastroenterology department for hepatitis B and hepatitis C. And any health check was, they had to include hepatitis B and hepatitis C. So we had a database of hepatitis B and hepatitis C. And to our surprise, we have seen a lot of patients coming from a specific area in Telangana who have been having cirrhosis, early cirrhosis to decompensated cirrhosis. So when we analyzed data of those patients, we have seen most of them were HCV positive, males more than females, and we have history of alcohol intake in few of their males also. So we thought there is a pattern and we need to, we should not stop here. So that's when we thought of addressing this issue. First we thought this awareness, improving the awareness about hepatitis, and if we can screen more patients going back there, we will be able to find out why this is happening and what is the incidence there. So retrospectively, this the place where we found more number of patients coming in was in a mandal. It's a sub-district called Aija in Telangana. So we went back there and we did a screening camp at a mandal headquarters. So this was in 2016 December, where we screened 236 patients, of which 48% were positive for anti-HCV. It was a very high number. What we were actually thinking that 1.5% of population may have hepatitis C, but here it was very, very high. So then each patient, we had taken their phone number, from which village they came and all. We then went back to all, wherever there were positive patients, we tracked back to their respective villages. And it was a tough time for us to convince everyone for getting them screened. So after talking to the village heads, explaining them the importance of screening, these were the people, I mean, these are the few villages where we screened. We have done many more, but I just wanted to highlight higher incidence villages in the same sub-district actually. So almost we have seen around 9 to 14%, 15% of incidence of hepatitis C in these villages. So all of them were in the same sub-district actually. So these were the number of patients. If you see in this total 11 screening camps, what we did, we found around 12.7% as an average, which was very, very high. So we then had to talk to all the positive patients, their family members. We counseled them regarding the virus and need for treatment. In these people, many of them were not able to afford further investigations. At that point of time, we were not very sure of pan-genotypic this thing, so we had to do genotypes, we had to do RNA quantitative. Many of them were not affordable for these tests or treatment. So we didn't have a national hepatitis viral control program at that point of time. So from Save the Liver, we treated almost around 400 patients at that point of time. And we did all these tests for all the patients. We had to go there. We established a center. I mean, we had a doctor there. So in this place, we organized the camps. We had to screen. We did all the tests for 400 people. We collected blood and we had to send it back to Hyderabad for testing. So in these 400 people, after ultrasound and these things, we found at least 40 of them had cirrhosis. It could be early cirrhosis to decompensated cirrhosis. Most of them with decompensated cirrhosis were males, and we found 4 HCC also in those patients. So this was because of lack of awareness about these viruses, a lot of people, they were transmitting to their family members, people around them. So multiple reasons. What we understood there was, number one, there was a lot of tattooing in those areas. Tattooing was being practiced very badly. And unsterilized needle use was one more reason what we found out. These were the 2 things what we could, and because it is there in the community, it was spreading rapidly. So later on, this was informed to the collector in that district, and he encouraged us to go ahead and do some more screening camps. So with the help of the government, collector and the DMHO there, we could do multiple screening camps in surrounding mandals. But to our surprise, we didn't find the similar percentage in surrounding villages. Surrounding mandals actually, not the villages. So we could see somewhere around 1 to 2% of HCV and 2 to 3% of hepatitis B in those mandals. So these people initially, once National Hepatitis Viral Control Program was started, many of them, we could get them to the nodal center, which was in Hyderabad, and started treating them. It was in Usmania General Hospital. With these multiple screening camps, a lot of awareness in the newspapers, and because it was supported by the government officials, the collector and the DMHO, there was a lot of awareness which was created in those mandals, and now voluntarily a lot of people were coming for hepatitis C testing. They were asking. So there were, subsequent years we have seen a lot of people coming voluntarily, getting tested and getting treated because they have awareness about this program and all those things. There are multiple other areas in Andhra Pradesh and Telangana where we have found similar incidents. There is a place called Palakollu in West Godavari district. We have done we have screened 1457 patients, out of which 144 were positive. This is an area which is like a rice bowl of Andhra Pradesh, we say. It's a rich people. So most of them could afford testing, and they got treatment without the foundation's help also. But many of them voluntarily came for testing because in some countries they don't allow if the anti-HCV or hepatitis B is positive. So that's why more number of people we were able to screen in a single go in those places. One more place very close to this Palakolli is Amalapuram, where we screened around 236 patients. Out of them, 28 were positive, like 11.86%. And another place where we had a higher incidence was a place called Rentachintala in Guntur district, where we screened 400 people and 45 were positive for hepatitis C. So this again we went back and talked to them. They had a source which was kind of unsterilized needle use. It was in Rentachintala place. So these are what we have found out, and bringing more awareness by more number of screening camps, and from the government, if there is more and more publicity and awareness camps about these diseases, there are more people coming in for screening. And the biggest challenge of finding the missing millions, what we have been talking for the last 5 to 10 years, we will be able to achieve and bring more number of patients into the treatment group. And because of the availability of hepatitis C treatment, very nice response rates and cure rates, we will be able to eliminate hepatitis C is what I feel. So we faced few hurdles in our journey. Initially, it was very difficult to get more patients even for screening. They were not willing for screening. Once they were educated, and once the government set up, government people like collector and the DMHO has come in, many people came voluntarily for screening. So it is not just a single person or a single institute. The whole government should be addressing this issue, like people were addressing HIV. One simple example, 88% of Indian population got vaccinated for COVID. Why can't we vaccinate 100% of our children who are born for hepatitis B? It's achievable. Only thing is, it should come from the horse's mouth. That's the whole thing. Maybe we will be able to achieve 100% vaccination for our next generation to keep them safe from hepatitis B. And telling people about hepatitis C and bringing them for cure is going to help eradicate hepatitis B and hepatitis C. Thank you.
Congratulations, Somasekar. Two lessons we learned from your anecdote is one, being a clinician, your social responsibility to go and give a screening. And number two is, as we are all been speaking from the morning, the private and the public coordination. I think without the public coordination, it will be difficult for him also to go ahead with testing and treatment. Both these are very mandatory in, at the level of the community. And next we move on for the next talk for evaluating acceptability and usability of hepatitis C self-testing by Dr. Saravanamurthy, a lead from Viral Hepatitis Path Foundation.
Thank you, everyone. So, I remember beginning this summit discussion happened like 6 months back with Dr. Vivek and Dr. Shanmugam, and we started building the agenda from the scratch. So, what I want to share is, over the process, at one point of time, Dr. Vivek said, like, let me take control of the agenda. You please take rest. So by the time, like when he was sharing each time, I used to see my sessions varying like between first day, post-lunch, before lunch, evening, late evening, and next day, second day. So I was anxious about when is my session is actually going to happen. But today, I think it's exactly placed in the right place, because from the morning, the context has been set well placed, And now I'm going to present about the self-testing study which has been conducted by PATH. And everyone able to now relate why and how this self-testing is going to play an important role towards the elimination. So that's the important context that I want to play. Thanks, Dr. Vivek, for this. And so the primary aim of this study was to understand its acceptability and usability of two different self-test kits. One was a blood-based kit, and another was a oral saliva-based kit. So there are two types of kit that we were using. And primarily we were, and both were being clinically evaluated for its sensitivity and specificity, which we are not doing as part of this. So we were just focusing on our acceptability and usability. And which are the population that we studied also, it's very well defined. We selected people who inject drugs because we saw from the morning they are the very highly vulnerable, high risk for the Hep C. And also we considered the injecting and sexual partners of these pivots, people who inject drugs. And the third category of population that we considered is the at-risk general population that we defined, which includes people who are currently on dialysis, who are approaching for ICTC, HIV testing facilities, who are all on country's transfusion. So these are the various categories of people who have been categorized or defined as at-risk population. So these three categories of population has been considered for this study. And we did the study in Uttar Pradesh and Mizoram. And there is a rationale for selecting these two geographies also. As per NFHS reports, Uttar Pradesh is the very low prevalence for hepatitis C, while Mizoram is the highest prevalence for hepatitis C. So, but once we started the process, there is in India, actually we have a long approval process because it's also a multi-country study. So we started with a WHO ERC approval. And by the time we end with our DCGA and HMSC approval, it was almost took 18 months of the time for approvals, which also reflected on our implementation timelines. So the methodology, broadly, like this study has been done in two phases. One is, which started with more of a qualitative, and which is formative assessment, where we conducted some focus group discussions, interviews with the stakeholders, and also the population that we are going to study. But for the interest of the time, I'm restricting myself to the quantitative part of the study, which is the intervention, which was done in follow-up with the qualitative phase. So in the quantitative phase, we did the study in 3 risk groups, again, as I defined, and it was done in hospitals. Like healthcare settings was selected for at-risk general population, whereas for reaching out to the people who inject drugs and their injecting and sexual partners, we went to the community model, and there was a virtual model also we tried, because in the past we had tried this virtual model for HIV self-testing study. So we want to understand what is the response for in the virtual population also. So we developed a structured questionnaire also to understand the risk behavior and vulnerability factors among these study population, which are influencing the uptake or the acceptability of this hepatitis C self-testing kit. So our sample size was based upon calculated on the assumption that 50% of the population would accept this kit. That was the assumption. With that, we calculated our sample size. So broadly, there was some descriptive analysis. We were focusing on our acceptability and usability measurement. Acceptability was the proportion of people who are seeing some benefit of this kit and who are ready to refer this kit to any others, their friends and families, and who are willing to use this kit in future. So these are the 3 measurements that used for acceptability. While usability, we defined as like how easy for this kit to be used and how confident the individual is ready to use in the future. So this is the profile of the people. So if you see, like, as I said, it's been done in Mizoram and Uttar Pradesh. You can see in Mizoram almost it's 50% of both male and female. Whereas in UP, we had more male participation in the study. Well, the median age was 34 years. it was not different between Mizoram and UP. It was the 35 median age in UP and 32 at Mizoram. So the education level also more or less like in high school grade, people have been able to through. So that's the basic minimum education they had. So there are many occupations, but predominantly what is happening, employees and the skilled labor were being considered to be part of this study. So we also explored, as I said, we explored about the knowledge. Since from the morning we were talking about the knowledge aspects, it seems to be the risk perception of these categories of the people. Like when it comes to the at-risk general population, the risk perception who believes that they are under risk, like we categorized into low risk, medium risk, and high risk. There are 68% of the at-risk population believe that they don't have any risk, like people who are from dialysis or people who are going for HIV testing or transfusion. So they are like vulnerable, but they believe they are not under the risk for the hepatitis. Similarly, this is in a Mizoram, whereas in UP, there are 51% of the at-risk population believe that they are under risk. Similarly, when we are coming to the injecting drug users population, so 45% in case of Mizoram believe that they are like they have a medial risk, but they are the high risk group because they are into a regular practice of injecting drugs. So they have, so the risk perception plays a vital role to understand, and this indicates indirectly the knowledge of the people on hepatitis C particularly. So as I described, we considered 3 indicators, whether the people are able to understand the benefit of this kit and whether they will use it in future and recommend it to others. So the overall acceptability in Mizoram among PWAD, which is 54%, whereas in at-risk population, it seems to be around 60%. In Uttar Pradesh, it is 66% among the PWIDs, the acceptability, overall acceptability, whereas it seems to be 75% among the at-risk population in Uttar Pradesh. Similarly, we also calculated about the willingness to pay. So there are people who are willing to pay, and the major category of people are willing to pay between rupees of 100 to 250, which is equivalent to USD 1.16 to 2.89. So that is the amount of they are ready to pay. Otherwise, they want to have subsidized for the kit access. And we also compared between the blood-based kit users and the saliva-based kit users. It seems like those who are using saliva-based kit have preferred more for an unassisted approach. They can use the kit on their own, while the people who are still having the blood-based kit, they still look for some assistance from a healthcare provider. So this is regarding the usability, which is again indicated by the way whether it is easy to use and how confident they perform in the future. So it seems like among the injecting drug users, it's 91% of them are confident, they believe like it could be used. They can perform it on their own. While in, which is in Mizoram, and in Uttar Pradesh, 86%. So almost 85% of them among the IDUs believe that they can use it in future on their own. Among the at-risk population, it's around 90% of the population believe that they can use it on their own, the self-testing kits. So they also given an opportunity to go through the information for use, which is as part of the pack insert like in the kit. So there are people who have been confident about understanding the kit because it much before the study has been started. Even the pack insert has been simplified for the local understanding with the Hindi translated materials available. So materials were available both in English and Hindi. So similarly, the demonstration, a video demonstration was also prepared as part of the study, which has also been used for making them to understand. So that also viewed and responded as a satisfactory material for understanding. So as a follow-up, because in the initial, on the design of the study, there was a concern that people might get into attempting to a suicide note. So those kind of concerns were there from the program people. So there was a conscious effort to understand, is there any social harms being caused by usage of these kits as part of the study. We were reaching out report like 19%, which is around feeling anxious about their own results after testing, whether it is going to be a confirmatory positive or what is going to be. That kind of anxiousness they felt. And 2% felt about feeling a fear, because the fear is primarily about disclosing the result to their friends or family. So that was the concern, major concern. So as point of the study, like we have also prepared some what would the counseling materials should be available, also been part of the study. So we also analyzed about the bivariate analysis for the factors that are associated with the acceptability and usability. Among the injecting drug users, it seems to be gender, education, and the assisted versus unassisted approach, and the HCV result also plays a role in acceptability of this kit. Whereas the gender and education plays role for the usability of this kit among the injecting drug users. In case of at-risk population, the gender, age, education, and the assisted versus unassisted approach for the acceptability is associated, while education seems to be associated with the usability of the kit. So this is my study team and the partners. So thanks to all of them. It's because, as I said, the approval time took a lot of time, but the implementation was done in a very quick manner because of all this team support. So thanks to them. Thank you.
Thank you, sir. It is open to discussion. Any comments on this? Sir, if it is not there, shall I ask you a question? What is the actual cost and is it available in India, sir?
Okay, so that's a challenge. So because the manufacturers are not too ready to want to share the cost at this point of time when the kit is not available in the market and the government is not given any approval for the kit. So once the approval is available from the DCGI in the country, so they are ready to reveal the kit's cost for the country.
Well, I have experience of using the oral test and peers using them and self-testing as well. And actually, yeah, great, but there are restrictions. So you can't eat for a certain amount of time beforehand. The more people you test, the more antibodies you're going to get back, and then you've got to RNA. So there were some difficulties, but there were far more, the benefits far outweighed. Particularly, we did a program in prisons where prisoners tested other prisoners. So, that was fantastic. So I think that we have to be aware of the good and the bad on everything, don't we? But it is a really, really great solution. Yeah. I wonder, does anybody, oh, yes, we have a question. Brilliant.
I would like to ask Dr. Somsekhar Rao, very nice work, what you have done is wonderful. The problem is, did you do HIV testing simultaneously? Were you allowed to do that? Why I'm asking this, we were doing a lot of screening in many areas of Tamil Nadu. At that time, there is one place called Namakkal near Salem. That place is a lot of truck drivers used to come because the truck building center, the bodybuilding center. So there, the HIV is very highly prevalent. We didn't do that test. But we did a hepatitis B and C. C was highly prevalent, nearly about 17% was a number. Whereas in other areas where we have gone through entire area of Tamil Nadu, it is only 1 to 2%. It's varying from place to place. But 17% where the HIV is very highly prevalent.
In these people, only in people who had cirrhosis of liver, we did HIV, sir. Rest of the screening, total patients, we did not do the HIV.
Because it go together. That's what we have observed.
Only in patients who had cirrhosis of liver, we did HIV because we were following them even later. Others we didn't.
It's a very difficult situation, I know. If you do without their knowledge, they are all upset and you will not be able to proceed further. Yeah. But if you do with their knowledge, they are scared that the family will come to know and then they are shattered.
Initial days, even getting few people in a village was very difficult, sir. We were actually almost behind them. We used to get 10 to 15 patients in a village of 500 people. So only after talking to them, we got some 200, 150 people like that in each village.
Thank you.
Oh, looks like we've got one more question coming.
My question to Dr. Saravamurthy, sir. Like, PATH has implemented HIV self-testing as well as HCV self-testing as a pilot in India. So, they have adopted different models while implementing these two projects. For example, private practitioner model, community-led model, to target the at-risk population groups. So, I'd like to know in what way it differs, or because the dynamics of transmission is more or less similar. So in that perspective, I just want to know which model helps us to take up the initiative on hepatitis, to the next level.
Thank you. So actually, compared to HIV self-testing study, the hepatitis C self-testing study doesn't use much different models. But in case of injecting drug users, we preferred, like we went to de-addiction centers. We also used HIV prevention program facilities and also the OST facilities. So these are various different facilities, but predominantly wherever already injecting drug users already accessing the services have been used as the phase to reach out to the population. So that become, so to our understanding now, the IRCA, which is de-addiction facility in Uttar Pradesh, and similarly the OST facilities in the Mizoram, that becomes the better model for the injecting drug users population because of the continuity of the cascade, because it's not about just the testing, it's about the overall treatment cascade also may be easy to complete for this particular population. So one of our presenters also talked about this previously. So it would be, I think from Mumbai he was talking. So there should be a constant advocacy towards the ministry. Like for example, for this dissemination of this study also, we invited Ministry of Social Justice, and we are going to continuously talk with them to have a de-addiction and OST-based testing and treatment for hepatitis C. So that would be a better model for injecting drug users. Yes.
How many women are in the part of this study, sir, in the path?
Yeah, very few women users were there. We didn't make any constant effort to avoid them, but in Mizoram and Mizoram only we were able to make some women reach to some women, but UP we could not be able to reach out to some women. But there are, as part of the qualitative part of the study, we reached out to some female IDUs specifically to understand the perspective also, but that has been covered as part of the qualitative study. Yes.
The same thing can be also what the sir was saying, that in HIV positive people, self-testing on hepatitis. So can it works, or it is?
It works because there have been, like, as I said, within the hospitals, at-risk general population, we have taken PLHIV on treatment is also been part of this study. So we are yet to analyze by category wise of these population. We will definitely disseminate that findings also once it's available.
Because in the for women in Chennai, for the cervical cancer, it is integrated to the health system, but other places it is not. For example, in the Adayar Cancer Institute, they also did the HIV testing when there is actually for cervical cancer. Similarly, HPV testing for cervical cancer, because it is one of the way of transmit HPV virus also through sexual route. So can that happen or not happen? Like how the, because I want to ask previous panel itself, due to time.
Yeah, I'm so sorry, we're running out of time.
Yeah, sorry.
No, it's absolutely
how
fine.
it can be integrated with whatever non-communicable diseases.
Yeah. So I think convergence for each and every disease, like that's what most of the people were talking. Yes, convergence as an approach for this multiple disease for the population that is required, particularly PL-HIV, or it could be IDUs, or it could be transgender population. So convergence for multiple disease, it's the way ahead. But how to do it, that's what people are presenting about implementation research and the government willingness and the program's collaborative way of functioning. These all the approaches I think.
Evidence is there for. Evidence
Sorry,
is
we have to close the session. I'm so sorry. Maybe you can talk afterwards. Just as we're closing this session, one word, brilliant panelists, thank you so much. One word or one sentence, just quickly, what would you say to everybody in terms of the fantastic work that you've done? What would you say to somebody in another area about how they could do your piece of work? But you've literally got 10 seconds to say it. Tricky.
As I have already mentioned during my presentation, in order to address those gaps that which I was highlighted, there is a need for community engagement with allocation of this one budget in the National Viral Hepatitis Control Program. Otherwise, reaching the elimination target may be a little difficult for us. Thank you.
Thank you.
Yeah, from this study experience, I would say like having this HCV testing, and not only HCV, even HPV vaccination could be done from the OST facilities and the de-addiction facilities should be the way to go if we want to march towards the elimination.
Thank you.
I would suggest everyone in this hall should encourage at least 1,000 people to get themselves, or those 1,000 people to get hepatitis B and hepatitis C testing voluntarily done, and all those 1,000 people should be vaccinated for hepatitis B. Thank you.
Fantastic. And I'm going to leave the last word to my co-host. So thank you very much from me and my fantastic co-host. I'm going to hand to you for the last word.
Thank you, one and all. It was a very entertaining session and enlightening also. Thank you.
Can we give our chairs and all of our speakers a big round of applause? And requesting our chairs to please do the honors and present our speakers with a token of our appreciation. Calling on Dr. Ganesh Kumar. Okay, can we bring the token of appreciation for our chairs, please? So, ladies and gentlemen, we now move on to our final session of the day, which focuses on industry perspectives on innovations in hepatitis care. This session will be chaired by Dr. Sumati and Dr. Balasubramaniam. So let's please give them a big round of applause as they take the stage. And calling upon from EchoSense, Dr. Murugan, hepatologist, Apollo Hospital, and Mix Yashwinder Singh. Let's give all of our presenters and our chairs a big round of applause.
So good evening, everyone. This is an important session. because the industry involvement and medical devices, point of care, and then industry participation to actually on the new test, they're all very, very important. In fact, actually, working in the field of disease biology for a long time, I know that actually all the funding agencies, the Indian funding agencies now promoting the medical devices, point of care devices, so that actually the health actually will be extended to all parts of the country.
Since morning we have been discussing all the strategies of elimination of hepatitis B and C and other viruses by 2030 through integration of public and private sector along with the collaboration of even national and foreign agencies. And I think the first session is a point of care in innovations through FibroScan. FibroScan is, we all know it's a non-invasive replacing liver biopsy. We have none other than Dr. Murugan sir, who is a person who can give all the information that is needed for the about the FibroScan. Thank you, sir. Please, I invite you to.
Thank you.
deliver
Thank you,
the
Dr.
lecture.
Sumati. So I'm going to bring a different perspective to viral hepatitis. I'm representing FibroScan, but I don't work for them, so there's no financial disclosure. I've been asked to give this talk more as an end user of these technologies. So mainly how to use these technologies in viral hepatitis as an end user, more in the perspective of patients with established liver disease. We are talking about public health and community screening and elimination of virus, but a significant proportion will already have liver disease at the time of screening, and these technologies help to manage these patients. So no financial disclosures. So as you all know, or at least some of you will know, that most of the diseases that affect the liver start to scar the liver, and this process is called fibrosis. There are different stages of fibrosis, and the end stage of fibrosis is called cirrhosis. Liver cirrhosis is quite a serious condition with a high mortality. Most of them will either die or need transplantation. So the goal is to eliminate all these illnesses before they get fibrosis. But once they get fibrosis, we need a process how to monitor them and how to identify them. Traditionally, we use liver biopsy to establish fibrosis and grade them from 1, 2, 3, 4. There are different grading systems, but the one mostly used is called the Metavir system, which was a French-designed system. And there are 4 grades of fibrosis. The last grade is called cirrhosis. This is based on the Metavir system. It is also important because once you get cirrhosis, you get a condition called portal hypertension. There's very high pressure around the liver in the portal veins. And this portal hypertension drives the liver disease forwards, making them more and more sick. And the portal hypertension increases with the increasing levels of fibrosis. So all this needed invasive testing with biopsy, HVPG measurements, etc., to make a diagnosis. But now we are moving to the era of non-invasive liver disease assessment in the last, say, 5 to 10 years. And this has been done either through blood tests, simple blood tests like platelet count, LFT test, and you get scores called the APRI score and the FIB4 score, which are an indirect assessment of liver fibrosis. But the imaging has made rapid grounds in this area of non-invasive liver fibrosis assessment. And a pioneer in this area is elastography, also known as transient elastography or FibroScan. And I've been using this for the last 10 years or so since the inception. So that's what I'm going to talk about. There are other tools also to check liver fibrosis non-invasively using ultrasound and MRI as well. We are increasingly using these non-invasive tests also to kind of measure the level of portal hypertension in a particular patient so that we can guide our treatment properly. So how accurate are these tests? So the third and fourth bars represent the transient elastography of FibroScan and the MRI scan. And the First and second bars represent the blood test, FIB4 and the fibrosis score, NAFLD fibrosis score. Generally, it is felt that the blood-based biomarkers to measure fibrosis is accurate for no fibrosis or cirrhosis to the extent of, we call it OROC. OROC is the area under receiver operating curve, which is a degree of accuracy of the test, roughly around 0.8, which is good. But the imaging tests are slightly better. They go up to 0.85 to 0.9. An MRI may be slightly better than other imaging techniques. So overall, blood-based markers are useful as a screening tool, but imaging markers and MRI may be a little more accurate. The current recommendation is to combine the two, use both biomarkers and imaging markers wherever available. And if both correlate as having fibrosis or no fibrosis, then the accuracy is almost 95%. So FibroScan is a pioneer in this area of non-invasive liver fibrosis management. It is kind of considered as a reference standard. I wouldn't say gold standard, but it is a reference standard. And there are many reasons for this. They were one of the early people to start this technology. Almost 20 years ago, and in the last 12 to 15 years, there's been a lot of work in this area. But more importantly, when we talk about point-of-care tests or simple-to-use tests, this is a bedside test which most clinics can have. Even in my hospital, we have it in the OP, and you just scan the patient and you get the results immediately, and fairly accurate. So it's bedside, it is fast, it is accurate, it is reproducible. It's easy to learn, and it can be reproduced fairly accurately, and it is repeatable. You can't keep doing biopsy every 6 months or 1 year, but you can do a scan as many times as you want. The only limiting factor may be cost. So it has become, FibroScan particularly has become a reference for liver fibrosis. And now we are increasingly using it for liver steatosis or liver fat assessment. As many of you may know, fatty liver or metabolic associated fatty liver disease is becoming the #1 cause of liver disease worldwide. It's overtaking viral hepatitis in a way that is good because we are here to eliminate viral hepatitis, and it is going down. And it is becoming the leading cause for liver transplant around the world, including India. So FibroScan has a lead in that as well. And the other reason why it is a reference standard is the number of publications. Huge volume of publications, and now being accepted by most guidelines as a reference standard. So there are 3 areas of capability for the FibroScan. One is the LSM, or the liver stiffness measurement, which gives you an idea about the level of fibrosis in a patient. Second is called the CAP, or the controlled attenuation parameter, which is a semi-quantitative assessment of the amount of fat in the liver. And the new technology, which we have just got a few months back, is the spleen stiffness measurement, which will give you a reasonably accurate estimation of portal hypertension in a patient, which previously needed invasive testing to diagnose. So you can combine all 3 or use whichever parameters are appropriate for the patient. So it's a very useful technology to have if it is available in your institution. So the current guidelines also reflect the transient elastography values or the FibroScan values as a reference standard. There was a discussion about the WHO guidelines. So they also have, in the new guidelines, recommended that not only you want to know the virus and the viral characteristics, you also need to know how much liver involvement the patient has. So one thing you should remember when you're trying to treat viral hepatitis is some of them may already have cirrhosis, some of them may already have fibrosis. And it may not be apparent by the screening tests that we do. If you simply do viral tests and treat them, they may already have cirrhosis that may need independent treatment in spite of viral eradication. So it's important to know at any time when you screen somebody, it may be hard to do in a community setup, but it is important to know to what level the liver has been affected. So you can use, as per the WHO recommendation, you can use a simple screening test like APRI. So you just need a blood test. You have to measure platelet count and AST level, and you get APRI. And they have recommended transendoral elastography as a reference standard for an imaging test. And they've given cutoffs. Above 7 is F2 fibrosis, above 12.5 is cirrhosis, and similarly APRI 0.5 and 1. So APRI may be too basic a test because there's a lot of inherent errors and accuracy rate of around 70%. So if there is access to technology like FibroScan, the accuracy improves. And I don't want to go into the treatment guidelines. There was some discussion earlier about it, about the pros and cons. But the WHO has expanded the treatment to include that if you have F2 fibrosis at any level of viral DNA, you can consider treatment. So the level of liver fibrosis is coming into the treatment guidelines for hepatitis B, which was already existing earlier, but the criteria were a little more stringent. Now WHO is trying to expand the criteria to include more patients to be treated. Similarly, for hepatitis C, the goal is to screen and identify patients with hepatitis C, find out whether they have current infection by doing an RNA, and then link them to care. So once you link them to care, it is useful and probably important to do a non-invasive test to see if they have any level of fibrosis or even cirrhosis. And even for that, the American Association, IDSA, and even WHO recommends elastography as an initial tool. So I'll quickly finish with a couple of slides. It may not be relevant specifically to what we are discussing, but FibroScan is also useful for non-invasive assessment of portal hypertension. There is a part of the liver history, the liver disease progression, which is called clinically significant portal hypertension, beyond which a patient can deteriorate very fast into liver failure. This can be picked up non-invasively using FibroScan by combining the liver stiffness measurement and the platelet count. So you can either rule out clinically significant portal hypertension or rule in clinically significant portal hypertension, and the treatment changes depending on what the patient has. So I'll conclude to say non-invasive liver assessment has replaced liver biopsy in assessing liver disease in clinical practice. Point of care tests may include blood tests, which may be simple tests to assess liver fibrosis, or even rapid assays like HCV assay, HBV assay, and also imaging-based tests. VCTE or FibroScan is a reference standard for non-invasive liver assessment based on imaging. FibroScan can assess fat content, fibrosis staging in the liver, and also assessment of portal hypertension. So current guidelines reflect this and recommend fibrosis staging in all patients with viral hepatitis. And using these non-invasive tests, serial monitoring is possible, and these tests are fairly accurate to be used in clinical practice. Thank you.
Thank you, Dr. Murugan, for this excellent work. The next speaker is Ashwinder Singh, and she's a public health expert and social activities, and she's going to talk on glucoprevir and pibrenavast for hepatitis C in India. Over to you, madam.
Thank you, sir, and very good evening, Vanakkam. I'm Yashwinder, and it's my pleasure to be here with all of you. I am going to talk about GP, which is glucoprevir and pibrenavir. We say GP. So my presentation is very, very small. It's not going to be very long. I know it's the end of the day and all of you are in hurry to go back. So I will not be kind of a barrier in that. But yeah, I'll just cover in 3 slides. What is the current status of drugs in India? What is GP? What are its benefits? Why we need it? And if we need it, then what we have to do? So these 3 simple things are there. And so currently, if we talk about India, you know that India has a large burden, of disease. But if we talk about genotype 3, which is the dominating strain here, approximately 60 to 70% cases are from genotype 3. And we have approximately 6 to 11 million people who are affected in our country by that genotype. Further, there is a high risk of complications like cirrhosis and liver cancer, which is also because there is a delayed treatment. People don't easily, go for screening. They don't reach timely. So, all these burdens are kind of, adding up. So what are the gaps if we talk about quickly? One and foremost is, I think, the longer treatments, because this is also one of the challenge. And let me tell you, ladies and gentlemen, if you go to field, you will find number of patients. If there are 10 patients, 6 or 7 patients will opt to go for a quack. They may not like to come for a medical, or allopathy treatment, but they would love to go for anybody who is doing some magic thing, who is doing some, local Ayurvedic pill, anything, any sort of thing which they are doing. And that is the fact. So now, if a person is coming, for the treatment, I think the longer treatment, which means, if it's taking longer time, it's always a challenge. How it's a challenge? Because mostly what happens that people when come, there is a tendency, where people tend to lose, there is a treatment adherence issues, which we have often seen. So that is, I think, a challenge which we are facing with in our treatments which are available now. So now what GP can do here? Actually, GP can do wonders, and this is not what I feel, this is what, studies have shown, this is what our communities are talking about. And when I say communities, not necessarily only transgender people, I'm using the pictures of only, transgender people, but this is for all the communities, who are affected by hepatitis C, viral hepatitis. So, first and foremost thing, as we've seen, that 98% cure rate in case of genotype 3, which is the largest dominating strain in our country. So treatment efficacy is much higher, here we see. Where generally we know in Sofodeca it's minimum 12 weeks, here it's 8 weeks. So again, reducing the time of the treatment. Further, recent studies have observed that people with even 4 weeks of treatment have shown that, 84% of people have shown that, that there is no, there is a cleaning of the virus from their bodies. It is very effective for renal impairment patients. Now, this is very important for us because, in our country, there are people, who are either people living with HIV, people who are, having the high burden on the kidney as well. So those kinds of patients, who need a certain kind of, regimen which will not impact their kidneys harshly. In that case, I think this is the best drug which is available to them. It has been recommended by WHO for the first line and second line treatment. And I said in the beginning that for communities, now specifically I'm talking about the communities which are known for HIV or the high risk groups. I think over there we need to, definitely longer treatment. There are adherence issues. If treatment is shorter in case of, prisons, in case of, people who use drug, then obviously it's going to be a game changer for us. Now, what are the barriers if we talk about? I think the first and foremost barrier is that GP is not registered and is not included in the treatment guidelines. Patent restrictions are there which are delaying the generic availability in the country, which is a challenge. Healthcare infrastructure, we all know, that is, I think, across all the diseases. I'll skip this point in the paucity of time. Proposed solutions, I'll come to next slide, which is basically, call for action. What we need to do now. And I'm very, very hopeful, sir, because this is the platform where I see all the experts, all the scientists, all top-notch people are sitting. And I think these are the platforms, where we have seen in the past, in HIV, disease, a lot of wonderful decisions were made. So I'm hoping that similar sort of, things would definitely be kind of, ripe out from such a wonderful platform. First and foremost, I think we need to call AB to add it into MPP licenses so that, we can have, licenses for the generic medicines. Include oral GP in hepatitis guidelines as per the WHO recommendations. What the communities can do, maybe, because also there is not much awareness. So maybe, inform the stakeholder on availability of oral GP that is available there. I think the demand generation specifically, keeping people who have genotype 3 in their mind and also the high-risk communities, because these are the one where we need to really, focus upon if we really want to achieve the 2030 elimination goals. And ending by saying that it is a collaborative goal where we have to go together. And trust me, we have done wonders as communities in HIV program, and I'm very sure that we together will eliminate HCV by 2030 if we work together and in with same spirit. Thank you very much.
Yeah, it's a very good lecture. And any questions, please?
This is to Dr. Murugan. Sometimes when we do serial fibro scan for the patients who is coming often to us, there is a variation. You just say about 30 kPa in the beginning. After a couple of months, we do it later, even with a supportive treatment and advice to the diet and all. It comes down to, say, 25 or so. Does it go up again? Is there a variation in the fibrosis process, or there is a variation in the finding of the by machine? Is it accurate, or what's happening?
Thank you, sir. There is an error rate of around 10%, so there will be some small variations. But if you look broadly at classifications, like if it is F2 or F3, F4 or F4, it will fit into that pattern. And also, certainly in viral hepatitis and also in fatty liver, in the initial period, there is always some inflammation, which increases the stiffness value by, say, 20%. So once the inflammation settles down, then it comes to a steady state fibrosis. We have also seen fibrosis improve in all etiologies, whether it's viral hepatitis or fatty liver. So you can expect some reduction in the stiffness, but it will still be in the F4. Sometimes even F4 can come to F3, F2. That has also been seen, particularly with fatty liver. But if you're saying 25 and 30, they both come under established cirrhosis. But there can be reduction in stiffness, either due to reduced inflammation or even reduction in the thickness of fibrosis that has been seen. So you have to keep it in the context of what you're trying to do. But there are errors technical errors are there to the extent of 5 to 10%. But when you want to rule out any fibrosis, F0 or F4, the accuracy is better. In the middle grade, there is some variations.
Dr. Murugan, I just want to ask one question actually. And I was sitting in a lot of ICMR meetings recently. I'm also ICMR emeritus scientist. There is a lot of actually need for actually country-specific reference intervals and reference intervals of clinical biomarkers, markers kind of thing, starting from hemogram to actually special assays. In the fibroscan, whether it is actually a LSM or SSM or CAP, is there any country-specific actually cutoffs?
There shouldn't be much variation country-specific.
Because
I don't think...
it needs to be tested because recently ICMR has started a new initiative. I call it as Terrific Challenges of TERIF. Task Force on Reference Intervals in Indian Population. There are about 60 actually clinical parameters they mentioned. So particularly the APRI or liver function test and then fibroscan, I think somebody can actually look at the actually country-specific or population-specific actually cutoffs. That would be nice.
Yeah. I don't think they have looked at it in that way, but when you look at the general studies from India and other countries, the cutoff seems similar because many times they're correlating with liver biopsy to get an accurate cutoff. It seems to be similar, so there is no detected variation according to the country or racial characteristics, but I don't think anybody has done a study like that.
I think that is a proposal.
Sure.
Sir, I have a question for you, sir. If the fibroscan value is less than 7, how long or how frequent should we do the periodical fibroscan? Is it every 6 months to 1 year or 3 months to 6? Because it is a dynamic process at times.
Sure, I agree. So when we are screening for portal hypertension and follow-up of portal hypertension, current recommendation is around yearly once. We are still using liver stiffness measurement along with platelet surrogate markers to determine the level of portal hypertension. Maybe spleen stiffness can be used. We have started using it, but there are no clear guidelines to the scoring, what score to use to give a correct, accurate value. So yearly once. If you're following for fatty liver and MSLD, again 6 months. 6 months is actually too early for any change. 1 or 2 years. If there is no fibrosis and you're worried that there may be progression, you can do after 2 years. If there is some fibrosis or cirrhosis and you're screening them, then yearly once you can do.
Thank you, sir. One question to Ashwinda. When will these GPs likely to come to India? If it's so, will it replace existing SOFOs and DACLA or Valthu, or only will be a drug, second and third line drug?
Thank you. I think it's a very good question. Will it replace or not? I think it's difficult to say now, but I strongly believe that, you know, being the beneficiary, being the patient or the communities, you know, we should have options. Okay, we want to go for option 1, 2 or 3. I think that is how I foresee as of now, but yeah, over the time period, we have seen that, you know, how interferons were replaced by SOFO-DECA because advancement, the innovations are happening. But one thing for sure, I would wish to see that the long-acting DAs, if are coming, that will be a game changer for sure. Thank you.
Any questions from the audience?
Yes, thank you. I'm specifically coming to Yashwinder's presentation on GP, glycepravir, pivotesvir, and we have other drugs which are also licensed but not have entered the market because of different limitations. We also have voxilapravir, Vosevi. The license has been there for a long period of time, but the Indian generics have not taken that up to manufacture that and sell it across the licensed territories. Similar is the GP situation. One of the peculiarity in the GP situation, and I think I would slightly differ from the presentation, is not for the community to ask FV to add India. India is an excluded territory in the GP license, meaning India can manufacture it, but it cannot sell it in India. 4 Indian companies have taken this license, and it has been ongoing from 2018. There has been a modification on this license to add 4 countries, take out 4 countries and add Sudan, I think that was in 2019. So it is not new. It is there for the last 6-7 years. But it is not for the Indian community to ask FV to add India. It has its own implications in terms of regulatory processes outside of India, because even if these manufacturers in India, the licensees, manufacturers in India, they will not get a COP to register it in other countries. I think it's around 93 or 98 countries that are included. CDSCO perhaps will not give that COPP because that product is not marketed in India, although manufactured in India. So the articulation should be for MPP, be it the expert advisory group, be it the community representatives there, be it the board, to talk to AV, to negotiate with AV, to relook at the license terms and, you know, expand the territory. Not only India. India is important because manufacturing countries should be able to access that medication. So that is one of the things. So it's for MPP to step up and negotiate after 7-8 years. Look, we haven't progressed. How do we renegotiate now on the license terms, inclusive of the territories? That's one. The second portion is on the treatment duration. I think it will not be appropriate to look at only that 8 weeks because that's applicable only to non-cirrhotic patients. And especially in genotype 3, if you are already cirrhotic, and unfortunately, again, we don't have the data in India to segregate and see how many of these people, 300,000 we have treated, Hep B, Hep C, are actually cirrhotic or non-cirrhotic. Unfortunately, we don't have that national data. But if that is the case, and India has majority genotype 3, treatment is going to be 16 weeks. The API for protease inhibitors, which is one of the components, glycepravir, is always expensive than an S5A or an S5B. The cost is going to be far more higher. So these are some of the things I think we have to also look at when we take this to policymakers in India to say, okay, what if India is included? How are we going to take on, this one? They're buying soft dakla at $15 or $40 now. Global price is around $60. So whether the Indian government at this point will be willing to step up to foot that bill to say, okay, we're willing to take on this, unless there is significant clinical advantages both for the patient and the practitioner and also the national program. Thank you.
Yeah, please.
My question to Dr. Murugan, sir, please. Sir, what we have seen that now many people are doing fibroscan in a camp-based manner in many small clinics or otherwise. And the machine cost is only 30 lakhs or 40 lakhs. But in hospital like your Apollo and all these machines are costing, I believe, 1.3 CR or 1.5 or 2 CR. Is there a difference between these two machines? One is camp-based machine, one is hospital-based machine. And the result of these machines is same or it is different?
I think the smaller machines have less capability. So most of the portable machines, they do only liver stiffness measurement, which is enough for most purposes. But CAP, I think recently they've added to the 430, but earlier they did not have CAP. CAP is a measurement of fat. And the spleen stiffness, again, is a new addition, which the bigger or the higher end machines have. So it's more the capability of the machine rather than the accuracy, because accuracy should be the same.
Another issue is that can you do fibroscan in pregnant women or fasting? How much fasting is necessary in the
now they have approved for pregnant women. There was some doubt, but there's enough data to approve. There was a concern about cardiac devices, particularly defibrillators. Pacemakers, now they're allowing. Defibrillators, they're allowing with a warning to the patient. So now there is no contraindication for fibroscan. This is as per the 23 guidelines. Some precautions have to be taken, at least 3 hours of fasting, because when you have a full stomach, the portal blood flow increases. That will increase the stiffness by 20%. So you may get a slightly higher value. So at least 3 hours of fasting is recommended. Pregnant women, sometimes if they are late into the pregnancy, the accuracy may be limited. And if you have ascites, the accuracy is not good. Even very obese patient, 35 BMI accuracy is not good, even with the Excel probe. So there are some limitations accordingly, you have to use it. I think 95% of the time it is usable. There are a small group of patients where you may choose not to do it.
Dr. Murugan,
thank you, sir.
One more thing actually. I was recently reading about guided the vibration control TE. So how far it is increasing the,
We don't have it. It was just introduced 2-3 months back. Basically, to get the correct position, there's some expertise required, which is not difficult to learn. Mostly technicians or nurses, we have physician assistants or technicians doing it. So you need about 100 to get certified, but if you do 500, you can be reasonably confident. So the guided VCTE shortens that process. The machine will tell you if the position is accurate or not. But it's not difficult to learn. So if you're going to buy it now, it comes automatically with guided VCTE. But you don't have to buy a new machine just for that. It's something like the iPhone upgrade. There'll be a 10% upgrade, but you can still manage.
It enhances the diagnosis of
so the
fibroscan.
Newer machines always come with guided. So your learning process is made easier.
Any other questions from the audience? Please.
Thank you both the speakers for the excellent lecture, very short and very crisp and very nice. I learned a lot and I thank my co-chairperson as well. Thank you. Thank you the organizing committee for giving us the opportunity as well.
Yeah. Thank you everyone.
A big thank you to our chairs and all of our presenters for that session. I request our chairs to now do the honors and present a token of appreciation to our other speakers for this session. If you would please do the honors. And I call upon Mila Maistat to present a token of appreciation to our chairs for this session. Thank you so much to all of our dignitaries on stage for a wonderful session. And thank you all of you for being such an engaged and thoughtful audience. Your participation has helped to make this summit a success. But of course, ladies and gentlemen, the day doesn't end here. We invite all of you to join us for a gala evening where you'll have a chance to unwind and enjoy some great entertainment and of course, continue to build connections in a more relaxed setting. So we have tea served outside, so please do enjoy some refreshments. And we also have a special surprise for all of you. And a reminder that tomorrow you will have a no HEP meeting here from 8:30 to 9:30 in the same space. But for now, we'll take a break. We'll have all of you relax and enjoy our special surprise that we have planned for you outside while we set up the stage for the gala dinner. And we'll have all of you all join us back here shortly. Thank you so much. Please do step outside and enjoy some coffee and tea in the pre-function area. Thank you, ladies and gentlemen.
வயலில் செக் பண்ணிக்கலாம். பாரு.
ரொம்ப லவுட் ஆகிட போகுது.
ரொம்ப லவுடாக இருக்கா?
லவுட் ஆகிட போகுதுன்ற.
இல்லை இப்போ பேர் பண்ணி கேட்குதா? ஃப்ரண்ட்டில் ரெண்டுமே கேட்குதா உனக்கு? கேட்கல, ஒன்று கேட்கல. Anantu, you and Sumesh just do some jamming. We'll out for the left right கேக்குதா? லெவல் ஓகேவா? ஓகே. So Sumesh, yeah. உனக்கு அனந்து லெவல் இஸ் ஓகேல?
Yeah.
அனந்து உனக்கு சுமேஷ் ஏதாவது வேணுமா? ஷோர்? இல்லைன்னா கொஞ்சம் எல்லாம் கிக் மாதிரி ஏதாவது வேணுமா?
Yeah, overall 20%. மிருதங்கம் லெஃப்ட் ஜாஸ்தியாக இருக்குது, ரைட் வேணும். லெஃப்ட் கம்மி பண்ணலாம். லெஃப்ட் இஸ் டூ லவுட். லெஃப்ட் இஸ் ஸ்டில் லவுட்.
Still louder?
நான் லெஃப்ட் ஸ்க்ராட்ச் பண்றேன்.
Yeah, yeah.
ரொம்ப லவுடா இருக்கு.
Check.
Loud, loud. Still not loud.
ஒண்ணும் குறையற மாதிரி தெரியல இதுல. Yeah, yes, loud.
Okay.
Check with the PA.
PA கம்மி பண்ணலாம்.
Kami pannalam.
Yeah.
Super.
Medium okay?
I'm good.
Hands-on மட்டும் வாசி.
Handsonic level கொஞ்சம் இருக்கலாம்.
It's louder Anandu.
எனக்கு வேணும்.
Louder.
I want more handsonic. Yeah. Super.
அப்படியே வாசிட்டு இருக்கு. உனக்கு கப்பம் கேக்குதா மானிட்டர்ல?
கேக்குது.
Words யாருக்கும் வேண்டாம்ல?
No.
கீபோர்ட் மட்டும் பண்ணிடலாம்.
Bro.
சூப்பர். வாங்க.
வயலின் ஆக்ஸ் 1ல கொஞ்சம் ஏற்றுங்க.
Check.
A very good evening once again, ladies and gentlemen. It's nice to see a lot of smiling faces in the audience. It's been an intense, power-packed day with a lot of sharing of insights and learning. So I hope that this evening everyone's in the mood to enjoy themselves and let their hair down. We have a fabulous lineup for you. So we would like to dive right into things with our first artists that I would like to invite on stage. Get ready to immerse yourselves in an incredible musical journey with this exceptional band. This evening we have on the violin the immensely talented Ananthakrishnan, who has had the privilege of accompanying many Carnatic music legends and continues to share the stage with senior artists across major sabhas in India. He also lends his artistry to popular films, blending classical and contemporary music seamlessly. On keyboard this evening, yes, a round of applause. On keyboard this evening, we have Ravi G, one of Chennai's most sought-after musicians, an incredibly popular keyboard player, programmer, composer, vocalist, and mridangam player with unmatched versatility and depth. And on percussion, we're joined by Sumesh Narayanan, an award-winning musician and producer with a career spanning over 20 years. With over 2,000 phenomenal performances and numerous collaborations, his rhythms have been celebrated worldwide. Together, they are ready to deliver a music experience like no other. So ladies and gentlemen, please put your hands together. Let's welcome them to the stage. Can we give them a big round of applause and make some noise?
Sí.
Check, check. Good evening, ladies and gentlemen. We are the band Dignitary. We are here to perform some classical fusion music and some cine songs as well for you guys tonight. Thank you, Indian Hepatitis Summit, for having us. It's such an honor for us to be playing here. Hope you enjoy the music. So that was a classical composition, Raghuvam Susuda, which was also having A.R. Rahman's classic Kandu Konten in between. We move on to the next. Oh, before that, we played Ennavale. We started off with Ennavale and went into Nan Pide, another classical number. The next song that we are going to play is a Maestro's classic. I would like you to recognize the song instead of me saying it. Thanks.
Thank you.
Thank you. I hope you recognized what song I played. Thank you so much for that. We've come to the last song for this set. We're going to be playing a Hindi classical number, which is also a very famous song, and I hope you all enjoy it. Thanks.
Thank you.
Thank you, ladies and gentlemen. Please don't go anywhere. We'll be back soon. Thanks.
Check. Ladies and gentlemen, can we give the band a big, big round of applause for a fabulous start to the evening? And now we have a mesmerizing traditional dance performance by the Rock Academy of Dance. Team Sakhyam presents Nritya Tarangini, a vibrant confluence of India's classical dance forms. From the sculpted grace of Bharatnatyam to the lyrical beauty of Mohiniyattam, the rhythmic storytelling of Kathak to the intricate sculpturesque movements of Odissi, each performance reflects the soul of India. So join us as we celebrate the unity and diversity of our cultural heritage through these timeless art forms.
हवामहे कविं कवीनामुपमश्रवस्तमं ज्येष्ठराजं ब्रह्मणस्पद आनशृण्वन्नोतिभिः सीदसादनम् ॐ गणानान्त्वा गणपतिगुं हवामहे कविं कवीनामुपमश्रवस्तमं ज्येष्ठराजं ब्रह्मणस्पद आनशृण्वन्नोतिभिः सीदसादनम् गणानान्त्वा गणपतिगुं हवामहे कविं कवीनामुपमश्रवस्तमं ज्येष्ठराजं ब्रह्मणस्पद आनशृण्वन्नोतिभिः सीदसादनम्
गजाननयुतम् गजाननयुतं गणेश्वरं गजाननयुतं गणेश्वरं श्री गजाननयुतं गणेश्वरं भजामि सततं सूर्येश्वरौ गजाननयुतं गणेश्वरं अजेन्द्र पूजितं विघ्नेश्वरम् अजेन्द्र पूजितं विघ्नेश्वरम् अजेन्द्र पूजितं विघ्नेश्वरम् अनादिसन्नुत पदपद्मकरं कुञ्जरभञ्जन चतुरधरकरं कुञ्जरभञ्जन चतुरधरकरं गुरुवाग्निजो प्रणव Vega Mavada Nitsa, Karitsa, Nita, Karitsa, Nita, Karida, Nida, 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 Basanida, Baba, Kamavada, Mavada, Nida, Badanida, Karida, Nida, 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 Bagamavada, Nida, Nida, Mavada Nitsa, Vega Mavada Nitsa, Karitsa, Nita, Karitsa, Nita, Karida, Nida, 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 Basanida, Baba, Kamavada, Mavada, Nida, Badanida, Karida, Nida, 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 Bagamavada, Nida, Nida, Mavada Nitsa, Vega Mavada Nitsa, Karitsa, Nita, Karitsa, Nita, Karida, Nida, 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 Basanida, Baba, Kamavada, Mavada, Nida, Badanida, Karida, Nida, 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 Bagamavada, Nida. समोत्सुकं विकीर्णविस्तीर्णकलापशोभितं ससम्भ्रमालिङ्गन चुम्बनाकुलं ससम्भ्रमालिङ्गन चुम्बनाकुलं प्रवृत्तनृत्यं कुलमध्यबर्हिणाम्
dani dim tadare dani dim tanadere na dim tadare dani dim tadare dani dim tanadere na.
Don't you want me like I want you, baby? Don't you need me like I need you now? See tomorrow, but tonight go crazy. All you gotta do is just meet me at the
Don't you want me like I want you, baby? Don't you need me like I need you now? Sleep tomorrow, but tonight go crazy. All you gotta do is just meet me at the
just meet me at the
just meet me at the just meet me at the
Can we hear it for that fabulous performance once again, ladies and gentlemen? Absolutely spectacular. And now it's time to add a touch of magic to the evening, literally. Prepare to be amazed and thoroughly entertained by one of India's most celebrated illusionists, SAC Vasant. He has performed on leading channels and has captivated live audiences across India and abroad. He's worked with legends like MS Dhoni, Gary Kasparov, A.R. Rahman, and more, bringing his mind-bending magic to the stars. Get ready for an experience that will leave you wondering, how on earth did he do that?
மேஜிக்னா என் கார்ட்ஸ் வச்சு பண்ணுவாங்க ஏதோ ரிப்பன் எடுக்கிறது பட் அந்த மாதிரி மேஜிக்கில் இட்ஸ் சம்திங் பியாண்ட் அது என்னால் சொல்ல முடியாது நீங்கள் பார்க்கும்போது தான் அவங்க ஒன்றுங்க
Vasant, I think, is the best what we have in that day.
Vasant was like really good.
Vasant international standard இந்தியாவில் இருக்கிற ஒரு பிரமாதமான ஒரு மெஜிஷியன்.
Number one magician in the world ever come across.
Presenting Master Magician Vasant.
Come on, you can clap. I know you're all here. Are you all ready? That gives me more energy. Yes. Yeah, I want some light on the audience.
you ready? All right. With me, I have a queen, a king, and a king. I have 2 kings and 1 queen. All of you, keep your eye on the queen. Here we go. So where is the queen? Anyone? This side? No. Which one? This one. One more time. I have 2 kings and my queen. I mean, the queen. Here we go. Watch it. I'll do it slowly, right? The king. I have 1 more king. And the queen. Keep the eye on the queen. Thank you. Hope you all enjoyed the show in the beginning. I know I can understand the time schedule, but thank you. I'll have 20 to 30 minutes of my time. I'll try to entertain you as the best as possible. So good evening, ladies and gentlemen. My name is S.A.C. Vasant. I am a mental illusionist. That doesn't mean I am mental doing illusion. Mental illusionism is something related with your subconscious state of mind. And I was telling, sir, in my job, I'm blessed to say that people book me to cheat you for your entertainmental pleasure, and only then they pay me my money. So I have to cheat you well for your happiness, to put a smile on your face. Give a big round of applause for them. Thank you so much, ladies and gentlemen. People generally have a lot of questions in mind, like what is magic all about? Some people say it is a supernatural power. Some people say it is a dexterity of hands. Some people say it's 400 bees. But in my language, in my definition, magic is an area where it is called to be an unexplored science. When you don't know the science, one day, many years back, Wright brothers invented the aeroplane. When it took flight for the first time, it was magical. But now it's very common. So that's what magic is all about. The more you know, it becomes non-magical. Today, I'm going to play with your subconscious state of mind. And every term, every terminology, what I'm presenting here, it's called a series of experiments. They're all Google-friendly, and it is all science. Now, let me show you that, let me demonstrate to you what is magic all about. How many of you are interested to know what is magic? Raise your hands. Great, fantastic. Now, I'll demonstrate to you about what is magic all about. All of you put your hands up high in the air. Like so. Keep your fingers like that. Like this, like this. Yeah, like saying super. Say super. Thank you. I go to my next trick. No, put your hands like that. Put your hands like that. Just kidding. Now listen to me very carefully. Just do what I say. Just do what I say. Are you all ready? Bring your hands slowly towards your face. I'll explain to you what is magic. Bring your hands slowly towards your face. Just do what I say. Slowly towards your face. And hit it right on your cheeks like that. Yes, do not move your hands. Ladies and gentlemen, this part of the face is called chin. Cheeks are here. Give a big round of applause. So that's what is magic all about, the small art of misdirection and playing with your subconscious state of mind. Now, okay, let us try one more time. All of you put your hands like this, put your hands like this. Like wave it, wiggle, wiggle, wiggle. Like this. Oh, for me from here it looks like hallelujah. Right, comes like that. Cross your fingers, cross your hands like that. Hold it tight, hold it tight, hold it tight. Hold it really tight. Sir, you can try it really tight. Tight, yeah, perfect. Hold it really tight, right? Wiggle your thumb, wiggle your thumb, wiggle your thumb, and slowly bring your thumb up. I know, if you can't, you can clap. So that's in a nutshell about what is magic all about. For my first act, I need a volunteer from the audience. For that, I would like to toss this ball. I'd like to toss the ball. Can I have some music in a low volume, please? I'll toss the ball. It's just a plastic ball. It's not going to create any injury. So the music will be played. So I'll toss the ball. Whoever catches the ball, preferably ladies. I want a lady on stage. Can I toss? Ma'am, I started from you. I'll toss it to you. You toss it back. You toss it back. Yeah, you toss it. Okay. Go. Good catch. Toss. Yes. Okay, you. Ma'am, please come. Thank you for the music. Please come. Give her a big round of applause, ladies and gentlemen. You need a lot of courage to be on stage. Thank you for volunteering. Please come. I know, this is the way of volunteering. Right. Hello, check. Ma'am, please introduce yourself on the mic.
My name is Rachel Alexander.
Yes, that's it. That's what I want. So nice to meet you, ma'am. Are you married? Yes. Oh, thank you. Nice to see you, sister. Sister. Now, has anyone hypnotized you before? No. You can speak in the mic.
No.
No. You're married, right?
Yes.
Even he didn't try to?
No.
Okay. No, I'm just kidding. Okay, today, don't worry, do not panic. Sorry? It is always true with the other side, sir. Right. Now, for the first time, don't worry, okay, do not panic. For the very first time, I'm going to try an attempt to hypnotize you. This is my first time too, so don't worry. All right? Now, very simple. When I snap my finger for the first time, I want you to look into my eyes. When second time I snap my finger, I want you to close your eyes. And third time when I snap my finger with your eyes closed, I want you to bow your head down. Can you do that for me? Yeah, please hold the ball tight, all right? Right. 1. Ma'am, நான் உங்களை hypnotize பண்ண try பண்றேன். I'm trying to hypnotize you. 1 ன்னு ஒண்ணு அவங்க இப்படி சிரிச்சிங்கன்னா என்ன ஆகிறது? கொஞ்சம் சீரியஸா இருங்க. All right. 1, 2, close your eyes. And 3. Bow your head down and relax yourself. You're in a deep trance. Now, ladies and gentlemen, after a long research in magic, I found out that this is the only way to keep the ladies quiet. But open your eyes, open your eyes. Anyway, now, by doing that, by touching your head, I have connected with you in a way of called a biomagnetic energy. Right. Now, you are randomly selected and you pick the ball. Am I correct? Yeah. So there was no any setup between us, right? All right. During COVID, I developed a habit of pictographic memory. Pictographic memory is again a Google-friendly term where you don't need to by heart, word by word, sentence by sentence or anything. But by seeing the pages multiple number of times, you get to store the pictures in your head. And then if you focus on the lines, then you get to memorize the lines. So I did memorize these 3 books with me. Right. One is called, can speak.
A Christmas Carol.
The Christmas Carol.
The Time Machine.
The Time Machine.
At the Mountains of Madness.
Exactly. Ma'am, out of these 3 books, I want you to touch any 2.
Any 2.
Any 2. All right. Good? Sure? Okay, you want these 2? Okay, out of these 2, touch any 1. Okay, great, fantastic. Now, very simple, ma'am. In this whole book, how many pages are there?
202.
202 pages. Now, out of this 202 pages, I have memorized the pages of the book in a certain pattern. It's a pattern, it's a technique. It's a technique. Now, I'm going to dribble through the book like that. I want you to say stop at any point you want. So there are so many pages and so many, I want you to say stop at any point, all right?
Stop.
Are you sure?
Yeah.
Right. Now pick a page, this side or this side?
This side.
This side, right. Now go to the last and see the page number. Don't tell me. Don't tell me anything from now. Just memorize the page number and go to the last sentence and memorize the last word. Don't tell me. Memorize the last word. Are you done? Right. On this side of the page, on the page number, on the last. Right. Fantastic, fantastic. Now, all I'm going to do is, I have some papers with me, paper balls. I'm going to toss it to the audience. I'm just going to toss it to the, all you need to do is just catch the paper and stand. Over here, good